Check. Hello. Suppose இதுல இருந்து ஆடியோ போடணும்னா ரைட். ம். Check. Check. Hello. இங்க பச்சை கலர் போட்டுருக்கு அந்த ப்ளூ. Check. ம். Check. Hello. Check. Hello. name என்ன? ஐஏஎஸ்சி மீந்திரவில் இருந்ததுல
இல்லை வெளியே மட்டும் நான் சொல்லிடுறேன். சரிங்க சார். அப்புறம் சேர்பர்சன் கூப்பிட்டு நான் ஃபஸ்ட்டு செகண்ட் மட்டும் நான் சொல்லிடுறேன். ஓகே சரிங்க சார். சரிங்க சார். டாக்ஸ் எல்லாம் வந்துருச்சு. எஸ் சார். நிறைய லேப்டாப் தான் சார். 2-3 அதுதான் பார்த்தாச்சு சார். கேஎன்எஸ் சார் கேபிஎஸ் சார் நம்முடைய பென்ட்ரைவில் பண்ணிடுறோம். அந்த அவருக்கு மட்டும் அதுலேருந்து பண்ணிடுவோம் சார். வருது கொஞ்சம் லோட் ஆகுது சார். சரி ஓகே. சரி பேக்கப் பண்ணி வச்சுக்குவோம். இங்கே ஓப்பன் பண்ணி வச்சுக்குவோம். இதோட டக்குன்னு மாற்றிக்குவோம். இந்த ஸ்லைடு இது போடுறோம் இல்லைல்ல சேர்பர்சன் இது போடுறோம். ஓகே இது பண்ணிடுங்க மைக்கு. Good morning, respected faculty, delegates, and one and all. So, I thank Sundarajan sir, Tapasvi sir for giving opportunity for Preeti Hospital to host this Indian Arthroscopy Society Outreach CME on arthroscopy. And we thank for selecting Madurai and Preeti Hospital sir and giving us opportunity to do this event here. So I welcome all the delegates who have come from various parts of southern India, and also we are going this live. So there is a registration from Pakistan, Maldives for the online this thing, sir. So definitely we have a broader reach through online for this event. So we will start sharp on time. So without spending more time, I'll do live repair. So first the hospital department and
Arthroscopic by Preeti Hospital. I thank the organizers of Preeti Hospital giving me this opportunity to chair this session and start the ball rolling on. And I also thank Indian Arthroscopic Society for choosing Madurai as the venue. And to start off, this is a very interesting and a very important session of ACL and meniscus injuries, which has become very common. I'll start off by calling up Dr. Joseph Prasad from GemCare Hospital, Kannur, to give a talk on classification of meniscal states and how to identify them arthroscopically. Dr. Joseph Prasad.
Very good morning, one and all, respected seniors and my dear friends. I am here to talk about a classification of meniscal tears and how to identify them arthroscopically. And I'll be just running through basics of meniscal anatomy and how to see it arthroscopically. Basically, we know the meniscal tears are the most common soft tissue injuries of the knee joint. The traumatic meniscal tears are most commonly occurring in young active people during the twisting sports such as football and basketball. Degenerative tears commonly occur in patients with osteoarthritis, although the exact incidence and prevalence are not known. So the anatomy, there are two fibrocartilaginous crescents, as you know, the menisci which are seen, which has two ends, two borders and two surfaces. The medial meniscus is a C-shaped structure forming 3/5 of the ring. The anterior horn is attached to the tibia, anterior to the intercondylar eminence of the anterior cruciate ligament. The posterior horn is attached immediately in front of the attachment of the posterior cruciate ligament, posterior to the intercondylar eminence. You can see the attachments. And this is the medial meniscus. The peripheral border is attached to the medial capsule and through the coronary ligament to the upper border of the tibia. So the medial meniscus is more attached to the surrounding structures rather than the lateral meniscus, which is more free. Most of the weight is borne on the posterior portion of the meniscus. And in the lateral meniscus, the most important thing is that it is a circular. It is forming the 4/5 of the ring with the symmetrical anterior and posterior horn. Mostly, it converts convex to convex area. That is from the femoral and the tibial surface, both are convex. So if the lateral meniscus is torn, it is very important to repair it, because if you take it off, it will create a very huge stress riser in the lateral aspect, because it is covering 4/5 of the surface, and it is also converting convex and convex areas into a more congruent areas. The anterior horn is attached to the tibia in front of the intercondylar eminence, and the posterior horn is attached to the posterior aspect of the intercondylar eminence in front of the posterior attachment of the medial meniscus. See that the lateral meniscus, you can see in the posterior horn, it receives anchorage to the femur through the ligament of Risberg. That is pointer. Here you can see that the posterior horn of the lateral meniscus, it is attached. This is a posterior meniscofemoral ligament. That is the ligament of Risberg, and anteriorly there is a anterior meniscofemoral ligament. Anterior meniscofemoral ligament and posterior meniscofemoral ligament both are attached to the posterior aspect of the lateral meniscus, and it goes along with the PCL and attaches to the medial aspect of the femoral condyle. The tendon of the popliteus separates the posterolateral periphery of the lateral meniscus from the joint capsule and fibular collateral ligament. The blood supply, as you know, the menisci of the knee develop at 8 weeks of gestation as a collection of fibroblasts. At birth, the menisci are vascularized through their substance. With aging through early childhood, there is eventual peripheralization of the vascularity. That is, initially only the entire thing is vascular, but later on only the outer portion is vascular. So here you can see the peripheral blood supply, that the perimeniscal plexus is there. It comes from the inferior genicular artery, and it gives synovial and capsular tissue periphery, supply the peripheral border of the meniscus. So depth of the vascular penetration is 10% to 30% of the width of the medial meniscus, and it's 0 to 25% in that of lateral meniscus. So here you can see the red zone, red-white zone, and white zone. The periphery, it is totally vascular. In the middle, there is a red-white zone and the white zone. So there are several classifications of meniscus. Mainly, it is an O'Connor classification, which classifies the meniscal tears into a longitudinal tear, a horizontal tear, oblique radial tear, and many other variations. So a longitudinal tear, as you can see, there are 4 basic patterns. There is type 1, it is a longitudinal tear. It divides the meniscus into an inner and outer portions. See that there is a meniscus is torn longitudinally. In a horizontal portion, it divides into a superior and inferior one. Then the oblique one is the this one, it is oblique tear over there, and a radial tear. A radial tear, if it extends peripherally, it is akin to nearly a total meniscectomy type of tear. And this is a longitudinal tear. You can see that we are pulling it to the probe, and the longitudinal tear is visible here. This one is a horizontal tear, in which you can see an upper flap, which is the femoral aspect, and lower one in the tibial aspect. So there is a horizontal tear associated with meniscal cyst, as the fluid can seep out and cause meniscal cyst. So radial tear, you can see that it's a complete radial tear. If it goes to the periphery, it divides the meniscus entirely and it will cause a loss of the hoop stresses and it will account to a near total meniscectomy. It will just be like a meniscectomy because there is a complete radial tear. It has gone to the periphery. And this is a flap tear or other degenerative type of tears in which a flap of the meniscus is torn. In complex tear, it accounts to almost all the tears together. That is, it's a complex type of meniscal tear. And this is a degenerative tear. You can see the degenerated meniscal tissue there, and it's completely degenerated and it is torn out. So another one is a ramp lesion. The ramp lesion were less identified earlier, but now we should look for the ramp lesion, then only we will find it out, because nearly 18% of ACL injuries are associated with the ramp lesion. So it's a type 1, is a meniscocapsular tear. You can see that it is a ramp is the area in which the meniscus and the capsule attaches to each other. It's a sliding area, that's a ramp. So at this portion you can see the tear. So this is a type 1 tear, type A, B, C, D, you can classify it. The type 1 tear is a meniscocapsular ligament region tear. Second one is, here you can see the meniscotibial ligament. The classification is in a type 1 is a meniscocapsular tear. The type 2 is a partial superior tear, that is only the partial portion or the superior aspect is torn. Type 3 is a partial inferior tear, that is in the inferior aspect it is torn. And type 4 is a complete tear. And type 5 you get a double tear. So this is a partial superior one, this is a partial inferior one, and this is a type 4, that is a double tear, that is two types of tears are seen there. And another one is a meniscal root tear, that is meniscal root is defined as an area which is nearly 1 centimeter to the root of the meniscus attached to the posterior aspect of the bone. Here you can see a type 1 is a partial root tear. Type 2 is a complete root tear, that is a radial one. The radial tear extending just beyond, just at the region of 1 centimeter at the root is called a root tear. So type 3 is a complete root tear with a bucket handle tear. In type 4 you can get an oblique tear, and type 5 is a root avulsion fracture. So arthroscopically, what you can see, just I have taken a small video. In this video you can see that you should look for tear, then only you can find many of the tears. So just a diagnostic arthroscopy with probing will be very efficient. So it's a lateral meniscus you are seeing there. You are pulling the popliteus tendon over there. The mobility you are checking it. And the medial meniscus, as I earlier told, we go for the posterior aspect of the lateral meniscus. All the medial meniscus and lateral meniscus, you are pulling it. And again, this is a looking for the ramp lesion. So that is very important. You should look for the ramp lesion, otherwise you will never find it. You go through the posterior medial portal, putting the probe there, and you are elevating the meniscocapsular region there. You can see that you are seen through the posterior medial portal. This is the view through the posterior medial portal. See that you are going between and going behind the knee, and you are putting a probe there, and you are elevating the region of the ramp. You are looking for the ramp lesion, then only you can see it, because it will be hidden there. And in this you are probing through the posterior, probe is coming through the posterior medial portal, and you are trying to elevate that region. And here you can see the ramp lesion clearly. Here you can just pulling it through the medial meniscus posterior horn, and there is a gap there. That is a ramp lesion you are seeing there. With the probe you are pulling it. In this you are not using the posterior medial portal, you are just coming from there. And these are the type of meniscal tears. It's a horizontal type of tear seen in the medial, in the lateral meniscus there. This one is a root tear. The root is avulsed from the medial meniscus. You can see the root, it is avulsed from there. And you are trying to fix it by drilling there, and this root is totally avulsed and it is floating, floating there. And this is another one, it's a bucket handle tear. The entire tear is gone and it is in the intercondylar notch. You are freshening it up and trying to fix it. So this is a bucket handle tear. And this is a complex type of tear in which there is a horizontal component and also a flap component. This is another horizontal tear which we are probing, and then only we will see the undersurface of it. So this is how we put a posterior medial portal. It is just described. You are going in between the PCL and the medial condyle, and this triangle region you are going. Your scope is going inside. you are seeing the transillumination in the medial region, and you're putting a needle there, and you're putting a portal there. So this is how you assess the posteromedial portal and to assess the ramp lesion there. So it's a short video. So this you reach the posteromedial region, and from there you can put a posteromedial portal and see the further ramp lesion. So you put a knife there, and the instrument is going in. So this is a posteromedial portal placement. Okay. So this was just a short video about that. So thank you for the patient listening. Thank you.
Thank you, Dr. Jyoti Prasad. Now I call upon Dr. Sundarajan to give a talk about overview of various methods of meniscal repair. When and how to do it. I welcome Dr. Sundarajan to give a talk on overview of various meniscal repair techniques.
Good morning, everyone. So my topic is about meniscus repair techniques. So I will show some 3 or 4 cases where how to do the repair techniques in indications. So how to get a successful repair depends upon how you choose the patients. The right indication is the most important thing by choosing the meniscus repair. Of course, you should have the armamentarium of implants and instruments, because sometimes MRI, you cannot predict how much suturing you require, how much implants you require may not be evident by seeing the MRI. So you should have all the armamentarium in your theater, and you should explain to the patient also the cost-wise it will going to make a difference, because we cannot say a fixed price for a meniscus repair technique. And also the techniques, which is very, very important. You should learn all the techniques before you start your ACL practice, because ACL surgery is not just ACL surgery. You have to address the cartilage and meniscus. So when you see a meniscus which has to be repaired, then you should do a repair. So it is important that you learn all the techniques before you start doing the arthroscopic ACL reconstruction, not the meniscus. So not all the tests are symptomatic. That is also very, very important, because you know all the techniques. You cannot institute all the techniques for all the meniscus repair. So the indications for the meniscal surgery is very, very important, because you can see asymptomatic tears in the MRI. So it doesn't mean that patients require any meniscectomy or a meniscus repair. So make sure that you correlate the clinical symptoms, history, then MRI. Then you choose that indications to do a meniscal surgery. When you do an acute tear, again, most often this meniscal tear are associated with other meniscal injuries, like other ligament injuries, like ACL or a PCL or a multi-ligament injuries. And you should assess the age of the patient, zone of the tear, where you know that you have to repair in a red zone or a red to white zone. At the same time, when you see a complete tear, then you should be able to repair even whether it's in spite of any zone. That is also very, very important. When it comes to the type of tears, I will show in the cases. In chronic situations, the most common situation which you come across is the bucket handle tear. So the most important assess in a chronic acute situation up to, of course, you repair in a white red zone and a red white zone. In a chronic situations, if you see a bucket handle tear in the same zone, it is important to assess the quality of the meniscus. Reducibility of the meniscus will decide whether they require a meniscus repair or a meniscectomy. If you are able to reduce it well, the meniscus go and sits very well in that place, that means you have to repair that meniscus. So of course, the root tear and horizontal tears comes in the chronic situations, radial tears. These are all the chronic tears requires a repair. I think Dr. Palnivelrajan is going to show the indications. When you want to do a meniscus repair, the most important technique to learn is the pike resting. So this is very, very useful technique to not only just to do a root tear, any bucket handle tear. If you are struggling, do a pike resting, make the middle opening little bit more, 3 to 5 mm more, so that you don't damage your cartilage. So that under yours technically it is very, very easy. You can see how the space is opened up when you do a pike resting with the 16 gauge needle from the outside. You can do it in both tibial side and femoral side. So this is the case of 7 years duration of pain and instability. This patient had a Lachman's and anterior drawer positive. He has got a pain in the medial side too. So when you go inside, there's a peripheral tear of the medial meniscus. That's what I said. That even there's an old ACL tear, patients can have a recent meniscal injury. So it is important that you expect this kind of injuries and go inside, because you cannot tell the patient that there is a meniscal tear because 7 years I do a meniscectomy. You can see this is almost in the meniscocapsular junction. So in this case, we cannot do a meniscectomy. That means you are going to do almost a subtotal meniscectomy. That is very harmful. So in these cases, so you have to do a repair. So you can start with the inside out stitches. It is very important armamentarium for your any meniscus repair. You do a first one mattress stitch, then you can do one a vertical stitch that is next to that. So you can alternate that mattress and the vertical stitch is very, very important. So this is the vertical stitch which you make one in the meniscus, one in the capsule. So these alternate stitches adds the more stability to your meniscus repair. And okay, I'm not able to do the. Okay, so this is the so once you finish the superior surface, then you come to the inferior surface. That is also very, very important, because we cannot just plan your suturing on the superior surface. Once you do a superior surface, you can see that the meniscus is flipped off. So you should make then suturing on the inferior surface too, both the vertical and the mattress stitches, so that at the end of the both superior and inferior surface, your meniscus gets stabilized in this position. So that is the inferior surface suturing. So this is again the inside out technique. You can see that once you put the inferior surface, it gets balanced. Then finally, once you do that posterior horn, in the middle horn, then you go to the posterior horn. Here you use the all inside technique, which is commercially available with all the companies. So here you are using the fast fix. That is then because here I didn't do a pike resting. If you feel that very tight space over there, do a pike resting, open up bit so that you are passing the instrumentation easy. Otherwise, you will spoil the instrument, which is around 20,000 rupees one implant. So it is important to do the pike resting. So this is how this all inside repair works, where the two implants go back of your meniscus and flips over there. That holds that meniscus. Then you pull that threads, then that tighten up, that knots gets tightened up and gets the stable meniscus. So in this case, you can see you can use the mattress and vertical. You can use oblique also, oblique tears that adds the stability to the repair. You should use both superior and inferior repair, and most of the time you require an all inside when it is extended to the posterior horn. So suspect new meniscal injury even in the old ACL. So this is another case, 29-year-old male patients, pain and giving way for 3 months duration. That is the X-ray, that is the MRI. You can see that is the Buchanan tear. That is the double PCL sign, which is the evidence of Buchanan tear. You can see this case, this posterior whole Buchanan tear was flipped inside the joint that was adherent to the ACL. So in this case, you separate that ACL adhesions between the adhesions and the meniscus. The cursor doesn't work. Cursor doesn't work. Okay. So you can see this, you prepare the meniscus. That is very, very important. You use your soft shaver, or you could use the meniscus ramp to prepare that meniscocapsular junction. Sometimes you can have the small comminuted fragments where you can take off before you move on to the repair. Then you reduce it, then you stabilize the meniscus by using the inside out technique. That is most important. You can see the reducibility of the meniscus. It doesn't look like very great, but it's only a 3 months duration. But it is almost a red-white zone or red-red zone. So here we cannot do the subtotal meniscectomy. So you can see that after preparing, putting the meniscus inside, then you do the inside out. That is the easy way of stabilizing the meniscus. So once you do the reduction, then you do the inside out technique with 1 or 2 stitches like this. So that will give you good stability of the meniscus. Then you keep on adding your vertical and mattress stitches like this. So you may require at least you require a 5 mm gap. We can use a 5 mm gap between each repair technique suturing. So you cannot give a long gap also, because you need a both stability for a bucket handle tear. So you may require to do a 6 or 7, 4 or 5 on the superior surface and 4 or 5 on the inferior surface. That's how you stabilize the meniscus. So then you take out the stitches. You don't need to do a posteromedial safety incision. Of course, you can do a posteromedial safety incision if you want to avoid a nerve injury. But if you are very careful, then you can see that most of the stitches are coming out not in the posteromedial surface if you are take care of your positioning when you take it out. So that is, then you add an outside in technique for your anterior horn. So that is how you posterior horn of the, you see that once you finish the middle horn and the anterior horn, then you see still the posterior horn is unstable. So that has to be added with both the superior surface all inside technique and the inferior surface. You can see that one fast fix going on the superior surface, one goes on the inferior surface. At the end of the procedure, then you do the, you see the stability, then you do the ACL reconstruction. You can add a microfracture or a PRP or a bone marrow aspiration, which I don't do, but when you have an isolated meniscus bucket handle tear, you can do that. That was the final repair. You can check it in the both flexion and extension, that found to be very stable. So this case, on next two cases, I go quickly. This is a 37-year-old patient. You can see the complete radial tear, which you see in this kind of ACL tear with the radial tear, which is one of the common scenario. Whenever you see an ACL tear, the most common scenario is the posterior horn, the lateral meniscal tear. So when you see a tear like this, you think that we cannot do the repair because it's completely torn and separated. But you can do the repair of this meniscus. You can do you can see that I'm being through the anteromedial portal, working through the anterolateral portal. So this kind of these instrumentations, which you do it for a shoulder, we have for the knee also. You can use the side-to-side stitch. So that helps you to approximate this both the fragment and get along with each other. Then you change the scope to the anterolateral side, then work through the anteromedial portal. So I am taking another bite through the middle horn. So the first bite was taken through the posterior horn. Then you take the side-to-side stitch. Then you approximate the meniscus. So that is how it looks. You can see the securing with your sliding knots, which you use for the shoulder. So that is approximate the meniscus. The lateral meniscus, posterior horn, has got a good healing potential. So you don't need to worry about the healing issue. So again, that was added with an all inside stitch. Then again, you add in a second side-to-side stitch. So that adds a stability to the repair. So one repair may not be sufficient, one stitch may not be sufficient. So use 2 or 3 side-to-side stitches. And at the end of the day, you see that is the final repair. The remaining inner edge can be trimmed off. Just you can use like a partial meniscectomy, just to trim out that inner third. And that is how it looks at the end of the procedure. Then you trim off that inner third meniscus, then that get a stability. So sometimes you get a patient of 38-year-old female patient, 6 months duration. This patient has got no locking instability, only pain. But you see the MRI, there is a complex tear of the meniscus. So this we plan for a meniscectomy. You can see this is a complex tear which was flipped between the femoral condyle and the tibial side. That is the flap which gives the problem whenever they put load and twist. So once you see this kind of fragment, this patient definitely required a pike resting. You can see that after a pike resting, you can see there's some opening over there. Then you do the partial meniscectomy. So in this case, you see that flipped fragment was done the partial meniscectomy. Once you done that, you see there is the big horizontal tear of the meniscus, which you may not expect many times. So this case we plan for a meniscectomy, but when you see in young patients with big horizontal tear with unstable meniscus, we tend to do a excision of the one flap before. But in young patients with a good healthy meniscus, but sometimes you can do a repair. You can do the same instrument which I used for that radial tear can be used for these horizontal tears. You add a multiple stitches for the both superior and inferior flaps like this, and the end of the 4 or 5 stitches will add a stability. But also you may add on an inside all inside technique stitches that gives the stability of the posterior horn of the meniscus to your capsular. Because this kind of horizontal tear with the complex tear will have an instability. But at the end of the procedure, you can see this is how you head. So instead of excising the meniscus, you can have a complete stable meniscus. You do the repair of that horizontal meniscus. It doesn't mean that you should do, it's a controversy, you don't repair all the degenerative tear. But when you have a young patients with a good cartilage, with the cyst with the horizontal tear, can be repaired too. Okay, to conclude, the meniscal repairs is a deep learning curve. Of course, it's an expensive, a patient has to be counseled for these kind of procedures, but saving the meniscus and knee is also very important at the same time. So you have to balance between these two. Thank you very much.
Thank you, Dr. Sundar.
So with the help of a chair, sir, I invite all of you for the IASCon 2022 to the Coimbatore, September 15 to 17. The early bird registration is extended up to 30th of the April. This hotel is a Lee Median. We have a lot of international faculties, more than 25 live surgeries, and we have a master class program for especially for the beginners separately, apart from the main conference. And abstracts are open, so the May 31st is the last date for submit your paper for abstract. We have 4 awards for that. We have a 2 days cadaveric lab in Singapore, and also we have a best paper can go for a 1 week Europe fellowship. Thank you very much.
Thank you for your invitation, Sundar.
If anybody wants to do a registration, you can meet me. We have the forms also. Offline registration. Thank you, sir.
Thank you again for the invitation and on your nice talk on how to do the various modalities of meniscal repair. And I want to insist the point that after an MRI, you see asymptomatic tear, you should not jump and do surgery, and better you be careful about it. So youngsters should not be the patients are more aware, they are more about the things. So asymptomatic tear, be careful and go ahead with the surgery, only if it is symptomatic. Next I call upon Dr. Palnivel Rajan on the management of the root tears and ramp tears. How we do it? Over to Palnivel Rajan. He's an arthroscopic surgeon from Madurai, alumni of Madurai Medical College.
Good morning, friends, respected chairpersons, and all the faculties. First of all, my compliment to Preeti Hospitals and the team for organizing this wonderful conference, and the Indian Arthroscopic Society for allotting this program to Madurai. My talk will be on meniscal root tear and ramp lesions. These are the two interesting meniscal tears that has evolved in the last decade. Before that, we were not very much aware of the root tears and the ramp tears and their implications on the degeneration of the knee as well as the stability of the knee. So the root tears, each meniscus is rooted down into the tibial plateau at the two ends. So any radial tear that happens within 1 centimeter of the meniscal insertion or avulsions at the insertion site are called meniscal root tears, and failure of the meniscus to convert the axial loads into transverse hoop stresses is the main defect. So that causes degeneration as well as instability. So as been already described by the previous speakers about the attachment of the meniscus, both anterior and posterior roots. So extrusion of the medial meniscus has been observed in both partial and total meniscal root tears, and with the extrusion being more than 3 millimeter is being associated with high cartilage degeneration and osteophyte formation. So a lot of importance is given now for the root tears. So there's also change in the loading pattern, and so early degeneration has been seen as similar to that one you see in a total meniscectomy. So you need to give some importance to the meniscal root tears. There are two types, like acute tears, which occurs in a trauma, usually young athletes, and more often a lateral meniscus is more involved. And in chronic tears, which is mostly associated with the degenerative changes in the knee, and that needs to be taken into account. So the most important thing is the imaging technique. You have to see the presence of any degeneration, whether it is a pan-arthritis or the arthritis involves only in the medial condyle or medial surface, medial joint. As well as the malalignment is very important because root tears are very often seen in patients with varus deformities, and so that needs to be considered, and any bony avulsions should also be noted. The gold standard is MRI, so it's very sensitive as well as it is very specific. You can see, I'll just show you the different views of how you diagnose this root tear. So you see a linear high intensity signal intensity perpendicular to the meniscus at the meniscal root lesion. And you have a pointer. This is very important. In the axial, so in the axial C, you can see the linear high intensity perpendicular. It's perpendicular to the meniscus, so that is very important. As well as you see a vertical linear defect on the meniscal root. It's called the truncation sign, which is associated with meniscal extrusion. And also in the sagittal plane, you see a ghost sign where there is an absence of the meniscus, and that also needs to be taken into account when you study the MRI. So usually it is a benign twisting motion, more often a subtle pop and joint effusions in case of acute injuries. Whereas in case of the degenerative tear, which is very common with medial meniscus root, the patient often complains of just getting down the stairs or getting down from a vehicle, gets a pop sound, and then the pain starts, aggravating over a period of time. So that is the common. I think this has already been discussed. So it's the type of root tears, which type 1 is a partial root tear, and the type 2 is complete root tear. Type 3 is along with the bucket handle tear, you have a root tear, and type 4 is an oblique. And the other issues that you commonly see in the medial root tear is the extrusion of the meniscus, which may precede the degeneration of the joint rather than the result of that. And the spontaneous osteonecrosis is the result of both OA as well as the root tear, which often gives the symptoms like severe pain. So the treatment modalities are just to restore the joint contact pressures, joint kinematics, and you delay the development of OA. So non-operative and operative treatment both can be tried in case where patients are old, there is a lot of varus or varus alignment deformities, or there is a pan-arthritis. You can try a non-operative treatment for a short duration of time before going for a replacement and other things. But whereas in patients who have lesser arthritic changes, who has less alignment problems, and younger age group, it's always good that you attempt the repair the root. Again, lateral meniscus root tear, sometimes you don't need to do surgeries in acute cases if it is very stable or if the meniscofemoral ligament is intact. And again, severe OA changes, you don't need to do non-operative treatment. Lot of surgical options available. You can do a transosseous pull-out sutures, or you can use a suture anchor or a side-to-side tear. So this is a 50-year-old female patient who had a sudden pop sound when getting down the stairs, and then after a brief period of pain, the pain got aggravated, and she is not able to put her leg on the ground. And then MRI was taken. The MRI showed there is a tear in the posterior root of the medial meniscus. The joint surface are reasonable, and the alignment is not bad. So in these cases, you can attempt root repair. I'll just show you the video of how we do the meniscal repair. So once you identify the unstable root attachment of the medial meniscus posterior horn, the first thing you need to do is you just debride the edges because it's more degenerative. You have to create some biological induction, And then once you debride, sometimes you may need to mobilize the meniscus a little bit, otherwise you can't pull it too tight, it may fail. So once you are sure that you can bring the meniscus and get it attached to the posterior root, there are so many different ways of doing. You can either drill a tunnel and then you can take bite, or you can take bites and then you can drill a tunnel and bring it down. So I always take a couple of sutures, as Dr. Sundarajan told, using the specialized instruments. I take a cinch, one cinch and one simple suture. And you can mix and match a different kind of suturing in repairing the root. So you have to take a thick tissue because it's a little degenerated. You have to be sure that you take a good chunk of the posterior horn. And after one cinch, I take one simple stitch, and then I use a jig. There's a special jig available for creating a root tunnel. And using the jig, you can drill a hole near the attachment site to bring the meniscus back and to prevent the extrusion. You have to choose a site where the meniscus is not too tight or not too loose to get extruded. So once you drill a tunnel, you have to be very careful that you don't pierce the posterior capsule. You have to give a protection. Once the K-wire is drilled or a drill bit is used, then I use a 4.5 reamer. The idea is to make a bigger hole so that it has a better bleeding and more biological healing potential. And once the tunnel is drilled, I take a lasso and bring both the sutures down. I think next video. Yes. Video enrichment. Yes. Okay. So both the sutures are brought down. Using a lasso, you just take both the sutures down, and once both the sutures are pulled, initially I used a simple stitch to use a sliding knot so that you get a very snugly fit. Nowadays I just pull one suture and tighten with a simple knot, not to slide the suture because it may damage the meniscus. Once this is done, the meniscus is, I use 2 fiber wire. A lot of people use one. It's up to you to decide which one you want. So this is a post-op picture. You have a small button on the medial side, and that gives the attachment site for the meniscus. This is another case, like sometimes you may have some adhesions attached to the torn root in a chronic case with some degenerative changes. You have to identify the stability of that, and if you find that the root is torn, this is a chronic case where once the root is detached, it got adherent to the posterior capsule and it's too tight to bring it back. So you have to release a little bit. Once you release, again the procedure is almost similar. You just try and find out where you can attach it in such a way that it functions physiologically. And then you again take the sutures. The most important thing is you have to take sutures so that it doesn't cut through the meniscal tissue. So once you take it in more, say inner part, there's every chance that the meniscal, it may cut through. So again, the similar procedure. For post-operatively, because I use 2 fiber wire, I mobilize the knee in the first week, but weight bearing I wait for up to 6 weeks. At least 4 weeks for full non-weight bearing, and then partial weight bearing, and end of 6 weeks we put them on full weight bearing and normal walking. Squatting as well as, so this is another different method of button fixation. Squatting we allow after 3 to 4 months. So meniscal root tears may be subtle and may be missed. So consequence of non-diagnosis are rapid onset of degenerative disease. So we have to consider the chance of repairing. And when a benign twisting medial thing is there, small pop or crack, if you get history from the patient, then you have to suspect the root tear. Again, ramp lesion, again it's a new concept in the last decade. It's always associated with an acute injury, very commonly seen in young patients. The posterior capsule and the meniscal attachment site is torn within 1 millimeter of the meniscus, and then we call it as a ramp lesion. So the hypothesis is that the contraction of semimembranosus, the capsular arm at its insertion along the posteromedial capsule, causes this sudden pressure, and this with the stress of the peripheral meniscus results in a meniscus capsular tear and instability. So always associated with 15 to 30% of ACL injury, and not every patient needs surgical intervention. If the tear is very small, like it's less than 1.5 or 15 mm, and then you can, if it is very stable, you can just debride and leave it. Otherwise, you have to repair. This is a classification like what the previous speakers have told, that it is the peripheral one is type 1, and one involving the superior surface is type 2. The one involves the inferior type 3. If it is a complete tear in the red zone within 1 millimeter of the meniscus, peripheral meniscus, then it's type 4. And then if it is a double tear, it's type 5. So it since meniscus, I think, supports the anti-translation, so we need to repair this. So small tears, you can just do a trephination, and you can do rasping, and the bigger tears you need to repair. Again, lot of techniques are evolving in repairing. I'll just show you how I repair. So always you see the trans-notch view, you can diagnose the presence of the tear. If you are not very sure that you can't see that, then you can use a posteromedial port, and then you can see the meniscal tear. Right? So you make a posteromedial portal, and then you view it through that. You can see here the tear. It's very difficult to find in little chronic cases, as the capsule is very lax. But if the meniscus is very lax and you couldn't find any meniscal tear, then you always suspect that it could be a ramp lesion. So for repairing, I always use posteromedial portals. I make 2 portals on the posteromedial side, one inferior posteromedial and one superior posteromedial portal. The inferior one I use for taking stitch, the superior one for suturing. So I pass a cannula on the superior posteromedial portal, and for the inferior posteromedial portal I don't use a cannula, because if you use a cannula, it is very difficult to manipulate and take as a bite. Most often I use lasso. We have to prepare this more with the rasp and less with shaver, because shaver might take away the capsular tissue. So you have to be very careful when you are using shaver. So once this is done, you use a lasso, and then you take a bite, thick bite through the capsule. And once you are sure that you can't take a single bite through both the tissues. So once you are sure that you are taken through the capsule, then take through the peripheral 1/3 of the meniscus. You should not go beyond that, not necessary. You can take 1 or 2 stitches. So just take a stitch and take it through the superior portal where you have a cannula, and then you can use different type of knotting, like either you can use a sliding knot or a simple knot, and then you can repair. If you find it very big, then you can use 2 sutures. For that. So once you find out the ramp lesion and then you repair that, you'll have a good clinical outcome, low reoperation rate or low re-injury rate of the meniscus, and the patient returns to sports in majority of the time. Thank you.
Thank you, Palanivel, for your exhaustive talk on management of root tears and ramp tears. Now I call upon Dr. Mukesh Ladda from Nagpur to give a talk on arthroscopic ACL reconstruction, step by step by hamstring tendon graft.
Good morning, everyone. I would like to thank Preeti Hospital and IIS for giving me this opportunity, and my good friend Dr. Parlat for asking me to come down here to the city of temple. Visited first time Madurai and saw the magnificent Meenakshi temple yesterday. Thanks a lot. So this is more of a practical talk, so please pardon me, there won't be any theoretical aspect in my talk, because its talk is stepwise reconstruction using hamstring tendon autograft. So I come from Nagpur, Maharashtra. So you can do ACL reconstruction in leg dangling position or in TKR position. I prefer to do it in leg dangling position. Do your surface marking, patella, tibial tuberosity, joint line, and then mark oblique incision just about a centimeter below and medial to the tibial tuberosity to harvest your Soceity graft. So always do evaluation under anesthesia to assess the pivot grade so that you can know whether you are dealing only with ACL or some root tears or ramp lesions, or you have to do some anterolateral reconstruction. Then you incise, palpate first, and the thing which is palpable is the gracialis. Take a longitudinal incision in the sartorial fascia, hook your Soceity out from below, and try to take about a centimeter or so of periosteum from the bone so that you can increase the length of the graft as well as it helps in healing. The important step is to cut the vanculas here. It's the attachment of the graft to the gastrocnemius. While doing so, see that the tip of the scissor is below and not towards the tendon, otherwise invariably you will cut the tendon. And try to hook the second vancula out. Don't pull the graft. If you keep pulling the graft and the vancula is attached, it reduces the thickness of the graft, and completely clear it with your finger and see you get that springiness. Hold it firmly and then use your tendon stripper to remove the graft. Clear all the muscle tissue. A small amount of muscle tissue may cause a vascular necrosis of it and tunnel dilatation. Then prepare your graft with a Chinese strap method, with holding it on a graft board or with it, and then measure the diameter. The diameter should be minimum 8 mm. If you feel the fold is not giving you 8 mm, add gracialis to it. Then mount it on the graft board, tension the graft, and cover it with vancomycin soak gauze piece. So tip to graft harvest, you can have oblique incision because it prevents injury to the nerve, superficial nerve, more cosmetic. The palpable one is a gracialis, so Soceity lies below that. Incise with periosteum. Identify the vanculas. Most important to differentiate it from gracialis and the Soceity. Cut the vanculas to prevent premature amputation of the graft while harvesting. Hold the graft firmly with ethibond when you are harvesting with a closed or open tendon stripper, because otherwise if it slips, it will suddenly pull inside and it will be difficult for you to get the graft outside. Pull and push the graft gently with the knee in 90 degree of flexion to harvest the graft. So once you prepare your graft, you can use either accessory anteromedial portal or a single anteromedial portal which is lower enough. So you make a horizontal medial portal because it's quite low. If you make a vertical, there are high chance you may do a radial meniscal tear. So if you make a horizontal, it will be an intra-substance injury. So once you do your portal making, see that's the Blumensted's line, or you may say the residence ridge, and this is the bifurcate ridge. So your tunnel should be posterior to the bifurcate ridge and below the residence ridge. So that's the area where your ACL femoral tunnel should come. I always use a femoral offset guide. If it's 9 mm, I use 6 mm offset guide which hooks on the posterior cortex, and then you drill with your bead pin from medial to the anterolateral cortex. This is the offset guide I always use, and then you drill with 4.5 mm drill bit to whole tunnel till the lateral cortex. And so while you are drilling, when you reach the lateral cortex, you can know the total length of the tunnel so that you can adjust your graft accordingly. And then you make a socket with the 8 or 9 mm drill bit, depending on the graft of the size you have. Minimum 15 mm graft should be there in the femoral tunnel. 15 to 20 mm you should drill. Once you finish the drilling with the graft, clear the mouth here on the femoral tunnel, because once you pass the graft, this soft tissue may tend to go in the graft and will hamper the healing at the mouth, because the healing takes place at the aperture of the tunnel, not in the tunnel. So when you pull the graft, this soft tissue tends to invert in the tunnel. So clear the mouth. And as I told you, the tunnel should be below the residence ridge and behind the, below the residence ridge and behind the bifurcate ridge. So this is the single circular tunnel ACL reconstruction femoral tunnel we do. So the tips here, you can make an accessory anteromedial portal or low anteromedial portal just above the medial meniscus and see that that portal is horizontal. Use offset guide. If you are comfortable without it, you can do that way also. I use offset guide. The knee flexion should be around 110 degree. Guide wire followed by reamer to break the lateral cortex. If you are using an adjustable loop, the socket length can be 15 to 20 mm. But if you are using a fixed loop, you need to make a socket 5 to 10 mm more for the turning radius of the implant. Visualize the portal through anteromedial portal. Visualize the tunnel through anteromedial portal always for self-learning to know whether you are little high or little low in the center. And as I told you, it should be below the residence ridge and behind the bifurcate ridge. For tibia, you can use either a tip aimer jig or an elbow aimer jig. I prefer to use tip aimer. If you are using a tip aimer jig, see that you are in the center of the footprint. If you are using an elbow aimer, see that you are just below the posterior border of anterior horn of lateral meniscus. Use that as a landmark. So angle of the jig should be around 45 to 50, and the bullet, mallet it on the anteromedial tibia so that it should not slip while you are drilling the guide wire. Otherwise, the guide wire may not come in center exactly. I prefer tip aimer so that my guide wire comes exactly in the center of the footprint. Hold it with a artery forceps and drill it with the respective diameter, tunnel diameter which you have. Clear bit amount of tissue anterior to the tunnel of the tibia to avoid cyclops formation and also to bring out all the bone debris. So the angle should be around 45 to 50 degree. Mallet the bullet on anteromedial tibia to avoid the slippage of the guide wire. The entry should be between patella tendon and anterior part of the MCL. Be careful while seeing so that you don't damage the anterior half of MCL. Tip aimer, because exactly in the center. If you are using elbow, just posterior. Identify the anterior horn of lateral meniscus as a landmark to make your tibial tunnel. Hold the guide wire. Try to preserve the remnant of ACL for proprioception and better healing. Once you have finished that, if you are using an adjustable loop, you can do a marking of the whole tunnel on the loop. As here in this case, it was around 30 mm whole tunnel. And then you mark here, because this is an adjustable loop, and then you mark the area of the graft you want to put in the femoral tunnel, usually 15 mm. But if you are using an adjustable loop, see that you drill up to 17 mm and keep 15 mm marking, because after fixation you need a millimeter or so to finally tighten the graft in the femoral tunnel. Now the time is to pass the graft from the tibia to the femur. You can ideally see the button flipping from the tunnel view from anteromedial portal, and slowly ask your assistant to pull the button out from the femoral socket. Slow and be very gentle, and you can actually see how the button gets flipped on the lateral cortex over there. And once you flip the button on the lateral cortex, pull it below from the tibia so that if any slackness is there, and that's your marking where exactly the tunnel ends, and then pull the graft. If you are using an adjustable loop, I'll just do adjustable loop. Different companies have different ways to pull it, so follow all the instructions. Mark the whole tunnel length on the loop and socket length on the graft. See the button flipping under vision. If it's a fixed loop, always do cycling after you toggle the button on the lateral cortex. There are chances that you may toggle the button on the IT band. So if you see the puckering of the skin on the lateral cortex while doing flexion extension, see that you are not on the cortex, you are on the IT band. Or if you suddenly feel that the length of the graft has gone too much inside and you are not able to see on the tibia, feel that you are not on the bone, so then you have to take a small incision laterally and try to pull that button on the lateral cortex. No graft tunnel mismatch should be there. Be careful, because if your graft is smaller than the tunnel, then there are high chance of tunnel dilatation and graft failure. So while fixing the tibia on the finally, now you have to fix the tibia in 20 to 30 degrees of flexion. You have to firmly pull the graft, your assistant giving a posterior drawer, and you are putting a screw or suture disc, whatever you prefer. I usually prefer to put a bio screw if I have a graft at the mouth of the tunnel, but if the graft is about, say, more than 5 to 7 millimeter in the tunnel, I will prefer to use a suture disc. Posterior drawer is a must when you fix. Hold firmly and pull the graft, and the size of the screw is usually one size more for if bio and one size less if it's a metal screw. And then finally you check after you fix the tension on the graft, you see full extension of the graft so that there should be no impingement, and if there any tissue or the remnant is there on the anterior aspect of the tibial tunnel and you feel that it will form a cyclops lesion, you can remove that small amount of remnant ACL. And if you have good amount of bundle preserving, you can even preserve the bundle and do ACL reconstruction. That's the remnant preserving. It's hugging the graft, which helps in proprioception and faster healing. We all know we are doing this technique since ages, and we have excellent results with this technique of single bundle, circular tunnel, anatomical ACL reconstruction. But we all know the amount of footprint coverage with single bundle is around 57 to 58%. And we are either creating AM bundle or AL bundle, or we are in between them. So with the same concept, Freddy Fook came out with double bundle ACL reconstruction so that we can form both the bundles and we can have more footprint coverage. But we all know the fate of double bundle, double trouble. Technically very difficult, and we have a lot of trouble. So we have all moved from double bundle again to anatomical single bundle. So can we do something to increase the footprint coverage with the same hamstring graft using a single tunnel? With keeping that in my mind, I have prepared a new technique of ACL reconstruction with a rectangular tunnel using the same Soceity hamstring graft. So we have prepared a special tunnel dilators which are rectangular rounded, and after you prepare your circular tunnel through the same portal, we are dilating the circular tunnel and converting it into a somewhat rectangular oval femoral tunnel. It's a marked with 5 mm increment so that you can gently tap it and convert the circular femoral tunnel into a rectangular or oval femoral tunnel. So this is the original ACL footprint. This is what we create with a circular tunnel, and we get good result. But with our new technique, we can increase the footprint area and we can have a bigger femoral tunnel compared to a simple circular tunnel. This I have done on a cadaver also, and you can see this is what we reconstruct the single bundle anatomical ACL reconstruction. And the same thing, if we are using a tunnel dilator, special tunnel dilators, you can convert that circular tunnel into a rectangular tunnel without blowing out the posterior cortex, but increasing the surface area both superior inferiorly and anterior posteriorly. Similarly, on the tibia, we do routinely this circular tunnel and it's perfectly well, but the amount of ACL still is not covered, so we are using the same rectangular tunnel dilator and converting this circular tibial tunnel into a somewhat rectangular tibial tunnel. So this is what the original tibial footprint is. This is what we recreate with our single tunnel, and this is what the new tunnel with special tunnel dilator, increasing the surface area. Even on cadaver, if you see, even the footprint, if you see mentioned in the literature, is not circular. It's somewhat rectangular in shape, and this is what we are recreating with this special tunnel. And we use the same graft, but the philosophy is little different here. If you have a 9 mm circular hemistring graft, you have to drill first with 8 mm diameter and then sequentially dilate that 8 mm into 8 by 10. Means sequentially the mediolateral will remain the 8, but then you convert that 8 diameter into 8 by 10 horizontal. And since you have a 9 mm diameter graft, which is a soft tissue graft, it will squeeze from one side and it will expand from other side. So it will cover whole of the tunnel with the same Soceity graft. And after you view from the posterior medial portal, and you see it will mimic more of a kind of double bundle, like when you are extending, the posterior lateral bundle is getting lax and the anteromedial is getting taut. And when you flex, you can actually see that the posterior lateral is getting taut and anteromedial is getting slack. It's a sort of double bundle. I may not say exactly the double bundle, but increasing the footprint coverage will give you more of a double bundle. Same on the cadaver. The anterior half of the graft will go medially, will give you anteromedial, and the posterior half of the graft will go more on laterally. So you will mimic more of a double bundle with a single tunnel. And as you extend the knee, you can see that the AM bundle is tight in flexion, and as you extend, it becomes lax. So mimicking more of double bundle but with single tunnel. And a simple mathematical calculation says that we can increase the surface area by 25% of the existing circular tunnel. And this is an MRI of the same patient done 8 months back, and you can see how beautifully the graft has grown with no tunnel dilatation, as the graft has completely matured in the sagittal cut. Even if you see the axial cut, you'll see the rectangular tunnel, which is very well in the center of the footprint, and no tunnel dilatation. Even on the coronal cuts, the post-op MRI of the same patient shows that the graft is exactly between the two tibial spine, medially and laterally. So this is the small variation in routine ACL reconstruction developed by me and my team. Thanks a lot.
Thank you. Hello. Nice. Dr. Mukesh.
Thanks, sir.
Coming all the way from Nagpur and having a good darshan of Madurai Meenakshi. Madurai is famous for all hospitality, and especially Preeti Hospital. We give good hospitality. Hope you will enjoy it. And nice of you talking about the ACL reconstruction and your recent paper on how to convert a round tunnel into a rectangular one, and how the single bundle causes both double bundle-like effect. Thanks. I have more questions in the session from the audience, I think, on your new technique.
Now I call upon Dr. K.P. Saravanakumar, a local boy, to give his talk on arthroscopic ACL reconstruction by bone patellar tendon bone graft.
Good morning, everybody. First of all, I would like to thank Professor Dr. R. Shivakumar sir, my teacher, and Dr. Prahalat, my friend, for giving this valuable opportunity. Thank you, sir. My topic is arthroscopic ACL reconstruction using PTB, step-by-step approach. Among all graft, we are having so many grafts. Commonly, we are using hamstring and PTB. But using hamstring is very high as compared to the PTB. So, why PTB is, can be used? PTB is originally described as a gold standard graft in our textbook of Campbell. Very strong graft, good fixation strength is offered by PTB. This will provide a yearly rehabilitation. Good bone-to-bone strength, healing is there. Predicted outcome is there. This is less complicated technique. Residual laxity is less as compared to the hamstring tendon. Then cheap and best. We can finish the surgery with a couple of titanium screws or even SS screws for low budget cases. So generally it is reserved for high demand individuals like athletes, pivoting sportsmen, military and policemen, manual workers, and obese patients. As like any other ACL reconstruction, diagnostic arthroscopy, we are doing articular debridement, notch plasty, preparation of the tibial and femoral attachment. Then we can do graft harvesting and in a 2 incision or 1 incision technique. 2 incision, one for graft harvesting and one for tibial tunnel creation. We can do it with one small J-shaped incision, avoiding incision over the tibial tuberosity and the infrapatellar branch of the saphenous nerve. Small J-shaped incision. Through this incision, we can harvest the graft as well as we can create the tibial tunnel also. Then after exposure of the graft site, we have to demarcate the proposed site of graft harvesting. Usually the patellar plug, bone plug should be 2 to 3 centimeter in length. Diameter, usually I take 10 mm diameter. And also the patellar tendon 10 mm diameter, and tibial plug also 10 mm diameter and 2 to 3 centimeter in length. Then after outlining, we have to take the harvest graft with a thin blade, oscillating saw blade. The direction should be 45 degree to avoid patellar posterior cortical rupture, cortical rupture of the patellar bone. The posterior cortex should not be disturbed by making the angulation 45 degree either side. So the triangle size graft will be taken. The depth of the graft should be 5 to 8 millimeter to avoid posterior cortical break. Then is the removal of the patellar bone plug, patellar tendon, and tibial bone plug. Then before preparation, when we are harvesting, please don't forget to harvest along with the tibial tongue. The tibial tongue is nothing but this projection from the upper part of the tibial bone plug. We have to take along with this tibial tongue. This will be useful for to avoid graft tunnel mismatch. When we are having very short tunnel, tibial tunnel, and the graft is hanging outside, that is tibial bone plug is hanging outside, we are finding it's difficult to fix into the tunnel. So in this case, the tibial tongue will be helpful, and this will be engaging in the tibial tunnel. So graft preparation after harvesting, we have to trim the graft according to our need. That is 10 mm diameter and 2 to 3 cm length, as I previously said. These bone fragments can be used for grafting the patellar defect or tibial defect, so that we can avoid the anti-knee pain also. Then this is a sizing gauge, 10 mm diameter. Both bone plugs are being sized. Then after that, we have to create holes in the patellar bone plug and tibial bone plug. 2 holes in the patellar bone plug with the help of the K-wire or a thin drill bit to prepare with the number 5 ethi bond. See, this is the patellar bone plug. We are tying the patellar bone plug with number 5 ethi bond in 2 holes, and this ethi bond in turn attached with the bead pin, and on tibial bone plug the number 5 ethi bond is attached. Then creating tibial tunnels, for comparing with the semi-T, we have to create tunnel length, adequate tunnel length, because short tunnel is not favorable for PTB, because the length of the tendon, length of the graft is fixed in PTB as compared to the semi-T, in which we can adjust the length of the graft, but in case of PTB, we cannot adjust the length in great extent. To some extent we can adjust, so that we have to create the tunnels with good length. So the angle we have to fix in the tibial tunnel is 45 to 50 degree generally, and we can discuss in the next slide. The placement, when we are fixing the tibial jig, The placement of the jig is outside the knee joint, or the anti-surface of the tibia is 4 cm below the articular margin and 3 cm medial to the tibial tuberosity. And the angle between the jig and anticortex is 30 degree. Inside, as Mukesh sir said, this is the positioning is extension of the inner border of the lateral meniscus 7 mm anterior to the PCL. So comparing the tibial tunnel angle and length, when we are choosing 45 degree, we will get short tunnel but superficial tunnel. When we are putting 60 degree, very long tunnel but vertical and deep tunnel. So we usually choose 52-55 degree to fix the angle in the tibial jig. Then create a tibial tunnel. So through the jig, guide wire is passed, and this is the inside guide wire is touching the jig. Over the guide wire, reaming is done. Reaming is done as we are creating the craft for 10 mm wide width. So 7, 8, 9, 10 reamers are used, up to 10 reamers. Over the guide wire, this is reaming is done to create the tibial tunnel. Then creation of the femoral tunnel. Regarding Soceity, we can create very horizontal tunnel, as Mukesh sir demonstrated, very horizontal, up to 3 o'clock position or 9 o'clock position, we can create the very horizontal tunnel. But when we are creating the horizontal tunnel, to make the anatomical tunnel, the tunnel length will be very much limited. That is 20, 25, 30 mm, that's all. But when we are using PTB, the tunnel length at least should be 35 to 40 to accommodate the graft well inside the femoral tunnel. So, 3 methods are used. One is transtibial technique, transportal technique, and a modified transtibial technique for creation of the femoral tunnel. Transtibial technique, we are aware the tunnel is created, femoral tunnel is created through the tibial tunnel by means of a femoral aiming device. The advantage is technically easy, we will get more tunnel length, but the disadvantages are more vertical tunnel and less anatomical. When we are using transportal technique, which is commonly used for Soceity, the graft femoral tunnel is used created through the anteromedial portal, which is more horizontal tunnel, more anatomical tunnel, but disadvantage is technically demanding when we are using freehand and less tunnel length. So combining these advantages of both techniques, we are using modified transtibial technique. What is that? Modification at the tibial side is the entry point is shifted 1 cm superior or 1 cm medial to the conventional entry point of tibial tunnel. This is nothing but the point of intersection between the anterior margin of the MCL and upper margin of the pes anserines, exactly this point. When we are using this site, we will get the good length tibial tunnel with a good angle. Knee is placed in the varus and indel rotation position to get this good femoral tunnel. Varus and indel rotation as well as in flexed position. Then at the femoral side, the femoral aiming device is rotated a little bit horizontally to get 10 o'clock or 2 o'clock position. So the comparison of the guide wire holds. This is transtibial technique, which is more vertical, transportal technique more horizontal, and modified transtibial technique is in between. Then the femoral guide wire is passed through the femoral aiming device. Reaming is done. See, we can get up to 40 mm length of tunnel in femoral side. So after creating the femoral tunnel, roof is pierced by the 4 mm drill bit, and this is the final appearance of the femoral tunnel. Graft passage. So the prepared graft is passed through these tunnels. First, the bead pin is passed through tibial tunnel and femoral tunnel and through the anterolateral aspect of the thigh is executed. This is followed by the patellar bone plug first, then followed by the tendon and tibial bone plug. So this is the importance of the tibial tongue. In which some portion of the graft is hanging outside. So the tibial tongue is very well engaging inside the tibial tunnel. So this is graft passing through the, that is patellar bone plug passing through the femoral tunnel. Through the anteromedial portal, the guide wire is inserted in the tunnel and bone plug, and over the guide wire, titanium screw is applied. This is 1825 mm titanium screw, and this is fixation of the tibial bone plug inside the tibial tunnel. This is the final appearance of the PTB as ACL. Very taut and regarding fixation, we have to prefer upper cervical fixation, very important, because as sir said, the healing is occurring at the upper chair level. So here the graft should be fixed at this point, and at the tibial side, entry level fixation is very ideal rather than the upper cervical fixation, because in this both fixation we are getting good hold to the graft. PTB is previously thought to be very complicated procedure and known for its complication, but we can very well manage the complications. For example, graft side morbidity, this is pain on kneeling, can be very well avoided by the oblique incision, avoiding the incision over the tibial tuberosity, very small incision, and bone grafting can be done for tibial and patellar bone defect. The numbness is because of injury to the infrapatellar branch of the saphenous nerve, so we can avoid the nerve injury by avoiding incision over that. Anti-knee pain is very high in PTB, that is 20 to 40%, can be avoided by good rehabilitation and early rehabilitation and all. So graft abrasion, when we are abrasion the screw inside the femoral tunnel, it can abrade the graft and it may rupture the graft. So to avoid that, we have to flex the knee joint to 120 degree while applying the screw, and we have to apply the proximal distal traction to make the graft taut and to avoid the graft abrasion. Very common complication is graft tunnel length mismatch, because the length of the graft is fixed. So we have to adjust to some extent. The reasons for graft tunnel mismatch are long graft because of tall patients, long patellar bone plug 4 centimeter and all, horizontal and short femoral tunnel by means of our transportal technique and all, short tibial tunnel with low angle jig, 45 degree, 40 degree, we will get very low and superficial, short length tibial tunnel. So to avoid that graft tunnel mismatch, the solutions are we have to create a long tibial tunnel with a high angle jig. So we are using 55 to 60 degree, 50 to 55 degree commonly. Long femoral tunnel can be created by either transtibial technique or modified transtibial technique. Then we have to make the patellar bone plug short, 2 to 3 centimeters is enough. Then tibial bone plug should be harvested with this tongue. This is the tibial tongue, harvested with the tongue. Unavoidably, sometimes if very long graft, we can push the patellar bone plug deep inside the femoral tunnel and can fix in the middle or upper part. This is actually this is wrong, but in sometimes unavoidably we can do it to make this. Then backup fixation. Backup fixation, sometimes if any problem is arising, the tibial bone plug is hanging outside, then we can use the anterior screw post. So to conclude, PTB is the technique is a gold standard, absence of radial laxity, early mobilization, surgeon friendly, solutions for complication available, less revision surgery as compared to the hamstring. This is cheap and best. These are the advantages. So it may be the re-emerging trending. Thank you for this opportunity.
Thank you, Saravana Kumar, and I thank all the speakers of this session. Unfortunately, we'll have to have a discussion over this only after the live surgery. We'll have the live surgery now. I thank the organizers for giving us an opportunity to change this session. And
thank you, sir. Thank you very much, sir. I invite our professor, our IAS Secretary, Dr. Sundarajan, sir, to felicitate our chairpersons. Sir. Professor Dr. Chidambaram, sir. Professor Dr. Satyanarayan, sir.
Yes, sir. Yeah,
over to live surgery. The case is.
They will say in this study there was this.
Yes, sir. Short history, he said 28. Sir, ready, sir?
Intensity in the fibers of the ACL and the hyperburden of the ACL suggesting a ACL tear. And these two images are the coronal T2 sections of the knee. In this section, we could see a medial meniscus tear in the both these sections on these coronal images. And in this sagittal cut, we could appreciate the tear is on the posterior aspect. The horizontal kind of tear can be appreciated.
We request Dr. K. N. Subramanian sir and Dr. Palnivel Rajan sir to moderate the live session on ACL reconstruction. The operating surgeon is Dr. Sachin Tapasi sir.
Good morning, Sachin. How are you?
All right, good morning, and I hope you can hear me properly.
Yeah, we are able to hear clearly.
After the pandemic and all the Zoom sessions, this becomes mandatory now. Can you hear me? Can you see me? Isn't it? So, good morning to all of you, and thank you so much for all of you coming here to this session today. It's indeed a great honor and privilege to be alongside with respected Professor Sivakumar sir and respected Dr. Sundarajan sir, our beloved Secretary of Indian Arthroscopy Society. And I'm looking forward to a very good interactive session with all of you. So I think you have the history of today's patient. So he's had a chronic ACL instability, and along with me, I'm assisted or rather directed by Dr. Prahlad. Prahlad has been with me since 2006, and I have learned a lot from him. He has always been a very meritorious and a very, very hard-working orthopedic surgeon, unlike me, and it's a real great honor to work with Prahlad. We also have here with us Dr. Dr. Simbu from some place which is 70 kilometers from here. I cannot pronounce the name. And we have Dr. Ranjit, who is from some place, I don't know from where. Keep it there, keep it there. And the plan today is to do an ACL reconstruction. So we started a bit 5 minutes earlier than what we expected, and we just harvested the graft. I have Dr. Sundarajan. Okay, I can show you properly. Dr. Sundarajan is going to show graft harvest technique. He has a very elegant way of demonstrating that, and I thought I will spend more time with the intra-articular procedure. So typically at this stage, camera 1 zoom in. Camera 1, zoom in this side. Typically at this stage, after the ACL graft has been harvested, I will camera 2 zoom in. Camera 2, this camera, top camera, which is this camera? Okay, yeah. So this camera now, head camera, then that is camera 1, this camera. Inside OT camera, actually we don't have this inside camera. Okay, then camera 1 only, you come in. I will repair the pes fascia. I mean, I'm holding it with my tooth faucet, so you can't see it too well right now because we don't have a top view. But I think it's really important that you should repair it. So now we'll move on to the graft harvest. Camera 3, come and show me from the top. Camera, you stand there. Camera 3, come and show me from the top. Alright, camera 3, why you move? Just to stand here only. Why do you go there? What's it to go there? Why camera 3? You stand here today. Why did you shift to your place there? knowledge out there. The plan is to do either a 5 or a 6 strand hamstrings. The first thing that you want to do is to make sure that you clean the graft properly. So here we are using a simple 12-inch ruler, and we're going to be cleaning up the graft. By cleaning up the graft, you want to remove all the muscle which is there. You want to make the graft look really nice, and that is how we will do this. So a lot of preferences for doing graft harvest. You can do a graft harvest with an open stripper. You can do it with a closed stripper. You can do it in a sort of a minimally invasive technique as well, where you are able to, make an additional incision on the medial side of the thigh, and you can not open up the area anteromedially. What is important to understand is What is important to understand is that no matter what you do, you should try and preserve the inframedullary branch of the saphenous nerve, which may cause any form of which may cause hypoesthesia or anesthesia, and then may lead to a painful neuroma. I want to do this. Okay, so we have this graph. Unfortunately, this graph monster is not behaving itself. Otherwise, you would have shown you properly. It keeps on twisting. Rather, you have to go like this. And put this here so that it stays under tension. Okay, so I'm not so sure what you can see there. Alright, wonderful.
Sachin.
That brings to a very important topic as to what sort of diameter program. We want to cover 80% of the foot. What Ranjit did not mention is that preoperatively I measured the diameter the footprint length of this patient's ACL tibial footprint on his MR scan. His tibial footprint is approximately 9 millimeters in width by 18 millimeters in length, and I want a graph which is going to be covering minimum of 80%. So 80% of 9 by 60 makes it around 8 to 8.5. So I want a graph which is going to be 8.5. That's the ideal width or the diameter that we want. The next question is, what length do we want? So length is actually dependent upon the patient's height and the patient's build and the quality of collagen that he's got. And if you look very carefully into the same, if you look very carefully into the same, taller the patient, longer will be the hamstring grafts. That's a no-brainer for sure. What we want is ideally about 25 to 30 millimeters of intra-articular length. We want about 20 millimeters, 15 to 20 millimeters, ideally 20 millimeters, to go inside the femoral socket, and your tibial socket should have at least about 25 to 30 millimeters if you're using a fixed loop on the femoral side or adjustable loop on the femoral side, and if you are going to do trans-tibial screw fixation with an aperture fixation and not use suspensory fixation on the tibial side. So that makes 30 plus 25 is 55, and another 20 is 75. So you want to have at least 75 to 80 millimeters of length of the graft, which is the ideal that you're looking for. Depending now upon the diameter of the graft, you will decide as to the diameter of the footprint. You will decide whether you want to perform a 5 or a 6 strand graft. I think if you ask me, there is not much role of doing a 4 strand graft, because a 4 strand graft directly reaches 8 millimeters, and we have a lot of papers that show that if your graft diameter is less than 7.5 millimeters, then the risk, we're talking about a hamstring graft, then the risk of failure of your ACL is as high as 25 to 30%. So with this very important data, which has got very good evidence now, we would definitely aim to have a graft which is no less than 8.5 millimeters in diameter, which I feel is absolutely critical in
So say that again.
No, I said this is my philosophy or ideology as to what should be the ideal graft diameter. Do you have any difference of opinion on?
No. I standardly use almost 9 mm diameter. Most of the time. Okay. 8 mm if I get it, I try to make it 5 stand or 6 stand at least to make it 9 mm. That is yeah. Yes, correct. 8 below 8 is usually not acceptable. Even in a thinner small individual also we try to make it 8 at least. Yeah.
Yes. So in your practice, what percentage of your grafts are 4 strand? What percentage of your grafts are 5 and what percentage of your grafts full?
No, in in 70% of the patients, we were able to get a 6 stranded graft of 7.5 to 8 centimeter length, and maybe in very few, like 10% of the patients, we couldn't make it beyond 5 strands, or we couldn't make 5 strands. In those patients, my preference would be to either go in for the opposite side, Soceity.
Okay, so you don't routinely harvest the gracilis, is it?
Yeah, of course we do. It's a 4 tendon quadrupled Soceity and doubled gracilis. 6 tendon.
Okay. Yeah, Prahlad, please soak that graft in the. Again, the next question is that if you see camera 3, if you see Prahlad has soaked the graft in vancomycin solution. So how many of you use vancomycin pre-soak for your grafts?
I think the couple of hands are being lifted up.
Okay, so I think I'm 100% vancomycin graft soaker, and you need to take 100 mils of vancomycin, 100 mils of normal saline, and you need to put about 500 to 750 milligrams of vanco. And the key to this is that if you, this is not opening, right, Prahlad? Yeah, now tighten it, yeah. And then if you take a simple gauze piece, then that gauze piece will soak in about 6 ml of solution. So you have a 0.6%. You have a 0.6% solution of vancomycin, and that helps bring down the risk of infection. So I think with this I've been able to bring down the risk of graft-related infections to almost 0% over the last, I don't know, maybe 6, 7, 8 years now. And we have multiple papers and meta-analysis on the same, which will corroborate the same evidence. So I think this vancomycin pre-soak has really helped improve our outcomes and our results. Again, the next question is that what do you suture your graft with? Normally you can use number 2 polyester.
I was about to ask, you are telling already. what material to stitch for whip stitch?
So
are you using ultra braid now, is it?
Yes, I'm using ultra braid because Prahlad wants me to use ultra braid.
What is the rationale behind that thought? The rationale is that's the rationale behind.
You will need to ask Prahlad after the meeting, very privately and secretly. Otherwise, number 2 polyester is what I use. Never use number 5. I've seen a lot of people use number 5. At least I will not recommend use number 5. That is one, because it forms a very bulky type of construct, and unnecessarily you have to drill very large tunnels to accommodate that number 5. That is one. Second important aspect is that don't go too overboard with your suturing, because if you keep on suturing over and over again, and if you have very long stitches on both ends of the graft, you want to avoid the presence of any polyester material inside your ACL tunnel, inside intra-articularly. So if you have something like polyester ethibond which is coming inside the ACL, then in that particular aspect you don't really want that to happen, because the presence of any such material inside will always cause problems. Again, there's no use of a very thin tendon towards the end, so we're going to sacrifice that. We don't want such thin tendons towards the end, and that is the other thing that you will do. So I'm sorry if I'm being slow. This is a part of the surgery which I don't think I have done for several years now. So, which is why I think I'm not looking as elegant as what all of you expect. So please pardon me for that.
Kindly explain us about what you're doing now, because you're stitching the middle of the tendon, isn't it?
See, what has happened is that the end of the tendon is so thin that there's no sense keeping that. It's not going to serve any purpose. And your sutures are also not going to hold. So,
Augmentation.
No, I would have ideally liked to just cut off that remainder part of the gracilis, which I will just show in a moment, because the end of the tendon is extremely thin and we don't want to use that at all. So this is no augmentation. This is just some, this is all very, Prahlad, your hand is coming. This is all very thin tendon, which is of no use to us. So that needs to go. Okay? So this is what we have. This is our gracilis now. Again, my gracilis is measuring about 21. So I can do a 3-strand with my gracilis. And now we'll move on to using a fixed 20 mm endobutton loop. So somebody please get a fixed loop 20 mm endobutton.
Sachin.
Yes, sir. Yes,
Sachin,
sir.
Sundar here.
Yes, sir.
So that means you are using 5 strands. That means you are using a triple semity and a doubled gracilis.
I will do a 6-strand graft.
Okay.
Okay, I'll do a 6-strand graft where I'll use a tripled semity and a tripled gracilis.
Okay.
I'm waiting for a 20 mm into. I'll open it 20. Come on, quick. People are waiting for us.
Only that is possible if you have enough length, isn't it?
I'm sorry?
If you have enough length in gracilis, we can use 6-strand or 3-strand.
Enough length gracilis, we can do 6-strand. You're right. Correct,
Yes,
correct. So we have now a 20 mm fixed endobutton loop. I am not so much a fan of using adjustable loops. Adjustable loops are really good. I mean, there's really not much of difference between an adjustable and a fixed loop. So we'll show it on a fixed loop today. Prahlad, come to my left. And this is your fixed loop endobutton. Prahlad is going to hold it like this. I'm going to first take my gracilis graft. The portion of the gracilis which is thinner is the one that I am going to stitch to the end of my endobutton. So this is the end of my endobutton. My friend, you have to hold the graft in your hand. Huh? Put up a good show. Good boy. Keep tension and keep holding it. Okay. So we're going to be stitching one end of the graft in this particular manner here. Okay, so this is how I normally prepare. Prahlad, you should not do this, beta. Wait. Arre, pay attention, Re. Why are you sleeping? Oh, 1 second. Sorry. Why are you sleeping, Re? So in the enthusiasm, he has pulled one end of the graft, which is why the second knot sort of slipped out. Sorry to put up such a shabby show, but these are common problems. Okay. Right, situation salvaged. Ranjit, why are you sleeping? Huh? Don't sleep. You also had alcohol last night? No, don't have alcohol. Okay, so 2 knots, then take it through the loop again. After you've taken it through the loop again, then take a stitch through the tendon for extra anchorage in this particular fashion, and then another 3 knots. Prahlad, ask him to hold properly. Huh? And once you've done this, before you cut it, you pull and see that it is not coming out, because the last thing you want is that the graft just knife 15 blade. Prahlad, don't shift. That the graft just pulls out and then you start landing in problems. Okay, so this is finishing with this. Again, now I'm going to come to the end. Prahlad, hold it here. We're going to come to the end. Knife, please. Give me the marking pen. Okay, and hold it here. Just to understand that this is the gracilis, we'll just make a mark with a blue pen. The next thing that you'd want to do is to Take the two tails, give me the two tails, Ranjit. Take the two tails, feed them in, take them out in this fashion. Get the graft through the loop like this, and then open up the two tails and bring it down in this fashion. So this makes your first 3 strand, and so that it does not shift out of place, I'm just going to tie a couple of knots on this so that it stays properly. Ranjit, hold this, be a good boy. Very good. Next we'll take the other tendon, and we'll again take the thinner side or the thinner loop of the same, repeat the same process. Ranjit is going to be more attentive this time, and he's going to behave like a good boy. Again, hold it there. Yeah, can someone just take out the slack and give it to me? Arey Ranjit, what are you doing? Hold it there, good boy. Come, bring it closer, my friend. Bring it closer, my friend. Bring it closer and don't move. Okay, now we need 3-0 monocryl. 3-0 monocryl. Again, 3 knots there. Pass it through the tendon for a loop, and then tie it down so that it stays in place, and have 3 more knots again. So Ranjit, I want you to pull the other graft that you have. Pull this and show. Pull. Good boy. So it's not coming out, no, Ranjit? You're happy? Yes. Very good. Ranjit is happy. I am happy. And now we'll cut this out. Discard that. Show me this. And again, we repeat the same step in which we will feed the graft. Ranjit, please feed. Ranjit is a very bright boy, and he wants to take over the practice of Prahlad, is what he was telling me just now, and banish Prahlad from this place. Prahlad? Correct? Okay, so now we have our graft ready, and now comes the time to size it. So Ranjit, pick up the sizer. The sizer number should be seen like this. You have to show it like this, Nare? So we're going to look at the tibial end. The tibial end is going to be a 9 or a 9.5 probably. The 9.5 or the 9 is going to be the tibial end. So we'll look at that. And now I'll look at the femoral end. The femoral end, 1 second, is again a 9.5. So the femoral end is a 9.5 to a 10. The tibial side is also a 9.5 to a 10. So I think a 9.5 graft is a good idea to have. And now this graft is going to sit in the endo-button cradle in this particular fashion. Take your hands behind. And we are now going to tension. We are now going to tension this. Why is this ulta, re?
Sachin, do you put monocryl also on top of this?
I'm sorry, 1 second. I can't hear you.
Do you put monocryl stitches on top of this?
Yes, I'm going to put monocryl sutures now.
Yeah. To keep all the 5 strands together?
Yes, to keep all of them together. What is this? I'll leave it. I've got it on this now. Wait. Yeah. I'm going to put monocryl sutures, and I'm going to pre-tension my graft. I think I really believe in the concept of pre-tensioning. So you have this pre-tensioner that comes up here. So you put one. This is broken. This pre-tensioner is broken. Okay, so now we have this. No, this pre-tensioner is broken, Prahlad. No, this is a broken pre-tensioner. We can't use this. So, unfortunately, we have a broken pre-tensioner. This is very unfortunate. And I think the company who is providing instruments should look at their armamentarium a lot more properly and at least for live demos, they should supply proper instrumentation. I think they are the ones who are losing in all of this by doing such unfortunate things. Right, so I'm using the other non-measurable pretensioner in this particular fashion, and now I'm going to ask Ranjit to stitch the entire graft with monocryl from start to end. And after that has been done, he is going to take a Raytech gauze soaked in saline and wrap the graft. Okay?
Sachin,
yes?
There's a small doubt we have.
Yes?
There is a mismatch between the length of ST and gracilis there, isn't it?
Correct. That is because the ST.
And how are we going to manage that?
So the ST is going to get cut because the ST was quite long, right? So I don't think that is going to come too much in our way. I could have decreased or cut off the ST to match that of the gracilis. But I think I'll sort of just stitched it, and once our graft protrudes out of the tibia, we will let go or just excise that extra piece of gracilis which is there. This is 70-degree scope. Where is 30-degree scope? Why are you guys giving me 70-degree scope?
Excess semitendinosus, you mean? Excess ST can be...
Excess ST I will cut off.
So, given a chance, you will prefer to cut ST or gracilis?
Given a chance, I will not cut anything. Given a chance, I will not cut anything.
Yeah.
Camera 2.
A 4-strand semity and gracilis would have been more better here?
You can do that. It will make a very thick graft, Mukesh. It will make a very thick graft because already we are now coming close to about 9. All right?
Yeah.
The patient's footprint is 9.
Okay.
A 4ST with 3G will go to almost 11.
2G.
And if you start a very large graft is also not a very good idea. Light source on is also not a very good idea. Now you'll have to move back.
I am also of same opinion like you, because more than 10 mm graft is very, very big. You have to go for 11 mm screw, and it becomes very non-anatomical then.
Inside view.
So 9 mm is optimal.
Yeah. If you have a very large graft, it starts stuffing the intercondylar notch, and then that creates problems. Okay? So now inside view on, I don't want. If they want, they can have. Then let it be. Forget it. Okay. So now we can see some loose cartilage fragments in the joint. I have not made them. So we're looking at the suprapatellar pouch here, going down to the medial recess, again coming up, going down now very gently to the lateral recess. Gradually, we are now entering the popliteal hiatus. What you see now is the popliteal hiatus and the tendon of the popliteus that is going right to the back of the knee. The popliteus tendon has 2 popliteomeniscus fascicles. You can see the what happened? You forget the recording, Ray. Don't forget the recording. You can see the anterior-inferior fascicle, and you can see the posterior-superior fascicles. These are the 2 fascicles of the popliteus. And once you see them, if you internally and externally rotate the knee, you can see the popliteofibular ligament tightening and loosening right in front of you. So whenever you're suspecting a posterolateral corner injury, that is a good thing to look at and decide what one needs to do. There is some fraying in the trochlea. The patella otherwise looks fine. I'm now going to flex the knee to 70 degrees. Once you flex the knee to 70 degrees, you will come in with a top view, camera 2. Sorry, camera 3. Camera 1, sorry, camera 1. You will come in with a spinal needle, and you can observe that the fat pad is like a triangle with the apex at the inferior pole of the patella. So you want to come in with a spinal needle or a standard needle with the knee flexed to 90, and your needle should touch the roof of the intercondylar notch. Leave the needle in place or take it out, and now make your first portal, which is the anteromedial portal. The anteromedial portal is important because if you don't make a proper portal, you will not be able to look down properly, and if you cannot look down properly, you will not have good visibility. Remove this.
Sachin, we are not able to see the arthroscopy pictures.
Inside view, somebody please show Ray. Do PIP, inside view. Okay. Once this is done, you want to resect as much of the fat pad as is required. You don't want to have any compromised visibility. So now I'm coming with a 4-5 shaver under suction, and I'm just cleaning up the fat pad which is going to obstruct my view. There was some thought previously that you should save the fat pad. Yes, if you save the fat pad, it does help in causing less infrapatellar scarring. But if because of a large and thick fat pad, you have obscured visibility of the anatomy, and if you make an abnormal or a non-anatomic tunnel, then the chances or the risk of landing in failure are much higher. So if you ask me, I will take the risk of a bit of scarring in the fat pad as against the risk of doing any form of abnormal, as against the risk of having a
I think the scarring risk is very, very minimal. I don't think we should worry too much about that.
Okay, so now this ACL looks so normal that you feel, oh my God, I mean, is this actually a tear? But you probe it, you'll see that it is completely come off from its femoral origin right here. There's nothing here. And this is a lambda healing in which the ACL sticks to the PCL. So this gentleman had a femoral sided avulsion. If you can see, I can just tease off the femoral sided avulsion here. Right there, okay. He's had a femoral sided avulsion, and the whole ACL has stuck down to the PCL. So what are we going to do? We're going to try and preserve as much remnant as possible. With the help of a probe, I'm just going to try and release all of this which is there. Again, please don't get too overexcited to try and preserve all the tissue, because the worst mistake that you will make is that you will start preserving tissue, and then because if you have limited visibility, then you will place non-anatomic tunnels and you will have compromised outcomes. So that is my philosophy, or that is my understanding of how to approach such type of injuries. If you want to preserve all the footprint, then you have to have another type of, you have to have some other extra visibility in the form of either using a C-arm or something of that sort to look at it. So this is the ACL now. Where was the arthroscopic ruler? It was somewhere here. I had kept it here. Yeah. You want to measure the length of the footprint. So preoperatively it was 16 millimeters in length. And yes, it matches 16 millimeters in length. Pretty happy about that. We'll look at the width, or we'll look at the ml dimension of the footprint as well. So let us check that now. And again, I find this ruler to be a very good companion. So here it is 9, okay, 9.5. So if you put in a very large 10 millimeter graft, it is going to remove the tibial spine, which is not a good idea. And if you check the width of the notch, it is barely 10 millimeters. Again, any graft which is larger than 10 will cause stuffing of this intercondylar notch, and your patient is likely to have a flexion contracture. So bigger is always not the best. You need to be exactly appropriate, and that is what we want to be. So now we'll start with palpation.
Sachin, what is your view about anterior-posterior width? You are telling about width in the coronal plane, isn't it? In the sagittal plane. ACL's dimension in the tibial side.
16 is anterior-posterior.
Yeah.
And mediolateral was 9 millimeters.
Okay, fine.
Okay.
Huh?
Thank you.
Thank you. So now you want to see, and the first thing that you want to see is the posteromedial part of the meniscus. So you pass your scope between the MFC and the PCL. The knee is still flexed to 90. You can see the shiny white fibers. These are the shiny white fibers which recognize or which indicate the insertion of the meniscus root and the recess between the root and the PCL. They are fine, so the root is good. And now you slowly walk in the back of the knee and then turn your light source around to see for a ramp lesion. So very nice talk in the morning by Dr. Sujit about ramp, and this is exactly what you want to see. You can, with your knee, just give a bit of varus force. So I'm just giving a bit of varus force with my knee, and that will open up if there is any ramp. Preoperatively, his MR scan was showing the presence of a tear, and now we'll bring the knee to a position of 10 degrees of flexion, pass in a hook probe in between, and start palpating the undersurface. So on palpation of the undersurface, you can see that probably there is, the meniscus looks just fine. You don't want to create a tear by pulling, but here I just feel there's a bit of extra mobility and giving way, and you can see that when I press on the meniscus, you feel that it is sort of, wanting to pout out inferiorly. At this instance, camera number 1, at this instance, I'm going to palpate the posterior middle part of the tibia. Zoom in. Camera 1, zoom in. Camera 1 large. Arthroscopy picture small. So you're going to palpate the posterior middle part of the tibia. I'm providing a valgus force with my leg, and I'm going to make a series of micro perforations in the MCL, and as you can appreciate, the MCL will give way. Now inside view large, outside view small. Inside view large, arthroscopy image large. And now you can appreciate that the meniscus, you've done pie crusting of the MCL, so that now you have good access to the medial meniscus. So here I cannot appreciate any medial meniscus tear. The MR scan was showing an intrasubstance signal. I am not too upbeat about trying to remove the zone 3 of the meniscus to observe a tear because it is not communicating. This meniscus looks too nice for me to do anything.
It's a grade 1 tear, isn't it?
Yeah, any difference of opinion? Anybody who would want to take out and start probing and create a tear in the meniscus? Yeah. Since the patient has got some laxity, it is quite normal and natural that you can get, such kind of opening which is suitable to you. Now we are going to bring the leg to a figure of 4 position. The things that you need to check here are the lateral root of the meniscus, the posterior root of the lateral meniscus. Again, very important. You can very nicely see the posterior root of the lateral meniscus, how it is inserting very nicely on the tibia. And you can then see the entire meniscus in its entirety right down to the anterior horn, which is what you require. In the mid-third area, you can again observe for the popliteus tendon. This is your posterior superior popliteal meniscus fascicle. You will have the anterior inferior, which is best seen when you look at it as you drive it down the gutter. Now there is an abnormal opening on the lateral side here, but this is not a posterolateral columnar lesion. This is because this patient has got hyperlaxity, which is why he has got this kind of appearance. So flex the knee to 90 please now. Prahlad, please flex to 90.
That's what I was thinking. No, lateral side you are opening up quite well. Lateral structures are normal, isn't it?
Lateral structures are normal.
His
clinical exam does not suggest the presence of posterolateral columnar injury. He's got hyperlaxity, which is why there is abnormal opening on the lateral side. Next, you want to make an anteromedial portal, camera 1. Camera 1 large, arthroscopy image small. Okay, this is the area of the joint line, and you want to come in with your needle and direct it towards the proposed site of the tunnel. So this is how you want your needle to come. You want it to be close to the medial femoral condyle, above the meniscus, and to be directed in that fashion. Prahlad, please remove the needle. Take it out. And now I'll make my anteromedial portal, and I always make it horizontal because I want a good area for my drill to come through. So we're doing an anatomic type of ACL reconstruction where we're doing transportal drilling, and for that reason, we create a horizontal type of a tunnel. I do not cut through the fat pad, instead I just open it up with a dissecting medicine bomb type of a scissor in both an anterior-posterior and a medial-lateral fashion, and then just come in with a shaver and clean up a bit, which makes you sort of, tidy up the whole thing so that all your instruments pass through quite easily. At this juncture now, I'm also going to do a bit of cleaning up for my anteromedial portal, because as you flex the knee, the fat pad changes. There'll be a new portion of the fat pad which comes into view. And always I think it's nice to have surgery which has got good visibility, which then allows you to do a good job. My scope now will shift to the anteromedial portal because we want to see the femoral footprint. Ruler, please. Ruler.
Now please show us the landmarks for making femoral tunnel.
Yes, sir.
Yeah.
So now I'm going to take the ruler, and this ruler is going to get bent in this particular fashion, like this. Again, inside view large, and then I'm going to pass this inside view. Please make the inside view large, outside view small, and now I'm going to pass this ruler in this particular fashion. You want to go and reach the end of the intercondylar notch, and you can see and observe that again the ACL footprint in this gentleman is about 8 to 9 millimeters, right? And the height of this ACL footprint, again I'm just going to enlarge the portal for a moment so that we can get our ruler in properly. Second, Prahlad. And the height of our ACL foot, oh gosh. Whoosh, whoosh. What is this? 1 second, I'll just get a shaver in. We'll just take it out. It will come again. Sundarajan will shout at me. If I don't do a good job. Okay. Yeah. So again, if you observe very carefully here, it's roughly around 7, 8. So 8 millimeters is the extent, correct? And if you look at the width, it measures about 12, 11, no, hang on for a second, 11, 12, 12. So 9 by 12 is the femoral side, okay? There are a couple of ways you can use this femoral footprint to your advantage, and we'll go through all the various techniques. I'm just doing a bit of a cleanup here so that you can see it properly. You need to see properly, otherwise, if you don't see properly, you will not have good tunnels. And if you have wrong tunnels, then you have wrong surgery. So, which are the various techniques by virtue of which, where is the meniscus slaughter? This one. Meniscus slaughter was there, right?
Sachin, for the sake of audience,
yeah,
can you please show us the ridges that you see, bifurcate ridge,
exactly.
residence ridge?
Yeah, I'll go through everything. Come on. Subi, hold this. Right. So now, what are the ways in which you can mark your ACL tunnels? Method 1. Give me a trimmer. Hold this. Put gauze piece and soak. Give me a trimmer, Prahlad, from here. Just give me a trimmer in my hand. Yeah. So, technique 1. Take out your slotted cannula. Technique 1. When I see the footprint, I place my reamer, which is equivalent to the diameter of the tunnel that I'm going to drill. I match it exactly on the footprint and I drill through it. Technique number 1. When you see the whole footprint properly, this I feel is one of the best ways to do it. Technique 2. Use a ruler. So in this, hold the scope, Prahlad, please. Hold the scope properly. You should show it properly. Otherwise, they will remove you from Tamil Nadu Arthroscopy Society. Wait. They will remove you, Prahlad. Okay. Technique 2. If you can see if you are able to visualize the footprint properly, hold the ruler. Prahlad, you want to hold the scope or the ruler? You'll have to hold something. Yeah, the ruler should not shift. Okay. Where is the tocha? Technique 2. You want to align the ruler with the posterior most border of the footprint. Prahlad, right there. You want to measure the length of the footprint, and then Prahlad, don't shift the ruler, beta. So this is the posterior border. Just hold the tocha 1 second. There is some tissue which needs to come out. Better. Yeah, it was coming in the way. Okay. So you align the ruler with the posterior most border of the ACL footprint. Prahlad, don't shift the ruler. Pull it out a little bit. Prahlad, they'll remove you from Tamil Nadu Orthopedic Society, Arthroscopy Society. Don't do that. And now you can see that the footprint measures about 10 millimeters. If you want to do a center to center, go to 5, but I will go to a 4, and I will make do tutu, and I will make do tutu. Dona, go. Subba, Somi, bas. You will make your, take it out, Prahlad. You will make this microfracture all whole, which will, wait, don't do anything. And this will be where you will make your tunnel. So this is technique 2. Technique 3, keep this like this, Ray. Technique 3 is that you will take an offset aimer. You will take an offset aimer which comes from behind, and you will go there. But I find this very crude because this offset aimer, you have so many offset aimers, and it's not that all the offset aimers are properly oriented. So offset aimer is technique 3. Technique 4 is you can completely denude the footprint, and I'll do this here now, so that you take out all the soft tissue from the footprint by using a radio frequency, by using a curette, by using whatever technique you want to use in this particular fashion, and then you palpate and see all the ridges which are there. So I need a small curette, Ray. You had a small curette, Ray, please. So in cases of chronic ACL, where you have 1 second, Prahlad, where you have no cannulated drill bit, where is that gone? Acha, you got this is what, 3.2 or 4.5? 4.5 I wanted, forget it. Give me that cannulated drill bit, Nare, hero. Put this. Okay, normally I don't do this step. I don't drill a bead pin, and I don't use a 4.5 cannulated drill bit. I just use 4.5 solid drill bit, the one that comes out of your AO set, and that is what I find to be quite easy. It's pretty much time saving as well. So here we are using a cannulated drill bit. Next you have to give me the depth gauge. Okay, here, hold. Put 7 femur followed by 9.5 femur next.
So please also tell us how much you drill 9.5, how much length, and
so this is where we are now. Now I am going to take the guide wire off our screw, bring the knee to, you didn't give me a depth gauge, my friend. You're supposed to give me depth gauge.
No. What is the length of the 4 mm reamer? How much did it go?
So usually I will get about 38 millimeters as the length in 95% of patients, and it is 38 millimeters here. Good. So now I will use a guide wire which comes from the screw, which is a simple Nitinol type of guide wire. Flex the knee to 90. Okay. Hold, Prahlad. You have to hold and show properly. Give me 7. Yeah. How much time do I have left? So accordingly I'll speed up. This is a 7 that is going in first, and I'm going to drill this 7 till I reach the lateral cortex, which is there. Flex the knee again to 90, and by doing so, I avoid injury to the cartilage, because the last thing that you want is to scuff the cartilage. 9.5 now, femur. If it is not there, give me 10. Give me 10. If they have not got the half sizes, give me 10. Again, do a bit of cleanup. Get me one single strand of ethibond, number 2, to use as a suture. Always a very good idea to use sequential reamers, and the advantage of doing this is that you can avoid injuring the condyle, which if your knee is hyperflexed, you invariably end up doing it. Prahlad, show properly. They will banish you from Tamil Nadu Orthopedic Society. Very good. Again, now with a 10, I'm going till I reach the lateral cortex. Bring it out.
You are almost reaming the 9.5 up to 35 mm, is it?
I go up to the lateral cortex.
So just sort of lateral cortex.
Yeah. When I feel it, I take it out. And the reason why I do that, Prahlad, beat pin with loop. With loop. Beat pin with loop. Put one suture loop so that we can, for graft pulling. Okay, and then you want to clean up everything. You can again cross-confirm to see if you are adequate. Just a quick check now. Have I perforated the posterior wall? Thankfully not this time. And this is an inside view of my ACL femoral tunnel, as it should be appreciated. You want to ensure that there is no perforation, there is no blowout, both lateral as well as posterior, and you want to ensure that you see this. The reason why I go up to the lateral wall is because there's a lot of bone dust that goes and settles on the end, and that effectively decreases the length of your loop. Where is the ruler gone? Ruler. Dr. Sundarajan wants to see the ruler. Okay, and you can always come back in with a ruler just to confirm and cross-check if you have done an appropriate job. So, correct, the center is around, the length is around 11 and my center is around 4. Okay, is that okay, or?
It's fine, yeah.
It's fine, thank you so much. So now, after this, I'll take a bead pin with a loop to park my pulling suture in. Prahlad, sir, 1 second. Hyperflex, please.
What is the angle you keep for drilling?
Pull.
Any specific angle, or you just
120 plus.
120 plus.
Clip. 120 plus. Put a clip. 120 plus is what I will use. Okay? No, don't clip it. Clip it. No, clip. No. Clip this. Prahlad, don't clip it to any drape, because if you clip the drape now and you shift the leg, the whole thing comes out. So put it on the top here so that it doesn't get locked, and just ensure that it is at the mouth and is not bothering you. Okay? So now we'll come to the tibial footprint. For the tibial footprint, again very important to see the center of the footprint. Get a grasper for a moment, please.
Sachin, if you have a hyperextension in this patient,
correct?
Any change in the footprint?
Yeah.
Do you
so
have
this
any
chap
other
has
type?
got hyperextension of about 5 to 10 degrees. He doesn't have like a huge 20-degree hyperextension. But the rule of the thumb is that if you are hyperextending, then you should try and go a bit more posterior rather than more.
Fine.
Now, I always like to visualize and mark out where my tibial footprint is going to come out based on viewing from the anteromedial portal, because you get a very nice view of the tibial footprint here.
Yes.
And your landmarks could be the posterior border of the anterior horn of the lateral meniscus, But again, that's a very variable thing. People have different size menisci. You see this very good, rich blood supply coming into the ACL from the anterolateral side. So normally, if I can just make a mark here, and this is the midpoint, you want to be more medial than lateral, somewhere there. And you can always use the ruler one more time to see whether you are exactly in the center of the footprint, whether you are more, where is the ruler gone again, right? Where is it? Yeah, got it, yeah. You need to be more anteromedial than posterolateral. So again, looking at this in perspective, 16. So I'm roughly around the 8 mark. So I'm in the center as regards the AM side is concerned. And if I'm looking at the side to side distance, I think I just will shift the scope here so that I can bring it from here. Okay. Oops. Yeah, that's better. Okay, so you need to be 2/3, 1/3, and there is some soft tissue coming again. I'm not doing a good job today. Prahlad is making me nervous. Okay. Right. So 6 plus 4. Okay.
Okay, fine.
Yeah.
Yeah.
6.
More medial than in front.
More
of the
medial.
center.
So
Yeah.
2/3, 1/3 is where I want to be. Now we'll come in with our tibial jig. So Prahlad, you have to come and drill for us, please. If you visualize from the lateral portal, make sure that you turn your light source to posteriorly so you can see the entire anteromedial extent of your tibial footprint. I'm going to use a tip aimer here because there is a lot of remnant, which is why if you have patients who have got a lot of remnant, it is always very useful to use a tip type of an aimer. Bullet? There is somebody lock the table, Ray. Lock this thing. So I have the angle set at around 55.
This one is elbow aimer, isn't it?
This is elbow aimer.
Yeah.
Come on, Prahlad, drill. And I want 7 followed by 10.
7 followed by 10.
Okay, understood? So Prahlad is going to drill. Prahlad, please drill.
Are you intentionally keeping little posterior?
Come again?
Are you intentionally keeping posterior?
Yes, a bit. But that's enough. You have come out. Okay. And now, Prahlad, come to my left. We'll visualize from here. This gives the best view of the tibial tunnel. I have not seen a better view of the tibial tunnel. Please feed, Prahlad. Please feed this. Sibu, Sillu. No, I'm good. Okay, come out very slowly, slowly, slowly. I need a grasper in a moment. Grasper, please. There's just some stuff here that needs to come out. Okay, so we have preserved the footprint. We've not disrupted the footprint as far as possible. And I'm just trying to find where the bloody hole is, which is right there. So if you have preserved the footprint and you want to have a peek, again I'll bring my scope from here, from the lateral side. My scope exits perfectly there. It is underneath the footprint.
Excellent position for the femoral tunnel.
And now I can just leave this in here. Prahlad, can you extend the knee very gradually, please? Extend the knee slowly, slowly, slowly. Prahlad, 1 second. I need to show properly. Extend the knee, please. Completely. Extend, extend, extend. Go, 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 go. There is no impingement. So in spite of hyperextension, go and do hyperextension 10 degrees. There is no anterior impingement of the graft there, okay?
Fine.
So please flex again, Prahlad, very slowly. Very slowly, please flex, 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 flex. Very nice. Thank you. Prahlad, little bit extension. Now flex 90. Good. Okay. Let's have the grasper for a moment. Right. Now again we'll come with our bead pen. This is wants to disappear inside. I'll just make sure it stays on top here. Okay. Right. Now please give me the bead pen in my hand, bead pen in my hand, and I want the tutu. Prahlad, take tutu. Yeah, where is the position, Ray? ठीक है, Selam. Silam. Where is it? Acha, I can't see. Can you see from here? Show me, Ray. Hold this. Hold this. Give me the shaver. I'll take care. Leave it. Yeah, I got it.
Can you see the arthroscopy picture also?
Array, who is taking away the
Thank
arthroscopy
you.
picture?
Got it.
Good. So now, you know, wait. So I am going to hold it with an artery clamp and leave. Selam, move aside. And now you can. Array, kya hai re? And now, if you want, you can manipulate the position. If you're doing sequential reaming, you can change it right, left, and center. Alright? So I'm going to hold it like this. Prahlad is going to show us. And now I'm going to drill 10. We will probably require an 11 or a 12 screw. So if somebody wants to get the screw ready, please get the screw ready. Again, very slowly. What is happening here? And the last few turns have to be done slow, because if you are aggressive on this, you get these chucks are of different intensities, and you should ask for a chuck which is high torque, low speed. So you get high speed, low torque, you get high torque, low speed, and you get high torque, high speed. So you want to use a chuck which is a high torque but low speed type of a chuck, so that it does not take out too much of tissue. So as you see here, in the end, in spite of preserving everything, the remnant, it just unfortunately took out everything, which is not a good thing to have. Okay. Grasper, please. And now somebody needs to be ready with the graft in a moment. So,
Sachin, do you prepare the screw insertion site or you just would you like to clear that site on the tibial surface, or
this side, the mouth?
No, on the screw insertion site.
Yes, I will clear that.
Okay.
So we will see on this side, correct? Hold the scope. I hold the scope, Prahlad. If there is a lot of soft tissue, you have to show here. Take one more and show properly. So, if I'm doing a BTB or a quad tendon,
okay,
then definitely all of the soft tissue over the tibial side comes off.
Okay.
Here, in a soft tissue graft, this is pretty open, as you see here.
Yeah.
Which is why I'm not going to be messing around with it too much.
Okay, fine.
All right. So now we will go to the graft and the insertion of the graft. Don't do that. Come, hold with your hand. Prahlad, show properly. What are you showing? They will banish you from Tamil Nadu Arthroscopy Society, I'm telling you. Show properly. Boss, keep tension on the graft. You don't want the graft to touch skin. You don't want the graft to touch drapes. Anything. Nothing should be touching. Alright? Prahlad, you are showing oblique view. No. You have to turn the camera, Prahlad. Turn the camera and show. Come on this side now, Prahlad. Come. Hold.
Can we have the inside arthroscopy view also?
Only inside arthroscopy view, outside small. Prahlad, hold like this.
Thank you. Yeah.
Okay. So now I will need the bandage that he has got. Roller bandage he has to give. Okay. So now camera 2. So for this now, you have to do a controlled insertion Prahlad, controlled insertion. You like to do controlled insertion. And for doing controlled insertion, you will use a bandage loop, roll it, and with your fist, you rest your knuckles on the thigh and do a gentle kneading movement. Prahlad, gentle kneading movement. Okay, slow. Prahlad, you will slowly hold it in your fist and do gentle, slow rocking movements. Okay. Very gradually, and after it comes through, you want to give it a small tug to see whether it has flipped or not. Okay, which is there, and I can feel the flip. Camera too large, camera too large, camera too open, camera too large. Array large meaning change re. Like this. I can feel it like this. If you want to cross confirm, you can go and put in a scope and check. So this is how your ACL graft looks. Okay, you can see it is footprint to footprint type of reconstruction. It is sitting nice and flat in the intercondylar notch, mimicking the ACL. Prahlad is going to come now to my right side and very slowly going to extend the knee without giving jerks. Prahlad, show properly everybody, without giving jerks. And he comes down, 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 and down again, and full extension, and hyperextension of 5 degrees, and there is no impingement in the notch, and I think I'm pretty happy with this.
Yeah, fine.
Now we will go ahead and fix the tibia. To fix the tibia, arthroscopy image out, camera 2 on. You need to decide what size screw you want, and to decide what size screw you want, you use the screwdriver. Take out the wire of the screwdriver. You use the screwdriver. Boss, take suction there, huh? Shimbu, why are you sleeping? Hold this here. One more retractor. Don't keep it. This is not the place to keep instruments. Prahlad, show. Yeah. Okay, so now you have your graft which is jutting out. Take the screwdriver and pass the screwdriver by the side of the graft. If it goes in snugly, like this, remove PIP, only one picture is required. Remove PIP. Array PIP, take it. If it goes in snugly like this, then take one size up. If it is forceful insertion, Prahlad, then same size. And if it is loose insertion or soft bone, 2 sizes up. Okay. So in this, we are going snugly. So 11 screw is what we want. Now I will
11 mm, is it?
Zoom out.
You want to go for 11 mm screw?
Yes. Zoom out, camera 2. Zoom out, camera 2. Camera 2, zoom out. And then you want to do cycling. Camera 2, zoom out full. Hai na uska. I saw it beforehand only. And you want to do cycling 20 times. Take out any creep in the graft. You don't want creep in the graft. Because if there is creep in the graft, it is not a good idea. Okay? Yes. Now, in this gentleman, because he has got hyperextension, I will go closer to full extension. So I'm going to keep it at 10 degrees. My knuckles, okay, my knuckles are resting on his tibial tuberosity, and I am giving a posterior draw with my hand and maintaining longitudinal tension. Where is the screw? 30, 35. 30 or 35. So now we'll put in a 1130 BioSure screw. The BioSure has a very flat profile at the end, which makes it very nicely and snug. It is vented also to allow for good osseointegration. And I'm giving, you should not rely on any assistance. So with one hand, you should give posterior draw. With your fingers, you are pulling and you are controlling the knee flexion as well. And you should get a good snug fit.
What is the length of the screw? 30, is it?
30. I would have liked a 35 here, but 30.
You have any preference for the side where you want to put the screw on the inferior side?
For tutu, where is tutu? So for a revision, yes. For a primary, no. And I'll tell you why. For a revision, sometimes you want to twist or the graft. Okay. In that case, what I will do is that I will hold my guide wire. Okay. I will hold my guide wire with an artery clamp and push it accordingly. But since in this primary, it is a screw which is 30 and not 35. Okay. If it was a 35 screw, then I would have held the guide wire with an artery clamp intra-articular and put the screw. But since it is 30, then the tip of the screw is not going to reach up to the area. Right. So after this has been done, I am going to get rid of this excess Soceity graft, which we have. Mukesh was very worried about the same. So I think, trying to make a thicker graft in this patient would have caused some problems. Do you agree with me? I mean, I think his footprint was only a 10, so it wasn't a very good idea to do that.
Yes.
Remove. And now you can observe that so you can see that we have got full extension here or hyperextension. We have got good flexion. There is no drawer. There is no pivot. There is no latchman, but I may have conflict of interest, so Prahlad will check and he will give final authority. Prahlad, you check and tell them if you're happy for this. If you're not happy, then we will do something else. Then I will ask Sundar to come and do revision. You're happy?
Great, sir.
Okay, so thank you so much.
Thank
to
you.
the entire
Thank you,
OT team.
It's a wonderful demonstration. There's a big clap from the audience. Thank you very much.
Anish, show camera on Anish. Anish, say thank you. Thank you. Ranjit, Subbu, Somu, Subbu, Sundar, sister, Prahlad. Prahlad is the main person. Prahlad.
Yeah, very nice demonstration.
Prahlad. Okay,
yeah, really.
thank you so much.
Thank you.
Chala, tunic it down. I put drain. You.
I think we'll go for discussion for the first session. If anyone has any questions, feel free to ask about first session's topics.
Meniscus.
So I will ask the first question because nobody is asking. So I'll ask first Jyoti Prasad to how to not to miss injury when you arthroscopy, the tips and tricks. You should not miss any meniscal injury. So what are your tips and tricks for that? So when you do a scopy, MRI may not correlate with arthroscopy. So what are the tips that you should not miss? Now you talked about the ramp. So other than the ramp also, the other injuries, how not to miss, that is the most important thing.
So first of all, we should have a clinical orientation before going in. First of all, we should have a clinical orientation before going in for a meniscal tear, because first of all, we should evaluate clinically whether there is a tenderness there and exactly what is the mechanism of injury. That is very important. And moreover, we should probe every portion of the knee, that is the medial meniscus, lateral side, anterior, posterior aspect. We should put a posterior-medial portal to look for the ramp lesion. We should probe adequately to evaluate the mobility of the meniscus and the hidden lesions. And in some variants like discoid meniscus and all, the tear will be hidden beneath the discoid. So while debriding it, making it the proper shape, and again you should evaluate for the discoid meniscus. And MRI should be only an additional, should provide only additional information rather than we shouldn't go by the MRI. That is my, let's tell more.
No, not tell. I mean, just I want to bring out the points from you. I think the most important point is the probing, because many times the hidden lesions mean what I'm talking about. These what is meaning is like that. No, the flap tear can flip back in the posteromedial joint space. So when you see inside, you may look like it's normal. Then if you put a probe and pull it, there is a part of the fragment will come into the joint. So if at all we learn a good learning point is the probing the meniscus all around from anterior horn to posterior horn, looking for the posteromedial joint space, including the ramp lesions, especially when there is a close associated with the ACL, is very, very important. Even other cases in chronic cases also, probing is the most important thing. You should inspect the root, especially the posterior horn of the medial meniscus is very important. So any patients you operate chronic ACL, then ACL root tear, medial meniscus root tear is very common, which can be missed. Because when you do an ACL, acute cases, common problem is the lateral meniscus root tear. So that you inspect and assess. Whenever you do in a chronic cases, because of the repeat instability, patient will develop the medial meniscus root tear. So that is the one easily missed in MRI. Many times MRI will not mention that unless you look into it. If you are not carefully looking into the MRI, then probing is very important for the root tear. Another is which I told, the flip back meniscus.
Medial pike crusting also very important as to it will increase the space in the medially, and after pike crusting, when we evaluate the medial meniscus, we can see many hidden lesions which was invisible before the pike crusting.
Use judiciously when you do a pike crusting. That is also important, because people aggressively do the pike crusting. Patient should not end up in the medial instability. So if you find very difficult in the assessing the posterior horn of the medial meniscus, you can do a slight pike crusting so that opens up a bit, so you can identify the hidden lesion. Mukesh wants to say same answer. So by the time, any other questions?
Just explain your method of doing pike crusting, sir. How many?
So we use the 16 gauge needle. We can use it in the tibial side or the femoral side, below the joint space or above the joint space. It doesn't make a huge difference. We know that the femoral side MCL heals very nicely. ACL with the MCL, when you see an MCL tear, always it heals, especially in the femoral side. So nothing wrong in doing the pike crusting on the femoral side. Even the tibial side, that means tibial means not in the tibial end, that is 6 centimeter below, but you are talking about the below the joint line. Just put a 16 gauge needle, just make a small 1 or 2 nick, side movement, it opens up, it pops out. Okay. Yeah, not the superficial, not the posterior. That's why you have to the posteromedial side. And it is always easy in the older patients. In the younger patients, you will find little tough, because this is very strong, ligament is strong. The older patients, very easy. Just you can make a small one movement, it will open it up. But in younger patients, you have to do slightly 3 or 4 movements to make it a opening of the pike crusting.
Okay.
Yes.
Patients tibial.
You need a longer needle.
Fish. I have one question about your technique.
Sir?
It was an interesting technique actually.
Sir, you can horizontally. Just 2, 3.
Found out very new technique, and it was
Thanks,
very
sir.
interesting.
Thank you.
I just want to know what is the rationale behind using a rectangle, because the normal ACL is elliptical. You could have used a elliptical kind of design.
The thing is how to size the graft with it. So if the whole thing is about graft, how will it match the tunnel?
Because our graft is most of the time you are making it like a circle.
But elliptical, how you prepare that dilator is difficult, because oval dilator, what's the shape of the tip, and the whole curvature, it's really tough.
Okay.
So here I have prepared various sizes, say 8 by 8.5, 8 by 9, 9 by 9.5, and it's a rounded, not sharp ends. So you can match that as per your graft size. So if you have a 8 mm graft, you can convert the tunnel into 7 by 9, so that it will squeeze on one side and expand on other side.
So you have a 9 mm dilator maximum, is it? For
I have prepared 8, 9, 10.
8, 9, 10.
10 is rarely used. But
rectangle means one side will be longer, one side will be,
yeah.
so 8 by 10, 9 by 10.
So medial lateral will remain the same, 8 mm. If you have a 9 mm graft, you have to drill first with 8 mm. And then you sequentially dilate that anterior-posteriorly. As you saw, the anterior-posterior is very big compared to medial-lateral. So it's 8 by 8.5. So 8 remains the same medial-laterally, and it expands anterior-posteriorly. So then it goes to 8 by 10 because your diameter is 9.
Are you patenting it?
Yes.
Yeah, please.
Yes,
Please
done,
do it.
done. Thank you.
Sir, do you have any experience in that? Actually, when you're putting a circle tunnel, after that you're using a rectangular thing to dilate. So it will have any fracture or anything like that?
No, because the dilator is not sharp. It's a rounded rectangular tunnel and it's a sequential dilatation. So it's 8 by 8.5, 8 by 9, 8 by 9.5 and 8 by 10. So with every dilatation you can actually see whether you are going wrong somewhere and you can correct it. Thank you.
After this technique, what is the
It's round now. Right now I have done 10 patients. So it's only 8 months I have started doing this technique. The MRI which I have shown is the only first MRI which I have done 8 months. All the patients so far doing well, except in one patient I got a minor complication exactly on the tibial footprint because the subchondral bone is quite hard on the posterior tibia. So from next time onward I am using a burr to just make it little soft and then it's too early to say about it because it's only 8 to 10 patients, but definitely all the patients who are coming for follow-ups here around 6 months, none have any complaint of instability. Even you have a very strong positive, very firm ledgement and no pivot and no anterior draw positive. From the surgeon side is not an advantage, but what I feel, the more collagen in the original footprint, you will have more rotational stability. So adding about ALL or LET or even in say grade 3 pivot, if there are no root or ramp lesions, this will give more collagen, more footprint and will have more rotational stability as well as anterior-posterior stability. For BTB, I have done only one case, but it's really challenging in BTB because you need to be very fine craftsman for that. You have to convert that in very, so hamstring easily accepts that squeezing and dilatation. Right, thank you, sir.
Thank you, Mukesh. So my question is to Palani. Because when you talked of the root tear, usually people get confused, what kind of root tear to be repaired, because we see an osteoarthritis patient also root tear. So how do you choose then correct indications to do the isolated root repair or a combined cases? So if you give a clear indications, that will be useful.
Certain things we need to consider when we see a root tear. The first thing is the BMI of the patient. Second is whether it is a medial joint osteoarthritis or a panarthritis. The third thing is the alignment of the patient. Suppose if the alignment is, there's a gross alignment defect, like it's more than 8 or 9 degrees, I won't advise the patient to undergo I don't advise the patient to undergo root repair. Rather, you can go for a HTO if it is if the lateral joint is reasonably good, because that gives a long-term result than doing a root repair. You can combine root repair with HTO, but you can do HTO alone, just ignoring the root. That also gives the same result. The study says. So because all non-arthroscopic surgeons, they do HTO, they don't consider root at all, and they give the same results. Suppose the alignment is reasonably okay, only the medial joint is involved, the lateral joint is good, then you can prefer a root repair. Mostly in the patients around 50 years, around 55, they are the ideal candidates. If they are above 60 and if they have more arthritic changes, patellofemoral arthritis and lateral joint is also involved, or if there is a gross alignment defect, then root repair alone won't be very effective. So there's a thin line which separates whom you should do a root repair and whom you should go in for a HTO. So it needs to be assessed multifactorially. It's not one criteria that says all root needs repair. You have to see the alignment, you have to see the BMI, you have to see the associated arthritic changes in the patellofemoral as well as in the lateral joint. So that is the main thing.
Yeah, that is the important point which you wanted to make it so that clear indications for a root tear. So make sure that patient doesn't have a pre-existing extensive osteoarthritis and alignment is, that is the most important thing to consider, whether to do a isolated root repair or H2O. That is the clear indications which Palani mentioned. Thank you, Palani.
Cardiogram sequence do you use for cartilage analysis before?
No, what I do is I just go arthroscopically and see if the lateral joint is really good, the medial joint is reasonably okay. Then if the root is torn, then you go for a root repair. If there is a severe damage in the medial femoral condyle or medial joint, and then still the lateral joint is good, you can try root repair, but it won't work in a long term. So maybe unicondyle, or you can give some other option for the patients, or HTO.
Because the clinical and radiological correlation is very important, what Palani said. So weight-bearing X-ray, MRI alone will not give you information of osteoarthritis. So weight-bearing X-ray is very important. We know that the bone-to-bone arthritis, then root repair, even H2O may not work well. So we have to be very careful in choosing the indication. So the weight-bearing X-ray is also a very important tool along with the MRI with the clinical correlation before you decide to do an isolated root repair.
Yes, yes.
And you used a distal suture button. So you always use that, or do you use a fiber tape with a fiber wire and a distal fixation? Do you use
The fiber tape and fiber wire, that doesn't make much difference. It gives, of course, fiber. Initially I used to do a sliding knot so that the button gets snugly fit into the tunnel, and I make 4.7 drill so that the tip of the button goes inside the tunnel, and so it gets a snugly fit. So I was trying sliding knot, but I thought sliding is not ideal because it may create a lot of aberrations in the meniscus. So it may weaken the suture which you have taken. So nowadays I just do simple, just pulling the other one, just tighten it.
And then there is a meniscus is mostly extruded, and after this repair also sometimes the meniscus is seen extruded in some MRIs.
Yes.
So do you feel that there's a need for a centralization anchor or something? Some people recommend it.
No, I have not tried.
Medialization anchor.
I just release a little bit, but if it is too much of extrusion, it means that it's very chronic. So the mechanism won't work.
It's a big controversial question you had asked. Because even after the root repair, we had found that extrusion is progresses. So even we had published one paper. After the root repair, MR, even though some healed meniscus, there is an extrusion progressed. So the centralization works or not, we don't know. Still, we don't have enough evidence to say to do a centralization. I had done a very few patients who were chronic ACL patients with the root tear with a lot of extrusion, and young patients where 20, 25 years old, neglected ACL for quite a long time. Whereas reasonably cartilage is good, but root tear is completely extruded. So that kind of patients I have done a centralization. Not for the old patient with the degenerative root tear, I have not done centralization. I am sure that Sachin also might have done the same.
I think Sundar presented a paper in international. It's published on
the root tears.
Regarding this repair, doing root repair and following
for the meniscal repair.
No, normally I don't do PRP for meniscal root repair, because once you make a drill, definitely the marrow is open and then the healing happens. So I don't think that will help in healing or anything with as far as root is concerned. If it is a bucket handle tear, if you think it is a little chronic, you can try. It may have some effect.
Thank you, sir. Thanks for the excellent demonstration of ACL technique by Sachin Tapasvi, sir, and well moderated by our Palnivel Rajan, sir, and K.N. Subramanian, sir. We also thank our supportive team, anesthetist, OT, and other fellow doctors. Now we will move on to our inauguration session. We invite all the dignitaries to the dais. I welcome our chairman, Professor Dr. Shivkumar, sir, IAS President, Dr. Sachin Tapasvi, sir, IAS Secretary, Dr. S.R. Sundarajan, sir, Professor M. Chidambaram, sir, and our organizing secretary, Praglad Kumar Singh, sir. Welcome to the dais, sir. A day without prayer is a day without blessing, and a life without prayer is a life without power. Let us all stand up for the prayer song. Thank you. We would like to invite our IAS Secretary Dr. Sundarajan sir to present the welcome address.
Good morning, everyone. So I welcome all of you for our Indian Arthroscopy Society CME program at Preeti Hospital, Coimbatore. Because of the pandemic, last year we couldn't do anything. I was secretary from last year, but 1 year we were doing only Zoom meetings. So we started doing this monthly meeting all over the India. We were planning to do one meeting at least in a month. And last month we did it in Mangalore, and we did an IAS ARC meeting in Kolkata, and this is our third meeting, which is happening in Madurai. So when we started thinking about Madurai, then Sumit nephew suggested that we had to do it in Madurai, and they opted for, they said that where can we do? Then I asked whether Praglad can do the meeting, and I wholeheartedly thank Dr. Sivakumar sir for accepting for our IASCME program to host in a short notice and making it a very successful program. Thank you, sir. And I thank Praglad and also our head of the department of Preeti Hospital, Dr. Chidambaram sir, for coordinating this event and making it more successful with the 2 live surgeries, with a good audience, with a nice program which was designed by Dr. Praglad. Thanks, Praglad, for organizing a short notice. So, as an Indian Arthroscopy Society is having more than 3,000 members at the moment, more 3,100 to be precise. And I request all of you, if you are not a member of Indian Arthroscopy Society, become a member of an IAS. It is very, very easy. Just go to the www.indianaarthroscopysociety.co.in and register yourself online. Just submit your certificate. You can become an IAS member. You can have access of more than 350 instructional video lectures, videos, and almost more than hundreds of Zoom meetings which were all done in pandemic with the international faculty. It will be very, very useful for you to learn, even if you missed in that pandemic period. Everything is available in the Indian Arthroscopy Society website. So I request all of you to become an IAS member too, apart from Tamil Nadu Arthroscopy Society. And with this, I thank once again Praglad and Dr. Sivakumar sir and Chidambaram sir for allowing us to having this meeting here. Thank you.
Thank you, sir. We welcome all the dignitaries on the dais and our Managing Director Hema Madam to come forward to light the lamp. Thank you, sir. We invite our IAS President, Dr. Sachin Tapasvi, sir, to give his presidential address.
Respected Professor Chidambaram sir, Dr. Sivakumar sir, Hema madam, all my dear friends, Sundarajan sir, and all my dear friends, faculty, delegates, hospital staff, and industry. Thank you so much for having us over here in Madurai. It is indeed a very humbling experience to be standing in front of you as a faculty, as a friend, and as an office bearer as well. I think this concept of taking education to each and every corner of India is going to be the topmost priority for all of us as a part of the Indian Arthroscopy Society. And the main aim is to nurture local talent and bring them up, because I feel that everybody will deserve a platform to express themselves. As we have over 3,000 members, and I think probably another 3,000 who are not members, each one is extremely talented and deserves to showcase their skill and their talent. And what best but to have these regional or connect meetings in which we are able to showcase the same. I am going to urge all of you to be an associate or to be a member of the Indian Arthroscopy Society. And I would like to take this opportunity to thank very closely and with very strong and humble feelings the whole management of Preeti Hospital for having us over, their hospitality, their warmth, their infrastructure, their case selection, the facilities, the operating theatres, the auditorium, everything is absolutely par excellence, and one could not ask for anything more. So thank you once again for having me over here in Madurai, and again welcome again to this event of the IAS, and hope to see you more closely associated in the near future. Thank you very much.
Thank you, sir. We feel delighted to welcome.
No, I forgot to welcome President and faculty. That is the most important of my talk, I forgot. So I take this opportunity to welcome our Sachin Tapasvi. This is the first program for him as a president after taking over. He took over only in the April 1st of this year. Sorry, I forgot this aging process. And I welcome Mukesh Lada. He is all the way coming from Nagpur. They are all traveling for almost one day to take a pain and time to come all over from Maharashtra. Mukesh and Sachin, please give a big applause to them. And also I thank all other national faculty, our Subramaniam, Palnivel Rajan sir, and our Ramakant, Santosh, and Jyoti Prasad and Ranjit. Thank you. And also I welcome all the delegates. I mean, without you, this program is not going to be a success. I'm appreciating your effort in learning arthroscopy, the keen interest in arthroscopy, which I could see in your time and staying all together for this course and all the time. Thank you very much. I welcome you all.
Thank you, sir. We feel delighted to welcome our Professor and HOD, Dr. M. Chidambaram, sir, to say a few words regarding our academy.
Good morning, everybody. Respected President and Secretary of IAA and other faculty and dear friends. At the outset, I also welcome you all for this conference, and Preeti Hospital has been doing this CME programs and Preeti updates quite often. Due to the COVID and other things, we are not doing it, and we have just started with this, and we will have subsequent CME programs also. At this juncture, I like to say one thing. When I was doing my assistant professorship in Government Rajaji Hospital in Madurai is one for CME when we were postgraduates, and also was teaching faculty, and we were the first to have this arthroscopic workshop when Anand Joshi came from Bombay, and we had the first CME program, and Professor Devdas was in GH. And Madurai, we had the first arthroscopy workshop in the whole of India. So this is the thing I want to say. With these few words, welcome you all, and you all the best for the program, and good learning experience you'll have. And I thank the management also for having done the good work, and all the supportive staff. Thank you.
Thank you, sir. We take the opportunity to hand over certificate of our postdoctoral fellows. We invite Dr. Sachin Tapasvi, sir, to hand over the certificates. Dr. Harun Raj, who completed his postdoctoral fellowship in spine surgery in 2021. Dr. Silvaraj, who completed his postdoctoral fellowship in joint replacement surgery in 2021. Dr. Harish Kumar, who completed his postdoctoral fellowship in arthroscopy. Thank you, sir. We cordially invite Organizing Secretary of the CME, Dr. Prahlad Kumar Singhi, to wind up the inauguration session by giving a vote of thanks.
Good morning, respected and distinguished faculty and senior professors who have come, and all the delegates who have come from all the place down south. So the success of the CME is depends on the good faculty and the enthusiastic delegates. So we have both here today. So it's a great occasion. So I would really like to thank Indian Arthroscopy Society for having chosen Preeti Hospital for their outreach CME program. So I thank my mentor, my teacher, President Dr. Sachin Tapasvi sir, for accepting our invitation, and in spite of his all busy schedules, he has accepted to come down and put up a great show. I think so. It was an excellent live demonstration from him. So we are really thankful to you, sir. I am really thankful for Sundarajan sir for giving us this opportunity to do this CME. So we were able to do under his guidance this great show here today. So thank you, sir. So I would like to thank all the faculty, senior faculty. Vinod, are we giving a memento, sir? Huh? So at the same time, I would like to also give a memento as a token of respect, so that we can thank and in a better way. So I would like I request Shivkumar sir to give a token of memento to Sachin Tapasvi sir. Vangappa. Thank you very much, sir, for coming all the way here and putting up such a great show. So now I request Sundarajan sir, MC sir, to honor Sundarajan sir. I request K.N. Subramaniam sir, and I also thank him for accepting our invitation and coming for this event. I thank Palnivel Rajan sir for contributing as a faculty and for the CME. I thank Dr. Mukesh Ladda, who has come all the way from Nagpur for this one-day CME. So we are really thankful to you, sir. I thank Professor K.P. Sarvanakumar, sir, for having accepted our invitation. I thank Dr. Santosh Sahanand from Coimbatore. Santosh Sahanand is a dynamic surgeon from Ortho 1. He was past president of Cartilage Society. Come, Santosh. I thank Rajit Matthews from Vellore. Dr. Ramakant from Ganga Hospital, Coimbatore. Thank you, Ramakant. I thank Dr. Jyoti Prashant, who has come all the way from Kannur. Dr. Jyoti is not there, huh? Jyoti is there. Okay. Yeah. Okay, sir. So, thank you very much, sir, for having this. I thank Chairman Preeti Hospital, Professor Shivkumar sir, for giving all the infrastructure and facility for putting up this show, and the entire Department of Orthopedics, Professor M. Chidambaram, Dr. Somashekar, Dr. Sudeep Kumar, Dr. Vinod, Dr. Bharat Kumar, and our anesthesia team has supported us a lot always as they do us in our surgeries. Dr. Balaji, Dr. Suresh, and their entire team, we are really thankful to you. So, apart from the doctors, we had a lot of supporting team from of the Preeti Hospital who has done very hard work to what we are seeing here today. Because as sir was telling, it's almost 2-3 years we haven't conducted any meeting. So all these auditoriums had become very this thing. So we have all again renovated. So all the credit goes to our chairman, managing director Hema ma'am. So she is the backbone of this hospital, and so we thank you, ma'am, along with the entire supporting team of Preeti Hospital, the entire staff. I'm really thankful to you all. So I thank all the delegates, the senior professors who have come from nearby places and far places. So without delegates, we cannot have a good conference. I thank you all. So not least, we thank our sponsors for this event, Smith & Nephew, who have arranged all the equipments, and they have helped us in making this show success. So if I have forgotten someone, please, Jyoti Prashant, okay. So Jyoti, you can come and collect your memento. We thank Jyoti for coming all the way from Kannur.
We also ask Dr. Sachin Tapasvi sir To honor our organizing chairman, Dr. Shivkumar sir. Yes, sir. And to our organizing secretary, Dr. Prahlad Kumar Singh sir.
So I would like to invite Smith and Nephew team we thank and also we would like to give a small memento for the Smith and Nephew team. Thank you very much. So we go for the next session, the national anthem.
We request everyone to stand up for the national anthem. Thank you. We will start our second session of the day on multiligamentous knee injury. We welcome our chairperson, Professor K.P. Saravakumar sir and Dr. Somashekar sir to the dais.
Welcome back, everyone, for the post-inauguration session, multi-ligament knee injury session. First of all, I welcome Dr. Ramakant to talk on the topic on multi-ligament knee injuries, how to approach.
Good morning, everyone. First, I would like to thank Sundar sir, Dr. Shivkumar sir, and Prahlad for giving me this opportunity. and I'd like to share my experience of treating the multiligamentous knee ligament. So how to approach. So the whole agenda of this talk has been divided into four aspects: presentation, clinical evaluation, treatment, and the literature. So the presentation, multiligamentous knee injury most commonly happen following sports or road traffic accidents. The presentation will be acute, or patient can present chronic. They present with a frank dislocation or a transient dislocation, and then the self-relocated knee, or they present with the neurovascular injuries. So the common cause for multiligamentous is contact sports, where you can see that in this picture, the fellow player is falling on the medial side, causing hyperextension and varus stress on the knee, can lead to PCL, PLC, and ACL. Or when the fellow player falls on the lateral side, can lead to the ACL, MCL, and PCL injury. But in the road traffic accident, we cannot exactly comprehend the exact mechanism of injury due to position of limb, direction of force, velocity of fall, or a transient injury or a gross dislocation of the knee. So for the clinical evaluation, the emergency evaluation is very important to rule out other injuries when they present with high velocity injuries in road traffic accidents. Primary survey of the knee, and also in general the patient is very important, and secondary survey should be focused on the neurovascular injuries. So in the clinical evaluation, the primary survey on the whole is airway, breathing, circulation based on the ATLS protocol, and knee examination based on skin, soft tissue injuries, deformities. So acute presentation of knee, they can present with dramatic injury like this frank dislocation, or they present with a transient dislocation and then self-relocated knees, or they can present with the open dislocation, knee dislocation, or with the neurovascular injuries. So the knee presentation can be like this with the gross swelling subluxated knee, or they can present with a subtle soft tissue injury or minimal open injuries which is sutured from outside. They can present with like this clinical picture showing invagination of soft tissues with the knee dislocation. In this case, we can see that there is a puckering and a medial type 1 open injury with extensive soft tissue injuries, or they can present again with the open knee dislocation. So the casualty assessment is very important. What looks like a subtle fracture and subluxation might look very drastic in case of lateral view, where we know that popliteal vessels are relatively fixed in the adductor hiatus and the soleus, can lead to the vessel injury. So the neurovascular assessment is very important. The studies have shown that distal pulses may not be a reliable indicator, and intimal tear of the popliteal artery where the patient may still have the presence of pulse, and the ABI ankle brachial index less than 0.9 is an indication for CT angiography in all the doubtful cases, where once the joint is reduced, CT is a very useful tool in identifying the vessel injury because of the dislocation. So the immediate reduction is very much required in these devastating injuries where there is a circumferential loss of 360-degree loss of soft tissue and disruption. And in this case, patellar tendon was repaired and the knee was relocated to restore the vasculature. So here you can see that there is an invagination of soft tissue because of tethering of soft tissue underneath and the dislocation. And once the reduction is achieved, the tethering effect is gone, or the ligament reconstruction can be dealt at the later stage. So here there is a medial puckering of the skin is seen due to buttonhole effect. It is a sign for irreducible knee.
So the close reduction was tried, but was not successful, hence taken to theater, and then again the close reduction was tried, but because of puckering and extensive soft tissue, the reduction was not possible, so in which case we have to open it. And in this case we found that medial MCL and soft tissue got invaginated into the joint, causing the reduction difficult. Once they were removed, the reduction was possible and then immobilized with the external fixator. The MCL and the soft tissue capsule were repaired at this stage itself. So, and then this is a X-ray of the same patient, and ligament reconstruction can be dealt at the second stage. So in vascular injury proven patients, even after reduction, there is a suspected vascular CT angio will identify it. And in this case, it had a thrombosed popliteal vessels, which was completely excised, and saphenous vein graft was used for the anastomosis and restore the limb circulation to salvage the limb. And then external fixator was applied first, then the vascular repair was done, and the fasciotomy wound. So with this background of cases of acute presentation, after the acute phases passes away, and what are the surgeon's dilemma in dealing with such multiligamentous injury, what classification to follow, how do we proceed, when to plan, single stage or double stage, cruciate first or collateral first, repair or reconstruction. So at the end of the talk, I hope to make it very clear for these decision-making dilemmas. Once the joint is reduced, the ultimate goal is to attain the stable and mobile joint and to reassess the neurovascular status, brief period of immobilization, gain the movements, and then plan for definitive surgeries. Schenk's classification is a very simplest anatomical classification, 1, 2, 3, 4 injury, KD 3, 4 injuries. It not only gives the what structure is involved, but also the higher the grade, the greater is the severity of the injury. And ACL, PCL, MCL is the most common, that is KD3M type. And this gives a demarcation where the lesser severe injuries can be dealt at a single stage, whereas the higher injuries need to be operated at the multiple stages. So the timeline in the management would be like, once the knee dislocation is there, the joint needs to be reduced, then the 2 to 3 weeks of brief period of immobilization for a soft tissue to heal, and if it is needed very unstable at the primary setting, we can put an external fixator, and then the external fixator might be removed, and then to gain the movement within 1 week with good physio. And then the first thing is to restore the central stability by ACL and PCL reconstruction, then the collateral ligament can be attained. So that for the single stage for lesser severe 2 ligament, 3 ligament injuries. So let's see some case examples where the patient presented with pain and swelling and inability to weight bear 2 weeks, sustained a bike accident. He was treated with knee brace and medication, and then this was his presentation at 2 weeks, where they shows gross laxity, where both anterior and posterior as well as the medial laxity was seen. Excuse for that. Sorry for that. That the patient had MCL, femoral side, and ACL, PCL. Standard arthroscopy was done, and that is the amount of medial opening we can see. It was about 15 to 16 mm medial opening. The step is to first drill the tibial side PCL, then femoral side PCL, then the ACL femoral side, and then the tibial side ACL. That is a sequence of tunnel drilling, and then the graft harvested from both the sides and then inserted into the respective tunnels. This is a final picture after ACL and PCL reconstruction. What is important here to note is this is an arthroscopic valgus stress view. We can see that there is about 15 to 16 mm of opening with the arthroscopic valgus stress testing, and once the ACL and PCL is done, the amount of laxity reduces by about 40 to 50%. Here we can see it's just about 8 to 10 mm. So this is how we can know the amount of laxity before the ACL PCL and the ACL PCL. So in this case there was a femoral side tear. Here we see that opening of the retinaculum first and then expose the femoral side MCL tear, which can be clearly seen. And this is the identification of posterior POL and the posterior capsule which was torn, and also the MCL femoral side tear was identified. So then the suture anchor is inserted. First POL and the capsule is repaired with the suture anchor, and the same sutures can be taken on to the MCL to repair the MCL side femoral side tear as well. So this is the repair which is being done, and then the retinaculum layer can be closed, and if still the persistent instability, then the PES also can be incorporated into the repair. So depending on the severity of injury. So this is the arthroscopic valgus stress view with the 5 mm scale. We can see the amount of opening after ACL, PCL and the MCL repair. In the same case, it just reduces about 4 to 5 mm. So the next case, this patient presented after sports injury 2 months after injury, but he was treated by a local bone setter where the local bone setter reduced his knee and did oil bandages. The patient also noticed foot drop after 2 weeks after the injury, but he presented 2 months after the injury. So this was his anteroposterior laxity, both grade 3 anteroposterior laxity, and this was his lateral side opening. There was a gross grade 3 laxity on the lateral side as well. And this is a gait of the patient where you can see he walks with the high stepping gait, and the patient is also not able to do a dorsiflexion of the ankle because of the common peroneal nerve injury. So this was he luckily had this old x-rays, he brought it to us. So it showed the knee dislocation. This was reduced by a local bone setter, and then the oil bandage was applied. This was his presentation to our hospital 2 months after the injury, and the MRI showed clear-cut ACL, PCL and the LCL avulsion. And this arthroscopic video shows gross anteroposterior laxity as well as the amount of opening. We can see it from the lateral side. And in this case, the popliteus tendon was intact, and it was mainly the avulsion of the LCL and the biceps femoris. So arthroscopic examination again showed about 14 to 16 mm. This is a 10 mm scale which is inserted, and we can see the amount of opening before the ACL PCL reconstruction. So the standard ACL PCL reconstruction done, the same sequence, and the final picture after the ACL PCL reconstruction. And after ACL PCL reconstruction, we did check the amount of lateral side opening. It was about 10 mm, where the scale is being introduced, and the scale is introduced, and you can see it is still about 10 mm. From 14 mm, it has come down to 10 mm. So we went ahead, he had a common peroneal nerve and the oil bandages. There was a lot of fibrous tissue around the common peroneal nerve which was carefully dissected, and all the fibrous tissue was relieved for whatever benefit the patient would have it, but the nerve was intact. And we did Larsen, since it was 2 months old injury, Larsen sling technique was used. The graft was inserted like a sling in the fibular tunnel, and then fixed into the femoral isometric point with a bio screw. So here we can see that the ACL PCL, and then we can see the amount of opening reduced to just about 4 to 5 mm of lateral opening. So the philosophy of management is cruciate. First policy will restore the central stability, and then the collateral can be attained. We have published our results of KD3M, KD3L comparison and the analysis of various predictive factors and the outcome of single stage reconstruction in Orthopedic Journal of Sports Medicine, Canadian Journal. And this is our flow chart from our series. We had 45 patients, and all the acute cases was dealt for the repair, and for the chronic cases the reconstruction was done. And the sequence is the PCL and ACL first will restore the anteroposterior stability, and the central stability will provide some amount of mediolateral stability as well. And less than 3 weeks we can go for a repair, and greater than 3 weeks reconstruction would be recommended. From the literature point of view, the Schenk's classification create 3 ligament, 4 ligament, or with the fracture dislocation have high chance of neurovascular injuries. So repair versus reconstruction, the same thing. The E4 guidelines recently have published. The repair is recommended for less than 3 weeks, and for more than 3 weeks reconstruction is preferred due to lack of integrity of soft tissue and poor definition of the soft tissue. So acute versus staged always gives better results than the acute from all these systemic reviews. So to simplify the approach, knee dislocation, reduce the joint. If no neurovascular, then single stage can be taken up for less severe, like 2 ligament, 3 ligament, and double stage for higher grade of KD. And the neurovascular, first reduce, then exfix, then vascular repair, and then the ligament reconstruction can be staged after 6 weeks or so. And for puckered skin, we have to reduce the joint, and then exfix has to be applied. And the fracture dislocation is very complex injury. It has to be dealt in a multiple stages. Thank you. And once again, invite all of you for IAS in September. Thank you very much.
Ramakant, we'll keep the discussion at the end of session. Thank you very much.
Thank you.
Now, I'd like to request Dr. Sachin Tapasi to speak about clinical evaluation and treatment algorithm for MCL injuries.
Thank you so much, Somasekhar. And I'll be speaking about MCL injuries. Of course, if you want to know more about MCL injuries, you have to be with us in September at a place which is about 4 hours away from here. Sundar told me there is Dindugul for biryani on the way, so that was his pit stop. And you should all register and be with us definitely in September, and look forward to welcoming all of you personally. So MCL injuries, all that you need to know, first you need to know where the MCL is. So the MCL essentially lies in your layer 2, which is the superficial MCL, and your layer 3, which is the deep MCL and its associated structures. So when you look at the MCL, this is a cadaveric view of the MCL. You can see it's a flat shaped ligament which is on the posterior-medial aspect of the tibia. It's about 6 centimeters, inserted 6 centimeters below the joint line, and is inserted at an area which is slightly proximal and posterior to that of the medial epicondyle. The white one is the adductor tubercle, and the green pins will show you the insertion point of the MCL. The yellow is the gastrocnemius tubercle, to which the gastrocnemius is attached, and the red is the condensation of the posterior medial capsule, which is called as the POL. The POL inserts on the tibia at the level of the direct arm of the semimembranosus, and proximally it will insert on that red dot which I have put, which is essentially an area which is close to the gastrocnemius tubercle. As you extend the knee, the POL becomes taut. As you flex, the POL becomes loose and lax. And these are how the two ligaments of the MCL complex work, the superficial MCL and the POL. The MPFL is another ligament which is closely adapted to the medial side of the knee joint, and it gets its insertion in the crater or the groove which is between the adductor tubercle and the medial epicondyle. So essentially, again, you have the superficial medial collateral ligament, which is the medial restraint in flexion, and a secondary restraint to anterior tibial translation. Ramakant in his previous talk did show us that when you reconstruct the ACL, the medial opening decreases, and when you go ahead and further do the MCL, then your stability for the ACL improves further, and the posterior oblique ligament is the medial restraint at extension. So both of these structures, which are very important, are the ones to be looked at, and that is why when you examine a patient clinically, if there is opening at full extension, it means that the POL is ruptured as well as the ACL is ruptured. If you have a stable knee at full extension but opening at 30 and 40 degrees, that means that the superficial MCL is torn and the POL is intact. So thereby you can plan or understand what sort of repair or reconstruction that you need to do depending upon a simple clinical examination. The usual modality is a valgus stress, and very often it is combined with an external rotation type of injury, which then leads to further cruciate damage. So plain valgus overload will lead to an isolated MCL. When you have that associated with a rotational injury, then it will usually involve one of the cruciates, which is what is required. An MCL injury is more commonly seen than what we feel it is. And this paper by Andy Williams, which was published last year, shows that almost about 2/3 of patients who are undergoing ACL surgery will have some form of injury to the medial complex, and of those who have it, about 2/3 will have an injury to the superficial MCL, and the remaining 1/3 will have an injury to the deep MCL. It's time that we relook the classification of MCL injuries, and if you look at a more practical way of looking at it, we need to find out which are the ones which are more important and which require surgical treatment and those which do not. So definitely those which are the femoral avulsions or the type 2s, they require surgery. The mid substance, if they don't open too much, you can conserve them or you need to repair them and reconstruct. And then you have the distal detachments, and you have the buttonholing type of injuries, which are the type 4 and the type 5, which are the ones that you need to consider when you look at these MCL tears. So grading in terms of grade 1, 2 and 3 is a simple grading which looks at the amount of opening, but when you want to look at it holistically in terms of the morphology, the clinical findings and the MR findings, you need to pay a bit more attention to the various bone marrow edema patterns. So there's definite consensus that all grade 1 and most grade 2 injuries will be treated non-surgically, but some grade 2 and grade 3 require surgical treatment. There is still no consensus as to how you treat them non-surgically, but what is accepted over these consensus guidelines that were published last year is that most of them will require a restricted range of motion for the first 6 weeks, which means you allow 0 to 10 or 0 to 20 for the first 2 weeks, you increase that to 60 for the next 2 weeks, and then you allow further range of motion in the last 2 weeks. Again, what about weight bearing? If your knee is in valgus, then partial weight bearing. If it is in varus, you can allow them full weight bearing with a brace, and the brace has to be used for at least 3 to 6 weeks is what we use as a consensus. Acutely, you need to go in if there is extensive medial disruption, as what Ramakant showed, if there's a displaced medial meniscus tear, if you have a Stener lesion, or if you have a bony avulsion. So this type of an appearance in which there is dimpling on the medial side should bring your attention to a condition in which the whole of the MCL as well as the capsule is sucked inside the joint, and these dimpling requires urgent open reduction, removal of that intra-articular flap and repair again. The next is what is called as the Stener lesion, in which what you find is that the MCL tears and goes above the pes, and the pes which is sitting in between the MCL and the tibia does not allow the MCL to stick back again. So if you see a Stener lesion on an MR scan, you need to go ahead and do an open surgery wherein you can retrieve the torn tibial end of the MCL underneath the pes and reattach it back to the tibia, which makes it again very important. So this, we have a 32-year-old lady who's one day following an injury in which she's got a KD3M, a grade 3 ACL, PCL and MCL. You can see that there's opening at both 0 and 30 degrees, and she was opted for a 2-stage reconstruction. Whenever you see the presence of this kind of bony avulsion, I think these imply very high velocity injuries. These are these so-called rim fractures which occur, and they will usually denote that it is a devastating type of injury. So the repair, an acute repair, is going to be a layer-wise repair. You go in, you expose, you start with layer 3, which is the meniscotibial and the meniscofemoral area. Here you can observe that there is a meniscotibial tear. The meniscus is attached properly to the femoral side. You first go ahead and isolate that. This is the small bony avulsion, which is one that has come off the POL from the tibial side. Again, that needs to be repaired. And then you start a layer-wise repair in which you first repair layer 3, which is the meniscotibial ligament, with the help of suture anchors. Once you've done that repair, then you proceed to repair off the POL, and then you go ahead and repair the superficial MCL in a stepwise manner so that you can get a good stable repair. It is always useful that you don't stop only at repair, but you also do some form of augmentation or reconstruction as well. And the reason being is that if you do a repair alone for a mid-substance tear, 1 in 5 will stretch out and will give you a poorer clinical outcome. So what you need to definitely do is that you need to do an augmentation, and if you do an augmentation, then you will have good results of the same. What sort of augmentation? You can take a CEMITI graft which is left attached to the tibia, take it up to the femoral side, use a suture anchor or use a bony staple, and then bring it down to reconstruct both limbs of the MCL, which means you can reconstruct both the superficial MCL as well as the POL, and you can fix them with suture anchors or whatever fixation devices you want. So adding a check rein makes it all the more better. If you happen to have a femoral or a tibial avulsion, then you can do a direct fixation either with the help of screws or staples or suture anchors, depending upon the preferred method of fixation and the size of the fragment that you have. It's always preferable to do early surgery rather than delayed surgery, because early operative treatment will always result in improved outcomes as compared to non-operative or delayed surgery. What about chronic MCL laxity? If you have someone who has a chronic lax MCL, this is a 14-month injury with a grade 3 ACL MCL with full range of motion, he is the one who will require a MCL reconstruction. An MCL reconstruction is done with the help of free graft, and what you need to look very closely at the patient's MR scans. You can see that there is a disrupted ACL, there is a posterior medial meniscus root tear, and you have a completely stretched out and disrupted MCL which needs surgical treatment. Stress X-rays are the standard of treatment. When you do a valgus stress X-ray with the knee at 30 degrees, whenever you have an opening which is more than 4 millimeters, when you compare side to side, it will suggest the presence of a complete superficial MCL and a POL repair. So don't forget to make stress X-rays, will be one of my take-home messages. And then as you go in through the MR scan images, you will observe. When you put your scope in, you will see something like this, which is a drive-through sign. Again, very well illustrated in the previous talk, in which you have abnormal opening or gapping of the medial side. How do we go ahead and fix this? Well, you bring this picture in your theater. I think it's very important that you bring this picture inside your operating room, and this is what you need to look at, because it shows which or what are the insertion sites, so that you don't forget as to where they should be. So the red is the superficial MCL. The insertion point on the femur is 3 millimeters proximal and 5 millimeters posterior to the medial epicondyle. The distal insertion is 62 millimeters below the joint line and 12 millimeters below the joint line. The POL is attached at the level of the gastrocnemius tubercle, and on the tibia it is attached to the direct arm of the semimembranosus. And this is what you want to do. You want to do a two-tailed reconstruction to restore both the superficial MCL and the POL, and by doing so you can achieve a good stable outcome. The way you do it is to take a single strand of the semitendinosus, split it into two, 12 millimeters and 16 millimeters. You then drill with a 4-5 cannulated drill bit, so that you create these blind sockets. You will enlarge these with the help of a 7 millimeter femoral drill bit. So essentially you are creating 4 sockets at the 4 insertion sites, and once you've made these 4 sockets, You then go ahead and start passing your graft. So it's the same process, one after the other. You take the first limb of the graft, fix it with the help of a bio screw, and then at full extension, you want to apply a medial closing force and reconstruct the POL. Then you'll go ahead and reconstruct the superficial MCL, again using the same principles. You want to put in your screws, and at 30 degrees of knee flexion, you want to go ahead and then add the second fixation. So this is how your MCL should look. The POL becomes taut in extension, and the superficial MCL becomes taut as you start flexing the knee. This is very quickly, so I'll just skip through this because, in interest of time, I'll just skip through this video, but I'll just bring it right till the end, which is what we want to see. Yeah, somewhere there. And once we've done your MCL reconstruction, you will observe that the superficial MCL is taut in flexion and the POL is lax in flexion, and as you move your knee towards full extension, the reverse or the contrary occurs, and this is what you should see at the end of your surgical procedure, a completely abolished sign. We wrote up on our own series of 34 patients who had been followed up for more than 24, at a minimum of 24 months, and we did demonstrate that the IKDC scores did improve and the valgus opening on a stress X-ray was reduced back to being normal again, which was published this year in the Gesta journal. Again, the recommendation is that if you're doing a concomitant ACL and MCL reconstruction, avoid ipsilateral hamstrings for the ACL, either go to the opposite side or use a BTB or a quad tendon graft. Another important paper which I think one must look at is this series of over 19,000 patients who were enrolled in the Swedish National Knee Ligament Registry, and what they showed is that if you treat the MCL non-operatively and only do an isolated ACL reconstruction, then the results are far more inferior. So if you have an ACL MCL injury, please make sure that you treat both of them and not just do the ACL, because when you fix only the ACL, you will find that a bit of laxity on the medial side will decrease, and it's important not to leave these patients lax as ever. So thank you so very much, and I'm also going to invite you to Pune, which is going to be your next meeting, which is going to be on the 29th to the 31st of July. We'll have 3 days of good surgery, good discussions, good case discussions, and I hope to see all of you then. Thank you very much for this opportunity.
Thank you, sir, for your wonderful presentation. Next, I call upon Dr. K.M. Subramaniam to talk on clinical evaluation and treatment algorithm for PLC injuries.
Good afternoon. After the extremely fantastic talk from our president, my talk has been sandwiched now. So, thank you, Praglad, for inviting me. And he has asked me to talk about posterolateral corner injuries. So first of all, let me thank Indian Arthroscopy Society for organizing such a good conference, and thanks Preeti team, and thank you Praglad and Professor Shivakumar sir and the whole team. Posterolateral corner has always been a little doubtful for everyone, because everybody gets confused when it comes to posterolateral corner, and it has been shown by history itself. It has been absent in some textbooks, not clear anatomy in vivo. So it has always been called as a dark side of the knee joint. So let us try to make it clear a little bit. First of all, if you go through the layer of the posterolateral corner, textbook mentions 3 layers: layer 1, layer 2, layer 3. And layer 1 will start from ITB and biceps tendon. Layer 2 will have patella retinaculum. Layer 3 will have all the important structures like LCL, popliteus tendon, and PFL. For us to be little concise, things that are very important are these 3 only, because these are the primary static stabilizers, which are popliteus tendon, lateral collateral ligament, and popliteal fibular ligament. The main reason behind this, these are the one which we are going to reconstruct when it comes to the stage of surgery. We are going to only reconstruct only these three structures when it comes to the stage of surgery. So how do I assess the PLC injury is, first thing is we have to identify whether it's an acute injury or a chronic injury. An acute injury will be one which is occurring within the less than 3 weeks time, and a chronic injury is more than 3 weeks duration. This is the first thing you need to determine. In the acute injury, let's take forward through it. Isolated injury of PLC is, I have not seen very much commonly. In the textbook it mentions about only 5%. So you don't come across a patient just coming with an isolated PLC injury. You always come with someone with a ACL PLC or a PCL PLC and LCL PLC like that. So these are isolated things are not going to occur very commonly. A severity of injury that you have to identify first. In terms of severity, grade 1 means just tenderness, grade 2 means slight opening of the joint, and grade 3 is the full opening without any endpoint. This is a common classification for most of the ligaments, and this applies to posterolateral corner also. And we want to do treatment for those patients who are having the grade 3 injuries. First is dial test is the important test that we do across for the PLC. We do at about 30 degree and 90 degree. At 30 degree, if it opens up more than 10 degrees by external rotation, it's significant for PLC. If at 90 degree it opens up, then it's significant for PCL as well as PLC together. This is the basic test that we all have to be aware of for a posterolateral corner injury. One has to remember that posterolateral corner is the primary restraint for external rotation, secondary restraint for varus stress. LCL is the primary restraint for varus and secondary restraint for external rotation. So both are equally important. So let's see this EUA of a person who has got a LCL as well as PCL and PLC injury. Sorry. So this patient has got a varus laxity where he is demonstrating LCL laxity, and he also has got a posterior sac positive or posterior drawer positive. He has got PCL is also gone, and external rotation is very farly gone. So this is a combination, typical combination of a LCL, PCL and PLC. That's what we commonly come across. Because EUA is a final determinant factor for a patient who needs surgery. Whom to operate is the next thing to decide. Grade 1 and 2 where there is just tenderness or a partial rupture where there is a end point, you are not going to operate them because they need conservative management only. Only those who are coming with a grade 3 or with associated ligament injuries are the one we are going to operate. In case of confusion, you can do a stress X-ray to identify whether there is opening up of the joint. Literature says that if more than 2.7 mm opening up, then it can be a LCL injury only. If it is more than 4 mm opening up, then it indicates LCL plus PLC injury also. This is a typical literature finding. You can use it. I don't do it for all the cases, but in cases where there is a doubt, then you can use this as a maneuver to identify whether this patient needs surgery or not. Posterolateral corner reconstruction, which we take it, there are only 4 things you need to know about. Where these 2 ligaments are, the LCL and popliteus tendon is attached, and where the PFL is. These are 3 things that you need to know about in terms of surgical wise, because ultimate aim for us is to do a treatment for them. For treatment wise, we need to know all these 4 points. Okay. So 4 points that we need to know about is the attachment of the popliteus tendon in the femoral side, attachment of LCL in the femoral side, and attachment of the LCL on the fibular side, and popliteal sulcus in the tibia. These are the 4 points that you need to know about. And typically they are located in certain specific anatomical landmarks. For example, LCL femoral attachment is at the just proximal and posterior to the lateral epicondyle, and popliteus femoral attachment is about 15 to 18 millimeter distal to the LCL attachment. That is a typical attachment. And for fibula, LCL attachment is about anterolateral to posterior medial is a typical trajectory of the LCL tunnel, and it is attached about 28 millimeter from the fibula styloid, or from the head it's about 8 to 10 millimeter. That's a typical attachment. And for the popliteal tendon attachment at the posterolateral part of the tibia, it is about 1 centimeter medial to the fibular attachment. So that is popliteal sulcus over there. That's where your attachment for the popliteus tendon is. So salient steps for PLC reconstruction. First is you have to identify the common peroneal nerve and make sure the peroneal nerve is well preserved. That's the first step. Because without identifying peroneal nerve, it will be very, very difficult for us to make sure that we are not going to have the foot drop at the end. So because so just do that one first and then start dissecting for the fibula tibia, and then show a video of salient steps where you drill the first you drill the posterolateral tibia where you have to go. So here what we are doing is I am trying to drill the tunnel on the posterolateral part of the tibia and use a femoral aimer for the PCL jig, and you can use it and do the posterolateral tibial sulcus. Next is drilling for the fibula tunnel. So from anterolateral to posteromedial is a rough landmark for the fibula tunnel. It's about, they call it as champagne glass appearance, where the head becomes neck. That's where you have to start drilling a tunnel and make a tunnel for that. And for the femur, you need to have two landmarks. One is at the lateral epicondylar just proximal and posterior, another distal about 15 mm from there. So two drills for the femoral tunnels, one for the popliteus tendon, another for the LCL tendon. So you are using usually hamstring graft. In cases where hamstring is not available, they are started using peroneus longus graft now. That is the second option for me, in cases where it is not available. So two tunnels for femoral side, one for LCL and another for the popliteus tendon. So outcome of reconstruction, I am not going to go in detail about, because this talk is not about reconstruction techniques, it's about making an algorithm. So if you just do repair, the chances of failure is very high. The current dictum is as for MCL, for LCL and PLC also, in acute cases also you try to go and do reconstruction along with repair. So you try to do misceptions repair and also do augmentation also at the same time. That has got a higher chance of success rate. Which situation you will consider repair is only in the cases where there is avulsion fracture of the capsule or avulsion fracture of the head of the fibula. There you can go and do anchor fixation repair. Doing an intrasubstance repair is not going to work very well. Whenever you do intrasubstance repair, try to do augmentation also. In cases where you are doing an avulsion fracture, then you can go and do repair with the anchor, that will work well. So that is a dictum for you. Now I want to go and talk about chronic PLC insufficiency. This is a totally different ball game. Acute tears are different, chronic tears are different. In chronic tears, first thing you have to look for is alignment of the knee joint. That is very important. See whether the patient has got a hyperextension or a varus deformity. If they are there, that should be assessed first. So for example, I'll just give an example of this patient who has got who is a 42-year-old, the PLC insufficiency. He already has got a varus malalignment also. Along with that, he has also got a posterior translation of the tibia. If you see the tibia, it has gone little posterior to the femur. So typical patient will have a varus malalignment and also the posterior translation of the tibia. Next thing you need to know about is the posterior tibial slope. These are the four ways of measuring posterior tibial slope, where you can take anterior tibial axis or mid anatomical axis or posterior tibial axis or the fibular axis. Commonly taken is the anatomical tibial axis. So if we look at the patient which I showed you earlier, the posterior tibial axis, the anatomical axis, posterior tibial slope is around 3 degrees only. Whenever a patient has got a reduced tibial slope less than 5 degrees, it means they are having a decreased posterior tibial slope. So actually this patient has got three issues. One is the posterior translation of the tibia, another is a decreased posterior tibial slope, and there is varus malalignment. There are three issues that we need to address. The first thing is that if we convert the posterior translation of tibia by increasing the posterior tibial slope, if we make it to align well, the PCL or PL's posterior lateral structure, which are in the posterior lateral aspect, which are lax, will become tightened. So just changing the posterior tibial slope itself can address the PCL insufficiency or PLC insufficiency and make it tight. But this is the basic concept, one has to be aware of it. So how much to correct it is the next question. For example, if this patient has got 3 degree posterior tibial slope now, if I correct 1 mm, then it can cause 2 degree of adjustment of the tibial slope. So alpha is the how much you need it, beta is the angle of correction. That's what is the general dictum. So this is the typical paper which says that if you want 2 degree correction, you need to make a differential correction of the anterior height for about 1 mm. Then you can get 2 degree correction. So if in this patient, all patients who are coming for chronic PLC insufficiency with varus malalignment or posterior tibial slope alteration, they will need X-ray, MRI and CT scan. This is must. Without doing those, we cannot do surgery at all. So for example, this patient had a scanogram, and then what we are doing is osteotomy, high tibial osteotomy with differential slope correction also. High tibial osteotomy by itself will cause some decrease in posterior tibial slope. If you do along with, so this is the way how you try to widen the proximal medial tibia and slowly widen it according to the need of correction. If you need to correct 10 degree, you need to open up 10 mm. If you want to correct the slope, you have to differentially correct the anterior and posterior side gently, then you can actually achieve that posterior tibial slope correction also. So this is gradually you have to correct without breaking the opposite cortex. If you break the opposite cortex, the chance of non is a little higher also. So correction wedge is available where you can try to graduate. These wedges are available to the depth of about 5 mm, 7 mm, 10 mm also, or even 12 mm also. If you want differential correction, I will put 11 mm wedge on the anterior side and 7 mm wedge on the posterior side. So you will get slightly more anterior opening, hence the tibial slope will slightly increase. By that way you can actually correct the posterior tibial slope also. So this is the way you address it. So correction wedge anteriorly 11 mm, posteriorly you keep 7 mm posteriorly. So by that you can achieve about 8 degree of correction. So for example, see this patient where we have done the correction surgery for a patient who has got a PLC injury, who has got varus malalignment and also the posterior tibial slope reduction. I have done the osteotomy. After doing osteotomy, you can see that posterior tibial slope is corrected to from 3 degree to 11 degree now. So by that you can see that translation of posterior tibia has also been corrected. See, earlier the knee was having posterior translation. Now the posterior translation is corrected. So this is one way of managing the chronic PLC injuries. So 4-month post-op, the patient is having a good range of movement, and another patient who has got 6 months post-op with good posterior tibial slope correction. So is PLC reconstruction needed in chronic PLC insufficiency is a question mark. So in chronic cases where there is malalignment, you don't need PLC reconstruction at all. If you do the alignment correction surgery itself, they might be okay. There are only small group of patients, but from Laprate's paper it says about 38% of patients did not need surgery at all, second surgery at all. Even though they have a ligamentous instability, if you do the correction of the slope and by doing osteotomy, they may not need a second surgery at all. But in cases where there is still laxity after doing correction of bony correction, then you can go and do a PLC reconstruction at about 3 months stage. Occasionally I have done both together. In only one case I have done PCL, PLC as well as correction osteotomy also together. So take home message is, for acute grade 1 and 2 tears, there is no need for surgery at all. So you can only do conservative management for that. For a grade 3 tears, you can do PLC repair, but repair alone does not work. So mixed substance tears, you always do repair and reconstruct together. So it's an augmentation procedure always. In cases where you can do acute repair, is only avulsion fracture where I do repair. So for example, like fibular head avulsion or a capsular avulsion, you can put anchor and repair it, then you can have good results. All other cases are acute cases, you are still doing repair plus reconstruction together like augmentation. In chronic tears, if there is no deformity, then you can still go for a PLC reconstruction alone. In chronic tears with deformity, then you should think about doing a slow osteotomy and also staged PLC reconstruction if needed. After 3 months, do assessment and see whether the patient really needs or not. If they don't need it, they don't need surgery at all. Thank you very much. So I would like to again emphasize that as a part of IASCON committee, I want every one of you to register for the IAS conference on 15 to 17 September. We need more registration from all our people. Tamil Nadu Arthro Society also encouraged that. You also should attend the conference and make use of it. Thank you very much.
Thank you very much, sir. Now I'd like to request Dr. Prahlad to speak about PCL reconstruction.
Good afternoon, everyone. So I think so far we had a very great session. So we have covered the major ligaments of the knee joint. So the two collaterals, we have finished medial side, we have finished lateral side. In the morning session we had anterior side, anterior cruciate. So I'll be discussing on posterior cruciate ligament. So we all know posterior cruciate ligament is a very strong ligament among the all, and it is a very critical structure which imparts greater stability to the knee joint. we have seen Ramakant stressing about the importance of PCL in multi-ligament knee injury. Yeah. So here I have tried to stress upon the surgical steps more. So we will just see how do we reconstruct PCL today. So before doing that, we would like to know the anatomy of PCL. So PCL is again the strongest ligament. If you see here, it is a dumbbell-shaped ligament. It has a unique anatomy where if you see it is made up of two bundles, the anterolateral bundle and the posteromedial bundle. The anterolateral bundle, they have insertion at the femoral side. It is a very broader insertion. It is 3 times that of the diameter here. So it is, if you see here, it is on the anterior and superior aspect of the medial femoral condyle. And also on the tibial side, it has a very broader insertion. It is 1.2 centimeters, that is 12 mm below the articular cartilage of the tibia, that is the champagne glass edge here. So, overall PCL is a very complex structure, more stronger structure, which is very difficult to reconstruct anatomical PCL. So we know it imparts greater stability by resisting the posterior tibial translation, and it is most often injured during the dashboard kind of injury, or whenever there is an hyperflexion injuries, or sometimes in the extension injuries, or when there is a direct blow on the anterior aspect of the tibia. So isolated PCL injuries are very rare, but still they can happen during the hyperextension injuries in the sports. But we most often see them in associated with the other multi-ligament injuries. So high index of suspicion for these injuries is very important. Sometimes a patient might have sustained a dislocation and he has reduced himself, and he will just come with a bruise on the anterior aspect. So it is very important you to suspect these kind of multi-ligament injuries, and neurovascular examination is very critical in these kind of injuries. So the test related to posterior draw, PCL stability, or the posterior drawer test, the tibial sag sign, and the quadriceps active test. These are the 3 most important tests which are usually done for the PCL, apart from the internal rotation in supine. So once you have clinically assessed your PCL injury, the radiographs gives us a lot of information. Apart from the scanogram and the standard anteroposterior view, we need to take the stress views. The stress views can be taken by giving the posterior drawer as it's done here. Also you can do a kneeling X-ray. So what are we going to assess here is the posterior tibial translation. So the posterior tibial translation, based on this translation, we can classify the PCL as a grade 1, grade 2 and grade 3 injuries. When the amount of translation is more than 10 mm, it is called grade 3 injuries, where we really need to do some kind of intervention. So the MRI and CT has a very significant role in assessing these kind of injuries. So MRI will not only assess the PCL, but also will assess the associated injuries. CT sometimes can help you in assessing the avulsion fractures, as we saw Subramaniam sir was telling about fixation of these avulsion fractures. So, and also Tapasvi sir was showing the avulsion of MCL. So these are certain avulsion injuries which can be picked up very well on the CT, so it is very important. So we'll just discuss a few cases here. So this 80-year-old gentleman who sustained an road traffic accident, and he had a anterolateral kind of knee dislocation, which we did a close reduction for him, and it was unstable. So we got an MRI done which showed there is a MCL tear, ACL and PCL. We did an MCL repair for him, and this patient was fine. We treated conservatively his PCL by giving the PCL brace. So definitely it is not necessary that you operate all the PCL injuries. So certain cases, you can definitely treat them conservatively. But this is another scenario, a young chap who sustained posterolateral dislocation, but his vascularity was good, so we did a MCL stage 1 repair, and then we did a ACL PCL reconstruction, and this patient had a excellent outcome. So you can do a stage procedure, or you can do a primary single stage procedure. So whenever you are planning to do a single stage procedure, PCL should be the first to be addressed. So this case is again a 30-year-old labor for whom we operated 3 years ago. So this patient had sustained 3 years ago injury. So we did ACL, PCL and PLC, and he was back to his work, and he did all kind of regular work. And again he sustained after 3 years similar injury, and he presented to us with this scenario where he had again a multiligamentous injury. So we did a stress X-rays for him, and posterior stress, varus and valgus stress. So we saw that there is again there was a varus opening for him. So he got an MRI which showed that there was a contusion because of the fresh injury and also the stretching of the graft. And his tunnels, we did a CT to assess his tunnels, which showed they were reasonably good. So bone quality was good. So we decided to do a procedure for him, again reconstruct. So this was the kind of varus instability he had, and also anteroposterior instability. So we will go through what will be the position, how we do the portal placement, what graft options, and how we prepare the tunnel, and how to deal the killer turn, and how do we fix. I usually do this in supine position in 90 and 110 degrees flexion. We keep 2 bolsters. The opposite limb can be dropped down, or you can use a lithotomy so that it doesn't intervene when you are taking the medial portals. So these are our workhorse portals, the standard anteromedial and anterolateral portal. So I usually prefer to take them closer to the inferior pole of patella and closer to the lateral patellar tendon, so that high anterolateral and medial portal will give us better notch view and also avoid the fat pad. So apart from that, we have several portals. Getting a proper portal is important here. So if you don't get a proper portal, then the entire procedure we keep on struggling. So it is important you get a good post portal, which can be done by 2 techniques. That is the illumination technique, switch off all the light and bring your scope through the notch and illuminate and find, or you can do by the tactile technique by identifying the soft spot and get your needle trajectory in a perfect position. If you can also have 2 portals, superior and inferior, lower posteromedial portal, high and low poster, so that you can do working and visualization through these portals. Anterolateral, posterolateral portals are also important. You can comfortably take them by feeling the soft spot, and you can use it as a working portal for the better visualization of the posterior compartment. So transseptal portal, you need to clear the septum and have both posterolateral and posteromedial as a working portal. So since we used both the hamstrings in the previous, so we harvested his quadriceps with a bone plug, and we took his peroneus graft. So we got good robust graft. Your graft is very important. You should have at least 10 to 11 mm, 10 mm for the PCL. So we had a good 9.5 for the ACL, and this is again peroneus for the PLC. So I'll rush through the technique of harvesting the graft because there is a next talk. So safety incision is always better to take in the initial practice, a posteromedial incision, and you feel the posterior aspect if at all you are in doubt. So we will just go, the landmarks for the femoral tunnel will be, if at all you are creating a single bundle or double bundle, accordingly you can plan your tunnels. So the anterolateral bundle will be the major bundle if we are doing a single bundle reconstruction. It is as closer superior and anterior to the medial femoral condyle cartilage. So you can do this by outside in technique, where you have the jig for that, and you can do by inside out technique as we saw today. For the ACL, you can use this technique for doing the PCL as well. So for tibial tunnel, you have to clear your posterior aspect. You should have a very good visualization, and it should be at least 12 mm visualization should be there. So you have to get a proper visualization so that you can bring in your PCL jig and you can see the entire posterior aspect. Minimum 12 mm you have to come down at the champagne glass drop-off level and get your tibial tunnel. So the trajectory will be anteromedial to posterolateral. So once you have done your tibial tunnel, the graft passage, the killer tunnel will be again a major issue here. So we will see how we will do that. So fixation of the graft can be done by interferential screw, by using metal screw if at all you are having a bony plug, or bioabsorbable for a soft tissue. Also you can use a surface endo button for the fixation on the femoral side, and similarly at the tibial side you can use again interferential screws. There is for the PCL a double fixation by either a screw post or a staple is again a good option. So the graft tensioning can be achieved by a tensioner or by giving a good anterior drawer. So again you can do transtibial single bundle or double bundle reconstruction. So we always, I prefer doing a single bundle. So this is another way of doing is tibial inlay technique, where you can, you have to do both arthroscopic as well as open. Nowadays few surgeons even do this arthroscopically. So this is the video of that patient. So the ACL was torn from the femoral side. So we had to debride the ACL for, because it was lax, and the PCL we tried to retain the previous graft which was lax here. So we created the posteromedial portal, and we were able to visualize. This is the outside in femoral tunnel, so which is closer to the articular cartilage. So we did the gradual reaming up to 11 mm because our graft was 10.5. So this is femoral ACL tunnel was done again with the gradual reaming. So we railroad the suture, and the PCL here it is very critical because your neurovascular structures are just 5 mm from your drilling instrument. So you want have to be very clear. You should have a very good visibility, and so that you don't injure and land up in a problem. So you shuttle your sutures from both femoral and this thing. Then you we also make a ACL tunnel standard technique, and then we railroad the graft. So here the difference what I do is I took the graft from the femoral side, so outside, so that we can avoid the killer turn. So the graft in the bone plug gets snugly fit in the femoral side, and then the soft tissue will be on the tibial side. So I do again, the ACL was done using an adjustable loop, and it was a strong good ACL. So the fixation of the PCL will be done in around 70 degrees of flexion, and ACL was fixed in around 20 to 30 degrees of flexion. So also the PLC was reconstructed using Laprades technique, and I did not bother to remove about the previous endo buttons and all. So you can nicely see here the bone plug, which is nicely situated with the fixed with the bias screw. And this patient at the 2 months follow-up has got good 90 degrees movement, and is a very good stability. So I just rushed through this another case we did around 7-8 years back, vascular repair and floating knee injury. He presented with instability. So we planned to remove his plate, but we could not remove because the screw head were cold weld. So I just was able to remove the few screws and do ACL PCL reconstruction. So It is very important to reconstruct PCL because it leads to medial compartment osteoarthritis as well as patellofemoral osteoarthritis. They say that there is 6-fold increase in the risk of developing osteoarthritis if they are untreated. Post-operative rehab protocol is very important. You have to, unlike ACL, you have to be little slower here. So you have to do gradual weight bearing only after 4 to 6 weeks, and then full weight bearing after 6 weeks. You need to protect your, ask your patient to use a brace for at least 3 to 4 months. So then you do a gradual strengthening protocol. So the factors responsible for the poor results is non-anatomic graft placement, inadequate graft fixation, thinner grafts, and also malalignment. If you are not taking into consideration of the malalignment, then you have problems, and also poor rehabilitation. So to conclude, PCL is a strong ligament with unique anatomy, and it is difficult to reproduce. So ideal reconstructive technique for PCL is still elusive. So the tunnel technique, graft and fixation options, whether you go single bundle or double bundle, makes difference, and rehabilitation will definitely influence the outcome. Thank you.
Thank you, Dr. Pragalad, for your very nice, lively presentation. Then I invite Dr. Rajit Matthews to talk on various graft options. How do I harvest them?
A very good afternoon, respected senior faculty, my colleagues, Preeti Hospital, and the Smith & Nephew industry. Today I'll be talking on the assigned topic, graft options for multi-ligament injuries of the knee joint. Multi-ligament injuries of the knee joint are rare but potentially disabling traumatic events that involve at least 2 of the 4 major ligaments present in the body. Present in the knee joint, that is the 2 cruciates and the posteromedial corner or the posterolateral corner, or all 4. A recent systematic review of the literature demonstrated that early operative treatment of multi-ligament injury yields improved functional and clinical outcomes as compared with delayed surgery. This is the ladder. Once a patient comes to the casualty, this is the ladder to be followed. One thing to be remembered is the ligaments of the knee joint can be addressed stage by stage, or it can be done all together in one stage. The thing that has to be kept in mind is the meniscal repair has to be carried out immediately along with the corners of the knee joint. The cruciate ligament reconstruction can be carried out in the same stage or on another staging. The knee dislocation classification. Coming to the grafts per se, autograft and allograft comparison. There is no additional cost when use of an autograft as compared to allografts. The availability is, the autografts are readily available, while the allografts availability is a little difficult, especially in the Indian market. There's no risk of disease transmission in use of autografts as compared to allografts. Yes, the quality is of autografts are superior as compared to allografts. Since allografts are usually gamma irradiated, and so they usually lose their biological and mechanical properties. Morbidity, yes, there is a donor site morbidity always involved with autograft harvesting, while it's not present in use of allografts. Infection rates are lesser in use of autografts, and tissue reaction is minimal. As we can all see, biomechanical properties of graft, all the autografts that can be taken out demonstrates equal or superior load to failure strength as compared to the native ligaments present in the knee joint. That is, the quadruple hamstring graft exhibits 4,100 Newton load to failure, a BPTB graft 2,977, Quadriceps tendon graft 2352 and a peroneus longus tendon graft, when doubled, it exhibits 4268 Newton load to failure. Load to failure. Even allografts exhibit a similar or a superior load to failure as compared to the native ligaments present in the knee joint. Coming to the ACL, functionally Gerges et al. Divided the ACL into two parts. That's the anteromedial bundle and the posterolateral bundle. Its length ranges from 22 to 41 millimeters with an average of 32 millimeter, and its width is 7 to 12 millimeter. The grafts usually used, it has to be always remembered that the minimum diameter of the graft to be used for an ACL should never go below 7 millimeter. I always use 7.5 millimeter and above. The commonly used grafts are either the hamstring grafts or the bone patella tendon bone graft. Quadriceps tendon graft have been used extensively and is again coming back as a favorite of a lot of surgeons, especially in the Western world, as they exhibit twice as large a cross-sectional area, better tensile strength and stretch as compared to the BTB grafts. Recently, the peroneus longus tendon grafts have also showed promising results, but there is less literature present. Allografts can also be used, again, tibialis posterior tendon, Achilles tendon, tibialis anterior, BTB, and peroneus longus tendon allografts. Scott and al. Concluded that the length of the normal ACL is 38 millimeter with a range of 25 to 41 millimeter, and the width is 10 millimeter, that is between 7 to 12 millimeter on an average. It is essential to obtain a minimum tendon length, that is the hamstring graft when taken. It has to be a minimum of 28 centimeter length, so that when quadrupled, you get at least 8 centimeter in length and should have a minimum thickness of 7.5 millimeters square. Grafts used for ACL reconstruction which have a smaller thickness, that is anything lesser than 7 to 7.5 precludes failure. Sometimes harvesting, that is when using a hamstring graft, getting an adequately sized graft is a little difficult, and at that time combine it with the with the contralateral hamstring graft. Coming to the PCL, the posterior cruciate ligament, the length of the posterior cruciate ligament is roughly between 32 to 38 millimeter with an average cross-sectional area of 11 to 13 millimeters square. PCL again is comprised of two bundles, that's the anterolateral bundle and the posteromedial bundle. In a cadaveric study, Otzi et al. Found that the average length and the diameter of the anterolateral bundle is 31.79 millimeter and 6.50 millimeter square, and the average length and diameter of the posteromedial bundle is 32.42 millimeter and 5.62 millimeter square respectively. PCL graft options entail autografts as well as allografts. Autografts include the bone patella bone tendon grafts, quadriceps tendon graft, hamstring grafts. Currently, peroneus longus graft usage is also becoming increasingly more. A lot of surgeons, especially in the Western countries, use allograft for PCL reconstruction. The diameter of the graft which is selected should ideally be 9 mm and above and nothing less than 8 millimeter square. Anything below 8 millimeter square is again precludes for failure. Coming to the lateral collateral ligament, again the mean length is 63.1 millimeter with a thickness of insertion at the femur 8 to 12 millimeter and at the fibula 7 to 12 millimeter diameter. The semitendinosus graft is the usually preferred graft for LCL reconstruction because it adequately fits the lateral collateral ligament length, which is usually 70 millimeter on an average. The semitendinosus graft is widely used and is easily harvestable, and the desired length of 24 to 30 centimeter is preferred with 7 to 9 millimeter in diameter. Coming to the PLC reconstruction, usually I follow the Professor Lapra technique of PLC reconstruction. Here, the anatomic reconstruction is being followed, that is the lateral collateral ligament insertion can be located 1.4 millimeter proximal and 3.1 millimeter posterior to the lateral epicondyle. That's the femoral insertion. And the femoral attachment of the popliteus longus tendon has been reported to be located 18.5 millimeter anterior and inferior to the lateral epicondyle. Again, the lateral collateral insertion comes on the fibula, and the popliteus tendon, longus tendon is being inserted into the posterolateral aspect of the tibia at the popliteus groove. So the femoral attachment, usually what I do is the femoral attachment of the lateral collateral ligament and the popliteus tendon is being drilled almost in a width of 7 to 9 millimeter in diameter, 20 to 25 millimeter length tunnels. And then the graft is rerouted, and the lateral collateral ligament is rooted into the fibula head just below the champagne drop-off sign, taken from anterolaterally to posteromedially, and the popliteus tendon comes here posteriorly into the popliteal sulcus and is being tied down into both the graft ligaments are tied down to the anterolateral aspect of the tibia, that is lateral to the Gerdy's tubercle. So the tunnel which I create in the fibula is 6 mm in diameter, and the tunnel which is being created in the posterolateral aspect of the tibia is 8 to 9 millimeters. Coming to the MCL, again the proximal width, the insertion at the femur is 10.09 plus 1.2 plus or minus 1.2. Distally at the tibia it's 10.7, and it has a length of 100.7 plus or minus 9.5 millimeters. And the deep part of the MCL, the insertion at the femur is 10.6 plus or minus 4.5, while at the tibia it's 17.9 plus or minus 2.7 millimeter. And the length is usually 30 to 35 millimeters. Autografts including the semitendinosus tendon or both the hamstrings can be usually utilized. The peroneus longus tendon can also be used, and various allografts can also be used according to the individual practice. It's always to be remembered that the anatomical studies have verified that the length of the SMCL graft has to be 16 centimeters, while the POL graft is 12 centimeters. So that's how you should calculate your graft size and your length. Again, remember, in an acute case, always repair a superficial medial collateral ligament tear and try to augment it with the contralateral hamstring grafts, if possible. Again, the Professor Laprade technique of anatomical medial collateral, posteromedial corner reconstruction. It has to be remembered the superficial medial collateral ligament femoral origin is located 3.2 millimeter proximal and 4.8 millimeter posterior to the medial epicondyle. The posterior oblique ligament is shown at its average distance 1.4 millimeter distal and 2.9 millimeter anterior to the gastrocnemius tubercle. Again, the insertion of the superficial medial collateral ligament comes 6 centimeters below the joint line and 1.2 to 1.4 centimeters just below the joint line, and the posterior oblique ligament again has to be roughly inserts at 1.2 to 1.5 centimeters below the distal joint line. Again, the tunnels that is being created are 7 millimeters of all the tunnels in a range of 20 to 25 millimeter length. Coming to the tendon harvesting procedures, the bone grafting. An incision from the lower pole of the patella to the tibial tuberosity. It has to be remembered the paratendon is being incised and open. The central third of the tendon is being, the patella tendon is being incised. 20 to 25 millimeter length is what we require from the lower pole of the patella tendon and from the tibial tuberosity, and the width and the height should be 10 millimeter. This should be kept in mind, and the harvesting should be done using an oscillating saw or osteotomes. Using an oscillating saw, 20 to 25 millimeter length of the bone block with 10 mm height and width. The quadriceps tendon autograft, alternatively quadriceps tendon bone autograft can be harvested 22 to 25 millimeter bone block with a 1 centimeter oscillating saw and harvested at the length of 6 to 7 centimeters. Again, the bone blocks are to be fashioned and sized to fit to 9 to 10 millimeters of width and height, and usually a 7.5 to 8 centimeter length of the quadriceps tendoning is being received. Along with the bone block, it gives almost 10 centimeters length. Hamstring grafts, most commonly used as they provide a balance between strength, stiffness and mobility, can be folded onto itself to form 2 to 6 strand grafts. I will discuss the advantages and disadvantages in the coming slide. The technique of harvesting the hamstring graft. There's a bump that is felt on the anteromedial aspect of the knee. The pes anserinus has to be incised. The semity and the gracilis are incised from the periosteum and harvested. I'll just skip through the slide. Peroneus longus graft has been a preferred choice because of various knee joint complications of the previously mentioned graft. Furthermore, it gives a good cross-sectional area and good stability as compared to many other grafts. Always, it has to be remembered that the peroneus longus tendon graft has to be sutured to the peroneus brevis tendon, and then it has to be harvested so as to avoid any weakness in the ankle joint.
Dr. Ajit, we are running short of time.
Yes. This one.
Yeah, works.
Coming to the conclusion, all the 4 grafts. Well, the indications of the bone tendon bone grafts, it's indicated in young athletic individuals who are skeletally mature, sports of profession that does not involve kneeling, because the common complication with use of a BPTB graft is anterior knee pain. So in such cases, if you want a robust, good graft, go in for a quadriceps tendon bone graft. The advantage is reliable, time-tested, and faster incorporation, good outcomes, and improved return to sports activities. Disadvantages: donor-side morbidity, risk of patellar fractures, and it's contraindicated in skeletal immature patients. Complications: patellar fracture, patellar tendon rupture, patellar tendinitis, and anterior knee pain. Hamstring graft, a good graft that is being usually used. Young athletic individuals who are skeletally mature or immature. The advantages are it's an option in skeletally immature patients. There's a low harvest site morbidity, smaller incision as compared to the BTB graft, and less post-operative knee pain. Disadvantages are the less predictable graft size. Usually the desired length and diameter is a little tricky. So in such cases, combine it with another, the contralateral hamstring graft. Higher re-rupture rates, and reports also state a higher rate of infection as compared to the bone tendon bone graft. The complications are bone tunnel enlargement due to windshield wiper effect and residual hamstring strength. Quadriceps tendon graft, the indications: young athletic individuals who are skeletally mature or immature, athletes who rely heavily on their hamstring graft, and laborers who spend their time on the knee joint who don't want to have an anterior knee pain due to BTB graft harvesting. It's a reliable and robust graft, can be used with or without a bone block, without a bone block in skeletally immature patients and with a bone block in skeletally mature patients. The usual disadvantages are donor site pain, fluid extravasation during arthroscopy, and weak quadriceps, associated quadriceps weakness. Peronis longus graft, the in graft, young individuals can be used in young individuals who are skeletally mature or immature. Long graft, large cross-sectional area, simple harvest technique, does not affect the knee musculature. Disadvantages are there's a risk of ankle instability and complications, a risk to the femoral peroneal nerve during harvesting. My last slide. In cases of ACL and PCL reconstruction when it's required, I use the ipsilateral hamstring graft for the ACL, peronis longus graft for the PCL, and if I require more diameter or length, I take the contralateral hamstring graft. When ACL, PCL, and the lateral collateral ligament alone, I use the ipsilateral hamstring graft for the ACL, ipsilateral peronis longus graft for the PCL, and the contralateral hamstring graft for the LCL. ACL plus PCL plus PLC corner, I use the ipsilateral hamstring graft for ACL, ipsilateral peronis longus graft for the PCL, and the contralateral peronis longus graft and the contralateral semi-T graft for the posterolateral corner. Same thing for the ACL plus PCL plus posteromedial corner, and I've not come through much cases where I get all 4 ligament injuries. If in such a case, I use the quadriceps tendon bone graft for the PCL reconstruction, semitendinosus graft for the ACL reconstruction, PLC and PMC, I use the both sides peroneus longus tendon grafts. Thank you.
Thank you, Dr. Matthews, for lengthy talk. Now I'd like to request Dr. Santosh for the last talk of this session, knee instability and malalignment.
Good afternoon. I can see a lot of hungry faces. I'll try to make it quick. I expected 5%, and I'm very happy to be here in the Temple City on a very auspicious day. I thank the IAS and Priti Hospital on bringing us here on this special occasion. So my topic here is knee instability and malalignment. Am I getting the slides? Okay, knee instability and malalignment. So, instability of the knee can be due to ACL, can be due to PCL or ACL and PCL together, or the collaterals, or it could be a multi-ligament knee injury as we've discussed in the previous talks, or it could be because of the patellofemoral joint instability. So, we'll try to cover all of them briefly. So malalignment could be in the coronal plane, could be in the sagittal plane, or it could be in the axial plane. So how are we going to look for it? So evaluation, first and foremost, is the clinical evaluation. History is the most important thing. However, the mechanism of injury, what's the velocity of injury, all that plays an important factor in deciding and giving us a clue of what was the injury or the instability or the ligaments involved. As we are going to deal with the osteotomy, history of the patient's smoking, diabetic status, status of bone, whether any metabolic bone disease are involved, or all are important in assessing the patient. And in examination, trying to locate the pain point is very important, because just the measurements, as you're going to see and you've seen already, alone does not decide on what kind of osteotomy and how much you're going to do. It again depends on where the pain is. So locating the pain, asking the patient and examining the patient in detail to locate the exact site of pain, to look for cartilage issues or meniscus issues. That examination point helps us to think of those aspects. So those are most important points over here. And Examining the patient in the standing position is very important. Stripping the patient at least till the thigh is very important. And analyzing the gait. You have to make the patient walk and see the patient walking. Then only you can pick up such malalignments. And last not the least, look for limb length discrepancies and neurovascular injuries. And most of my talk is based on our president's publication over here, which gives us a lot of tips. So you can go through this, which is available in the net. So evaluation, first scanogram. Before scanogram, weight-bearing X-rays are the most important thing. Single leg weight-bearing views are very important. After that, full-length scanogram, an AP scanogram as well as a lateral standing scanogram is very important. I don't go into the details over here for want of time. And the first line which you would draw is the Mikulic's line, which is the hip, knee and ankle axis. If it moves medially or laterally, it means varus or valgus. Usually we call it, if it's 10 mm medially, laterally we call it valgus, and 15 mm medially we call it varus. So next important thing is to measure each component individually. So just we usually think varus alignment requires high tibial osteotomy. It's not so. We have to measure the individual components, the femoral component separately, tibial component separately, which is given by LDFA, lateral distal femoral angle, and MPTA, medial proximal tibial angle, and the joint lane congruence angle. To keep it short, these three things are the most important of all of them. And there are various softwares. It can be done manually with scanning, templating. It can be done with softwares, but softwares are more advanced, and chances of error is less. And planning for the osteotomy is key. There are various ways of planning, various techniques. I'm not again going into the details of that. It's vast, and depending on the osteotomy, it's going to vary. So apart from the coronal plane, sagittal plane is the next thing which you need to assess. This is possible with a lateral view, but more literature is coming out saying a full-length lateral view is much more important and accurately deciding the posterior tibial slope. This is a recent one which has come out in KSST. Shared yesterday in social media. So, so if it's varus or valgus, that's what we're going to see. If it is associated with an ACL or PCL, the cruciates, we have to look for the posterior tibial slope, the sagittal plane alignment also, along with the coronal plane alignment. So, if it's an tibial slope which is decreasing, if the posterior tibial slope is decreased, what would happen? There will be slight posterior translation of the tibia. This would be ideal when it is associated with an ACL injury. So decreasing the posterior slope would be advantageous in a situation where there is ACL insufficiency. On the contrary, increasing the posterior tibial slope, where it would result in the anterior translation of the tibia. Here you're seeing the femur moving, but relatively there will be anterior translation of the tibia. This will be more protective in a PCL insufficiency. So in a multi-ligament situation, if you have both ACL and PCL, make sure you don't change the slope. That's a point to note. Apart from the varus, valgus malalignments, sagittal plane alignments must be noted in ACL and PCL insufficiencies. This is a case example where this is a re-revision ACL. Once revision done, again failed, and as you can see, there is a definite medial joint space reduction, and the alignment shows varus malalignment, and you need to do MRIs. MRI is mandatory in such situation where you look for cartilage defects and you look for meniscus issues, and you do need to address them along with considering osteotomies. And as you can see, there was a osteotomy done along with slope correction. When you do an ACL reconstruction along with an osteotomy, the issues which you would technically face is convergence of the tunnels and the screws. So there are ways you can avoid it, like placing these trocars into the tunnels, and you can, so to some extent, avoid convergence of the tunnels. And you can use the help of X-rays to help avoid convergence. Apart from that, there are other plates, variable angle plates, where you can divert the screws in different directions with those locking plates. And when there is a PCL insufficiency in such situation, which is a case example where there is a varus malalignment with a PCL insufficiency, you might do a lateral closing wedge osteotomy or a medial opening wedge osteotomy. It's up to the surgeon and technical difficulty level. You can choose whichever you want to do. As we are complaining at the PCL reconstruction, I chose to do a lateral closing wedge osteotomy. Here, only a pre-op individual assessment of your femoral component and the tibial component only made you decide which kind of osteotomy you would need to do, whether it's a HTO or a distal femoral osteotomy. In this case, as we've already discussed in detail, Dr. Subramanian told in detail about LCL and varus malalignment. Rarely you might need to do it both in the same sitting, but this will be decided based on stress X-rays. So LCL reconstruction along with an osteotomy. Talking about multi-ligament injuries, this is a very good paper by Dr. Binshaw in our official journal of IAS, JSSM, where it mentions when there is a multi-ligament injury in a chronic situation, when there is a malalignment, it is better off doing a corrective osteotomy at stage 1, reassess the patient after 3 months, and then decide whether you need a second stage PCL reconstruction or not. And going on to the axial aspects, clinical evaluation of these axial rotations is based on Craig's test, which you will look for the femoral anteversion, thigh-foot angle, which is a static, unlike the dynamic test of dial test. This is a static measurement. And apart from this, very important to look for the rotational element based on CTs. You can do overlapping films or various cuts at various levels and measure using software. Femoral component rotation to be measured as femoral anteversion, tibial torsion to be measured again, and apart from that, TT-TG distance also helps. And as I told, MRI is also important. CT evaluation, you can see this is a routine CT evaluation for any patella instability, and the other important aspect is looking at the patella height and TT-TG CT values. In this, if the TT-TG values are higher, if it's usually more than 2 centimeters, then you consider correction. Unlike 1.5, which was used to be the upper cutoff, now it's being revised to 2 centimeters. And this can be done with either medialization, more and more anteriorization is also possible. That's again based on the cartilage defects or the lesions on the patella. Go through this, and apart from medialization, based on the height of the patella, distalization also can be added, and this again is I would call it as a unloading osteotomy. This again, we can consider this as a malalignment in the proximal distal plane. And the last case as an example, this case is presented as a right knee patella instability up to episode and left apprehension for the patella. As you can see, it looks like a valgus knee. But video is not playing. Okay, it's just not the valgus malalignment. We have to do the CT to evaluate, as I told, and the CT showed a femoral anteversion. Femoral retroversion. Right side showed a femoral retroversion of 15 degrees, left side of 10 degrees. So the key point over here is just not the coronal plane; it's an axial plane rotational malalignment also, which needs to be addressed. In this situation, we opted for a distal femoral osteotomy, where you can see the biplanar osteotomy of the distal femur, which was done. There you can see the closing. Conventionally, you need a 2-level osteotomy. The valgus must be done distal as a DFO, and rotation must be done in a mid-femoral level. But it was to do this way. This is a new technique which is being sent for publication, where you take a wedge. Along with this wedge, there is an oblique wedge taken over here to give the 10 degrees correction. So as a result, you get both valgus correction as well as a 10-degree rotational correction. That's the kind of thing. So as a take-home, history and examination is very, very important in finding out malalignments. Gait analysis is very important. Scanogram, measure the individual components. Weight-bearing X-rays are very important. Lateral full-length X-rays are very important to look for the posterior tibial slope. Stress X-rays are key to manage the collaterals. CT is important in managing axial malalignments, and MRI is also mandatory before going on and doing the surgery. Precision planning and execution is required to have good results. And as a last slide. Thank you, and I do invite you all to Coimbatore for the AS meeting, and do present all your papers. We have 5 categories of paper submission. Abstracts are open from today, and there are various options. Excellent prizes which has been announced by our secretary. So do come in and apply for papers. Thank you.
Thank you, Dr. Santosh. And the discussion of this multi-ligament knee injury session, as the lunch is eagerly waiting outside for us and followed by live surgery, we can restrict our discussion session within a few with a few questions.
One question to Dr. Santosh Sahanand, sir. How common is this axial malalignment patients do come? Because are they really sports athletes, or is someone who is young, who is more fussy, means who is not somehow happy or something?
Not very common. It's not very common. When we see those patella instabilities, we have to keep looking for them. And clinically, we might miss it sometimes, so we have to make it a routine to put them prone and check the femoral anteversion and tibial torsion every time. So sometimes, if at all we miss it, if your CT scanning involves these measurements as a routine, we have all this as a routine measurement. If that involves as a routine measurement, the chances of missing that is less. But it's a rare presentation, but you should not miss it. And if you address it without addressing that, there will be recurrence.
Around and Ijaraja, another STO or something like that. Even axial sagittal deformity, Sachin says talks only with corrections and docents, very fancy things that he does.
He's coming up with another paper. You can give some inputs on the paper on sagittal
deformities. How often you see them, sir? Really?
How often do you see them? They're very common, to be very honest. How often do you need to correct them? Less than 10%. So only if you have 2 failed ACLs, then I would do a correction of a slope. If I have a neglected PCL, then I would do a correction of a slope. Otherwise, you pick them up, you'll find that a lot of people have high slopes, but you don't go overboard trying to correct each and every slope. It's only when your primary surgery fails, then you would have to look at this cervical slope correction.
So one word about more fancier these days. What's the opinion about the faculty to use peroneus for ACL reconstruction? I don't know.
Complete disaster if you want to start using peroneus longus, because peroneus longus is a very important muscle, and I don't think we should sacrifice it so easily. The tendinous length is long, it's attractive because the harvest is easy. I feel you should reserve it as a bailout situation, multi-ligament more than anything else. That is my take. I don't know. What's your take? Same? Yours? Always? Yours? You always use?
Even now, my indication is only for cases where we are having multi-ligament or in a revision scenario. But having said that, I've actually done 20 cases so far for multi-ligament, other purposes, not for primary ACLs. But my own patients, I have not seen any deficits, any functional deficit. Even some of them are really sporty individual also. So I don't have an answer for the question yet.
So you will not, you won't see a foot deficit, but given a choice that you have a primary ACL. We're talking about primary ACL.
Primary ACL, we are not using peroneus. We are only using hamstring only.
Okay. Now my question.
But cases where you are you want to go for other options, then you are thinking of that.
Okay. My other question is that you're doing a revision ACL or primary graft source. Revision ACL, you have a failed hamstrings. And you don't have gross tunnel dilatation. What is your first graft choice?
Usually I go for opposite hamstring.
Opposite hamstring.
If opposite hamstring is not available, then we go for is the arthroplasty. think when we are discussing about failures, we have to identify the cause for failure, and that is a different ball game to address. Yes, yeah.
Traumatic re-rupture, the tunnels are in good position. Will you still reconstruct again with a soft tissue graft? And why so? Don't you want bone plugs in the tunnels? I'm just asking. I mean, just a discussion. You go to opposite. Why do you want to go to the opposite side?
Hamstrings, I be better because
I think the diameter is important.
Yeah.
So I would go for a proper 9 mm or at least 9.5 also, big graft. That is more important. And obviously BTB has got its own pros and cons, but I have done revisions with hamstring with good graft, reasonably fine.
Get the same size because graft diameter will increase.
When you don't have that option, then you have to go for BTB next. That's my next option. After that, peroneus comes in play.
Sir, person comes one time.
Okay, and he has a very high slope, I will correct it. So if I have a high slope and I'm doing a primary ACL, I might think of doing an extra-articular tenodesis. If I have a high slope, I'm doing a revision ACL, I'll do a slope correction and do a revision ACL.
Sir, do you use internal?
That he will tell us. Graft choice. What is your consensus on internal brace?
I have not used one.
Why not? Who uses?
No, I want to ask one question to you.
No, internal brace. Who is using internal brace? I think you should avoid using all this foreign material in the joint because.
No, yeah, that is true.
As far as possible, don't do it. One situation where I would use it is if someone has got 20 degrees of hyperextension in a primary ACL, correct? In that person, I would add an internal brace, but I will drill a separate tunnel and fix it independent of the ACL graft at about 0 degrees of extension as a check rate. That will probably be
the message is intra-articular, never use any foreign graft.
You should not
that
use.
That is against biological concepts. So not use it, internal brace or anything, even ethibond also I don't want to use intra-articular.
So that is why you should use suture. You're whip stitching your tendons, make sure that suture does not come intra-articular. If it comes intra-articular, it is very liable to cause synovitis. Somehow this concept of internal brace has been blown out of proportion, if you ask me. Correct. And a good concept is getting a bad name. And I've seen patients with these internal braces, they don't integrate, they look separate, they tear, they cut through the condyle, they destroy cartilage. It's not a good thing. I think it's a good concept that has taken a bad name. Extra-articular, yes, you can use it. No problem, you can use it on the medial side, correct? But again, to be proper understanding of when you're doing internal brace for extra so when you do a reconstruction, you are anatomic. When you're doing an internal brace, it has to be isometric. So you have to spend enough time, check the isometry of your internal brace before tightening it. And what is interesting is that if you're doing for an MCL, then the femoral position will change the isometry, not the tibial position. So if you see the original technique which was described for a medial internal brace, it was an anatomic technique. The problems which even I faced was that I over-constrained the knee and my patients didn't get proper flexion. So which is why it has to be isometric, and you take 2 wires, get the tibial point, get a proper suture, and then manipulate the femoral insertion so that it is isometric throughout the arc of movement, otherwise it is defeating the purpose. Don't over-constrain it because it will never stretch out.
Regarding the graft option, I think debate between hamstring and BTB has been going on for many years. It will continue also. If you are comfortable with using hamstring, diameter is very important. That's what my own concept is. And if you think hamstring was the reason for failure, you should have used BTB from the beginning itself, not for the second revision. So that's why I think the reason for failure is only the graft, then maybe the diameters was insufficient or the tunnel was not correct like that. Then you can use hamstring again, but with a good diameter. If you are using BTB means then you should have used BTB the first operation itself. Why for the second operation?
Yeah, so if you want, the other important point is that if you're doing a revision, you have to enlarge the tunnel. Because if you use the same tunnel, even if it is in the correct position, the ends are sclerotic, which is why you need to over-ream and create a larger size. So what was a 9 automatically becomes 11. And then trying to do 11 hamstring may be a bit of an issue. So that is one other thing that you need to consider.
When it comes to ACL plus PCL plus
ACL, PCL, PLC. So I would do quad tendon, I would do BTB, and I would do hamstring, or I would do BTB for the ACL. I'll do a triple peroneus longus for the PCL, and I'll use the Soceity for the PLC. Depends. Yes. So if it is a grade 3 PCL PLC, then I need to do a double bundle type of reconstruction. So I'll probably use the peroneus longus and use a single strand. We wrote about it in the arthroscopy techniques where you don't need to harvest two tendons. You can do a single loop of PL. So I'll use a single loop of PL for the lateral side, and then I'll use the Soceity for the ACL, and I'll take the quad tendon for the PCL. So yes, you should not take the hamstring. You should not take ipsilateral hamstrings. If there's ACL, MCL, you should go to the BTB. And I think there's a good consensus paper which has been published this year which shows that you should not touch the hamstrings if you have a MCL.
Sir, I thank everyone. I think we had a very excellent discussion. So we.
Sir, thank you, sir. Thank you.
So our lunch break will be squeezed now. So we will try to get back as early as possible. Live search. So please come early. Start the live, and we can spend some more for the meniscus workshop. So 2:15, 2:20 we will go for live surgery. First floor. Lunch is on the silt floor, just one floor above.
Check. Hello. Check. Check. Hello. Check. 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 Hello. Check. Hello. Check. Hello.
Santosh.
Yeah.
Yeah, have you are audible, Santosh?
Yeah, clear.
Eleven blade.
Santosh.
இது இருக்குது, இது என்னது?
பாலாஜி கேக்குதா பாலாஜி?
எஸ் சார்.
உங்க வாய்ஸ் வரல சரியா.
சார் இப்போ கேக்குதா சார்?
ஆர்ட்ரி.
ஹலோ.
ரொம்ப கம்மியா கேக்குது.
ஸ்ட்ரைட்டா கவுட் இல்லையா? சரி ஓடாக்கு பரவாயில்ல.
சார் டெலிகேட்ஸ் இப்போ தான் வந்துட்டு இருக்காங்க.
இல்ல இது ஜஸ்ட் ஒரு சந்தோஷ்
இப்போதான் வெளியே போனாரு சார்.
ஓகே ஒன்றும் இல்லை
சார் வந்துட்டாரு சார்.
ஒரு டயக்னோஸ்டிக் மட்டும் பார்த்து இது பண்ணுவோம்.
சரிங்க சார்.
சந்தோஷ் யூ ஆர் தேர் அல்ல?
யா.
நீங்க எப்படி இது அன்லாக் பண்றது?
Just do a diagnostic round.
Okay.
So once crowd comes, then sir will plan properly.
This is going live online or?
Live online போயிட்டு இருக்கா இது?
உள்ள தள்ளுறது? ஆன்லைன் வேண்டாம் வெயிட் பண்ண சொல்லுங்க.
பாஸ் பண்ணி வச்சிருங்க.
ஓகே.
இந்த பக்கமா இதா
Mukesh is joining you, Santosh.
Sorry?
Okay, தண்ணி
Mukesh is joining you.
Yeah, Mukesh will come. He's not yet finished his lunch.
டேபிள் இதுக்கு மேல கீழே போகாதுல்ல? ஓகே. Bucket handle tear, flexion.
We can't see the Scopy image. Can somebody put that?
இது Scopy image போடுங்க.
Yeah.
Is it now okay?
Yes.
Yeah. Okay. என்ன பண்ணலாம்? அதே லைவ் சர்ஜரி காமிக்கணும் இல்லையா?
ஆமா.
இது ட்ரக்கா இருக்கணும். மிடில் போட்டு வச்சுடலாமா? டைம் சேவ் பண்ணுறதுக்கு.
Sir, did you have lunch?
This one or this one? இதா பட்டு இந்த பக்கம் இருக்கு, இந்த பக்கமா உங்க பக்கமா? அந்த பக்கம் ஆப்போசிட் சைடு. அவ்வளோதான் இருக்கா? ஓகே. ஃப்ளெக்ஷன் பண்ணுங்க. 11 பிளேட். எதுங்க? ஆமாம் போடணும். ஹைட்டு கொஞ்சம் இன்க்ரீஸ் பண்ணிக்கலாம். லெவன் பிளேட். Probe. Sorry, the open. Just we'll see the joint space whether you required a pie crusting. Maybe I can show a pie crusting. வேண்டியதில்லை ஏற்றுறது ஒன்றுமே வேண்டியதில்லை. Okay. Figure of 4.
Can still show, sir, for the sake of showing.
Santosh, it is visible now?
Yeah, Scopy is.
Okay. Straight.
Okay.
Is my voice audible there?
Yeah, it's audible.
Okay.
It's audible.
Okay.
So once if you feel like delegates are there, Then sir will start taking graft and all.
About 10 delegates are here.
Okay.
And the other shower will get used to how to use
You can just rush up, Balaji.
Sir?
The delegates mattu koncho vanda.
Yes, sir.
Yeah, they will not, otherwise they will miss the graft harvesting and all.
Yeah, but ninnu
Okay.
Oh, you have to stop. Press பண்ணி எடுத்துறணுமா? Okay. So we have to wait till okay. Section கரெக்டா இருக்கா? Okay, okay. கொஞ்சம் டைம் ஆகணும் யூஸ் பண்ணுறது. They are not used to the hand. Careful.
Santosh?
Yeah, about 15 delegates are here, sir. You can start, I guess.
It looks long, but it's not long. Ready, yeah? Santosh?
Yeah, sir. 15,
Can you?
Yeah, we can start. The 15 delegates are there. They're slowly coming in.
Okay, so case history, yeah.
So this patient around 30 years old young gentleman who sustained a twisting injury while playing volleyball 1 year ago, and following which he had a locking episode. Yeah, he had a locking episode, and then he took some kind of native treatment, and he was treated conservatively. But now his pain and instability aggravated, so he has presented to us now. So clinically he had a grade 3 Latchman and anterior drawer positive, and otherwise there is no pivot shift and all were like within normal this thing. So McMurray's was positive, and when we did his MRI, the alignment was okay. So the MRI showed the signal changes in the medial horn of the medial meniscus, and if you see here, we can see some meniscus in the intercondylar notch as well. So the ACL is completely lost here. So you can see that there is some meniscus here. So he has a bucket handle type of meniscus tear, medial meniscus tear, and complete ACL tear. Over to Sundarajan sir.
Yeah, Santosh.
Yes, sir.
So you know the history now.
Yeah.
So it's a chronic case with the complete ACL insufficiency with the loss of ACL fibers, and also he's got a bucket handle tear of medial meniscus. He is an young and very active individual. Here we are planning to do a patellar tendon bone graft. We have done already diagnostic round, and we found that there was a bucket handle tear of medial meniscus. Otherwise, the rest of the joint looks to be okay. So, shall I go ahead with the patellar tendon harvest?
Yeah, yes, sir. I mean, otherwise, Lachman pivot shift.
Yeah, Lachman is positive, but pivot is not very obvious, but Lachman's was positive.
Okay, sir.
So, we are planning to do a PTB graft here. So, you can see that already I have done the diagram. It's a patellar tendon, that's the tibial tuberosity. I'll give you a marker. So when you make the incision for the patellar tendon, so we don't make a midline incision at morning like Saravanan told, to prevent that irritation when you do a kneeling. Always we make a curvy linear incision on the medial side so that you don't make incision directly on the skin. You can see my mark, it is almost in the medial side rather than the midline. 23 blade please, knife. So we can just make the incision slightly, maybe half centimeter or 1 centimeter distal to the inferior pole of the patella. You can see that I'm making the skin. Maybe we need only 3 to 4 centimeter incision here for the patella tendon harvest. Do you have the smaller one like this? Yes. Forceps scissor. You have 2 more like this. Ideally, you need a. Yeah, can you retract it? Yes, that is also fine, no problem. Can you give me a 10 blade? Can you see the patellar tendon now?
Yeah.
That is the patellar with the patellar tendon sheath. You can see that what I am doing incision is on the patellar tendon sheath. I am using scissor. The very thin sheath here. Can you see that? It's not a very big, it's not a very thick sheath, very thin sheath. Can you put the other retractor? You can use both, no problem. One is above, one is down. Same way here. You can use one down, one above. So what I want is to expose the entire patellar tendon. Retract with the sheath. Yes. Sandosh?
Yes, sir.
Hope you are all not sleeping post lunch.
After very good Jigradanda.
Yeah, Jigradanda. So you can see the entire patellar tendon is exposed. You should see the medial and lateral tendon, end of the tendon, so that you can use the, you can take the central 1/3 of the tendon. So I generally take around 9 mm of the graft. Unless the patient is very stout, we can take 10 mm. So you can take you can use a scale to measure, or you can use you have a scale with you. So you can see it already made the incision, and I am measuring here almost 10 mm. Can you see that?
Perfect.
Okay. So next, I want to expose the tibial side. Do you have 2 more like this? You don't have? Okay, if you don't have, it's okay. Then you extend the incision over the tibial side around 3 centimeter. Like how I expose here. You can retract the skin very easily for a 2 to 3 centimeter. You have the, you don't have that? Okay, it's okay. It's okay. You can push like that, so that if the both end of the tendon is exposed well. So I have to see this both end. Can you see that? Ideally, you have one more small this retractor will help you to retract the patellar tendon.
Actually, we can see better than what you can see. I think.
Really?
Yeah. It is hyper zoomed.
Okay, super. Is it in the correct view for the anatomical view for you? Saw. Hold it like this. I think you can see better now.
Yeah.
Yes. So this is what you need incision on the tibial side. Ideally, if you have a 90-degree bend saw, will be very helpful. Here we don't have that, but I am using this straight saw. So you require a 45 degrees angle for taking the graft. Usually I use a blade. When the lever arm is longer, then it's difficult to take. You have to use the shorter blade. Because unfortunately here we have only this blade, but we try to use this. And make sure that you go the depth of maybe 9 to 10 mm. And make a distal cut. Yes, it's a 10 mm blade. Then you use the osteotome, 10 mm blade with a curved osteotome like this. Can you give me the mallet, please? Yes. Then go up, do the osteotome. So you cannot do the patellar tendon harvest without saw. You require saw, otherwise you will break the graft. You can see that. Yes. Scissor, please. Scissor. Thank you. Can you give the towel clip? Towel clip. Can I give the same osteotome again in the hand? Or scissor, please? Scissor. So the tibial side harvest is almost over. Can you see that?
Yes, sir. So,
So
what's the target size you are aiming at, sir?
10 in the tibial side, 9 or 10 mm in the tibial side, and femoral side I usually aim for around 9 mm. Depends upon the patient. He is a very stout and big individual. He can have a 9, in my opinion. So you harvest at least 3 cm of the graft with the tongue, but sometimes the tongue can break when you prepare, when you do a preparation or when you insert the graft. No need to worry about it. You have a 2.5 cm of bone in the tibial side is more than enough. Okay? So the tibial side is over. So I'm going to the femoral side. Yes. Scissor, please. Sandosh?
Camera needs to focus.
Yeah. Can you give me the cloth? I'll arrange Buneva. No cloths? Okay. Okay. It's okay. Scissor again. Can you see Sandosh now? There are.
Yes, sir.
You can see that again I am incising the sheath in the patellar side.
Yeah.
Can you retract with the sheath now? Yeah. You can use the change the graft. You can put this here. This can come there. Yes. Like this. Yeah, this is fine. He is fine. Yes. I want the. Can you see it properly?
Yeah.
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 10 blade. 10 blade again. Thank you very much. So, extend the incision to the patellar bone. Then you make around 1.5 to 2 centimeter in the patellar side. You don't require a 2.5, 3 or in the femoral side because it's very difficult to negotiate the graft because you are making the transportal technique. So this has to be flat and lie down so that when you use the saw, this should not hit my saw. So you can put it down like this. Okay? You don't need to put all your force. Just gentle retraction is more than enough. So I am using the saw again. Can you see it?
Other view, please. Yeah. Yes, sir.
Okay, 1 minute. You can bring this here like this so that it doesn't obstruct the view. Can you focus from the top so that you can easily see better? Yeah, you are showing upside down.
The PIP can be the other camera. Yeah.
Can you change the camera and show the position properly? Other way. Other way. Yeah. Can I see it?
Yeah.
So again use the 45-degree angle.
So what is the depth you go in the patellar, sir? In 10 mm?
What is that?
Depth of the saw.
Depth is same 8 to 9 mm because we are aiming for 9 mm. So we want to get it 9 mm of the graft. It's okay. I'm not talking too much here because of the control of my blade is slightly less than what I use normally. Can you see my angle of the blade?
Yeah,
it is angled for 45 degrees. You don't use like this. And you use angle like this. It's okay. Yeah. Just gentle retraction. You don't need to use the force. The patella is the one place we have to be careful that you should not have a patella fracture. Knife again. And I need a 10 mm osteotome in my hand. And I want that blade put upside down and show me. So then you remove the patellar pad here. Can you show that under the grab?
Yeah, seen.
Seen? Okay. Yeah. So then you can use the undercut, changing the blade upside down. Can you see that?
Yeah.
Osteotome. Because the blade is a bit longer, your control is less here. Scissor. Thank you. Give a small osteotome again. Okay. Okay, scissor. Thank you very much. You can see this, removed the entire graft. Can you focus here?
The PIP can be larger.
Sorry?
Yeah.
Can you see that?
What's the length of patella tendon?
Yeah, I will measure it and show you. It will be around, in my opinion, 3 centimeter in the tibial side. And the femur, it looks like 2 centimeter. Anyway, I will measure and show how much it is there.
Tendon length.
Tendon length, I will show you. So this is the tibial bone plug. Can you show? Camera?
Scale 1 to 2. 1, 2, 3.
Show me the scale. Okay? Sandosh, tell me 3 centimeter, you are super. Like that, you should tell me. No? Okay. Oh, I can't see. Okay. You can see now?
Yeah. Perfect.
Tell me super.
Super.
Okay, thank you. So this is the tendon length which Mukesh was asking. 3.5.
3.5.
And this is around
1.8.
1.8, yes. That is the ideal. Because you don't want to get more than 2 centimeter. Nibbler,
super.
Please. Enough. Okay. And you need a small nibbler to make it. And we will use the bone plugs as KP Saravanan told in this talk. We will use it, fill this remaining graft, whatever you nibble it up, you can use fill the both the tibial side and the femoral patella side. The first preference is for the patella side because you don't want to get any patella stress fracture. Yeah. And if you have a remaining graft, we can fill it with in the tibial side. Can you show me the tunnel sizer? This one. Okay. This is 10. So this is 10.
Yeah.
Can you see that?
Yes.
I think I could see that. So which I want to do only 10. Slightly we can nibble it off slightly here. Otherwise 10 goes very nicely here. So here we want to go 9. Maybe slightly I need to do some more nibbling here. Do you have a small nibbler? It's okay. So you can make sure that you don't take excessive bone. Otherwise the graft will become very small. We make very, very thin slices of the bone so that to make it a rounded graft. Again. So after taking need some more nibbling. Because especially in the patellar tendon graft, we cannot struggle in passage of the graft. So you have to be very, very careful. Because small nibbler will have a more control. That's why I asked for the smaller ones. I don't want to take too much bone. Yeah, it's almost 9. Okay?
Yeah.
Okay, so 9 and 10. Maybe slightly you can smoothen off some more, make sure it's free. So I usually make 2 tunnels, 2 drill, one here and one here, and one here and one here. And we use this ultra threads or any thread you can use it for passage of the graft. So preparation of the graft is almost, that's it. That's we have to make 2 drill holes and make this thread inside. So Ramakant is going to do. Ramakant is with me. He himself is a big surgeon, but today he's agreed to assist me.
Asne super sundar. Sometimes it has been mentioned in literature that the patellar tendon part of the BTB gets fractured while you are pulling. So any other different technique to prevent that when you are pulling and taking the suturing technique in some different way?
But when you make a drill for the thread to put inside or what?
No, when you are pulling the graft from the tibia to the femur, there are chances that while pulling sometimes the patellar tendon, the bony part of patellar tendon gets fractured.
Correct. I will show you the trick. Okay. When I insert the graft, is it okay? Can we discuss at the time?
Yeah.
Yeah, sure.
For the benefit of delegates who are not yet doing PTB, what extra instruments would you advise them to?
So the main important thing is you need that saw, 10 mm saw with a very short lever arm. So this is a bit longer saw. So you need a smaller blade so that you'll have a control when you do a graft excision. So that is very, very important. So saw is the most important instrument when you do tendon harvest. And you need the 10 mm curved osteotome. That is also very, very important. Other than that, you need a small retractors and other instruments. Other than that, you don't require any big instrument. You cannot do it with osteotome. That is sure. Okay. So that is the patella. That is the trachea. Looks to be good. That is the lateral gutter. And you can see that is the popliteal hiatus. I think already our master had shown all about the popliteus hiatus, popliteus tendon, musculocutaneous junction of the popliteus. So after doing all around, I had come to the intercondylar notch, flex the knee. So we did already diagnostic round, and but we didn't do anything. Just we did a diagnostic round. We can see that bucket handle tear of the medial meniscus.
Yeah.
So this is how morning when we discussed. How do you know whether it is repairable or not? You can just lift up and see. You can see the quality of the tendon. It is a very chronic and it is rough. You cannot reduce it. So any meniscus goes like this, then it is not possible to do a repair. Can you see that?
Yes.
Yeah. So here we are planning for partial meniscectomy. So it is very important to use 30 degrees of your valgus, and external rotation helps you to open up the medial compartment. You can see that? So that is the pro, please.
Outside image of the knee position, please.
Can you show the outside image?
Yeah.
You can see that, sorry, your name? Ramakant. Sorry, I forgot Ramakant's name also. I thought somebody else is assisting. Ramakant is assisting. He is holding it in 30 degrees of valgus position, external rotation of the foot, so that helps you to open up the foot space. Yeah, you can record it, no problem. So you can see that is the meniscus. You can reduce it if possible for your excision. That is very, very important. But the quality of the meniscus is very bad, so I am not going to do a meniscus repair. Can you give me the upbiter? So when you do a bucket hand of the medial meniscus tear excision, then first go to the posterior side. Okay, don't do the anterior excision first. Otherwise, it will be unstable for you to hold the posterior side and do the excision. They are given a very nice instrument. Then you come to the anterior side here. Can you see that?
Yeah.
You can use this way, or you can come on the other side. You can change the portal and do it. But always leave the posterior some tag of the posterior attachment. Here already I done that exercise actually, unfortunately. But in generally, if you do that, it is easy to remove it. Can you give the artery? Straight artery what you had before. So here I didn't do a pike resting because I didn't need to, because we have enough space. You can see that your notch is seen better now. Can you see that?
Yeah.
So especially in a chronic cases, so make sure that you identify the proper posterior end of the notch so that you don't make a mistake when you make an entry point. Can you give me the probe now? Yes. So you can see that is the posterior end of the notch. This is called what you call the residence ridge. Okay. When you see sometimes from here, you think this is the posterior end of the notch, people tend to make a mistake of entry point here. That's how the people end up with the anterior tunnel, resulting in an ACL failure. So it is very important to visualize the posterior end of the notch. You see how does it make a lot of difference when you see from here and when you go see inside and see the entire posterior notch. Okay, agree?
Yeah, agreed.
Okay, so our the entry will be almost in the level of just posterior to the residence ridge. Especially when you do a patellar tendon, we have to be careful that you don't go very posterior, because you need at least 2 mm posterior cortex, because we are going to use the interference screw. Do you have the marker that wand was working? Okay, so I have a RF now. Just maybe I will show it through the RF. You can see maybe my entry point will be around here. Okay? Hope nobody is sleeping there.
Can you show that from the medial portal also, sir? So
Okay. This is not okay. Can you give me the small awl, which I told a spine awl, which I gave you, no? Can you give that awl? Yes, I will show it with the, this is, I think this is the, do a slight flexion, some more flexion, a slight flexion. Somebody is pressing the, yes. Almost this level, okay, a slight hammer. Yeah, 1 minute, yes. And if it is, no, it is not a very sharp. It's okay. Go one more. One more sharp end. Okay. Okay, we can use the micro pick. Hit. Okay, enough. So probably that is the entry point. Anyway, I will use again jig, just to make sure that, I think it's fine. Santosh, are you happy? Mukesh?
I feel it's little higher up.
You feel it's higher up? No,
Yeah.
no.
Okay.
That is higher. That is okay. If you come, the mistake what we should not make is you should not come too low and anterior. Okay, even if we go slightly posterior and higher, no issue at all. Because if we come low and anterior, it will become a failure. Okay?
So any difference in point for the PTB and hamstrings, or you take the same point with it?
I took the almost same point. It doesn't make huge difference. So can you give the jig again? You do have what jig you have for the femoral side? I will show in the femoral jig also. You have offset guides? Femoral side? Give us 7 mm. Yes. 7 mm. Yeah, because we will see that we will put a jig and see how much difference this make through this. Okay? Can we do a fraction? Yeah. Enough. Flexion.
Yeah.
Can you see that? We have the 7 mm offset. Can you put the guide wire? This is where I marked it also. Somebody can hold the leg and somebody can drill it.
This is 7 mm offset, sir?
Yes.
Perfect.
Can you see that?
Yeah.
This is where I marked it because I wanted 7 mm. Yeah, don't bend and go. Yeah, go.
Mastering it superb.
Okay. Go. Yes. Okay. That's fine. Can you use the probe? Yes. Just I want to check it again. Double check, triple check when you do a PTP graft. So can you use the 8 size reamer? Eight mm reamer, please, faster. Yes. So I am going to go slightly gradually 8 mm reamer. Always it's safer. So suppose if you feel that, put it inside. Suppose if you feel that if you put 9 or 10 mm directly, suppose if you breach the posterior cortex, it is a problem. Okay? So it is important that you just negotiate. Don't dream when you do the femur reamer. Can you see that angle here? That is the femoral condyle. You don't touch the femoral condyle. That is the one of the most common injury when you do that. It happens. And when you do I couldn't measure the length of that. Can I use the 4 mm guide pin first and measure the length of the femur? 4 mm cannulated reamer. Do you have that? It looks a bit posterior. I'm worried a bit. Can you give the probe again? Even after using the 7 mm offset, I think we have enough bone. Okay. Yes, enough. Can you put the 4 mm? So we have almost 45 length of the femur. Okay. Can you give the guide wire again? Can you give the shaver? Shaver, yes, thank you. So I'm going a bit slowly here. You can see that even the 8 is almost close to the posterior cortex. Wait. Ramakan. Ama. I'm planning to make, please call it.
Eccentric reaming now?
Probe again. Sorry?
Some eccentric reaming to prevent damage to the posterior cortex now?
Yeah, we'll see that. That's what I'm trying to do that. Okay, you can see that it is very close. Even after keeping the 7 mm offset, I'm very, very close to the femoral, almost to the posterior cortex. Yes. Maybe I had to alter my entry point. Can you give me the one more different guide wire? So I'm trying to make a different entry point. Okay?
Yeah.
So do you have a K wire? Yes. 2 mm K wire, please. So we can make a sharp end to make an entry settle middle to that. Then we will make the reaming again. Okay. Luckily, I didn't ream it fully. This is what when you do a PTB, you have to be very, very careful. So keep on inspecting each and every step. Can I give a one more 2 mm guide? Yes. Yeah. I'll try to make an entry slightly anterior. Okay. Give me the same 4 mm or 6 mm, whatever you have. Give me the 4 mm. No, give me the 8 mm reamer directly. Yes. Thank you. Okay, 20, 25. So you can make a slightly longer tunnel here so that when you have a patellar tendon mismatch, it's always easy to adjust. Can you give me the shaver again? Yes, wait. Hope that The suction works well. So I've changed the graph to 9 to 8 in the femoral side. So that I don't make one more entry and breach the posterior cortex.
Okay.
Can you make it 90 degrees now? Yes, yes, yes. Okay?
Yeah.
So if you go beyond that, it is always risky because even the entry was a bit more posterior. So by making that adjustment like this, still we can save the posterior cortex. If you're not seen, then it is risky.
So sequential reaming is a must.
Sequential reaming is very important. Then each and every step you have to inspect here. So even I used a 7 mm offset guide, still it was very posterior. So I am going to make the graft of 8 mm in the femoral side. Okay? Come to the tibial side.
So you're going to downsize the graft, huh?
Yes, yes,
Okay, okay.
yes. That's why I didn't want to ream the 9 first, because I know that it can happen. Many times it had happened before also. So, yeah, it's an elbow aimer, which I think already had shown. So that is the anterior horn of the lateral meniscus. That is the posterior border. That is the anterior border. If you see the most of the border, most of the occupancy of your ACL is corresponds to the anterior horn of the lateral meniscus. So I'm going to make entry point here. You can see that is the elbow aimer. So like if tibia, the femoral side also you need a sequential reaming, especially in the PTB graft. Of course, in the the posterior cortex, you can take a little deeper, you can take the graft a little longer. Is it okay?
Yeah.
Yes. Yes, enough. Good. You can do a sequential reaming, do the 4.5. I think it is the center of the footprint, but still we use the 4.5 or 4 mm drill. Then if you want, you can adjust your reaming again. Okay? Yeah, can I give the guide pin? Yeah, can I give the artery? Are shown change entry point from the central entry point. You can make it we can make it on the lateral side, you can make it on the medial side, you can make it on the posterior side. Okay? Go ahead. What is this? 7 mm? Yeah. So again I am going for a sequential reaming here. Take it out. Okay. Next. 9 mm. So far, any queries? No questions?
No major questions.
Okay. Because I am going to downsize the graph.
Distally you're going to...
Yes, make it a 9 and 8. So that is the advantage in the PTB graft. Sometimes if you have a problem, yeah, go ahead slowly. Yeah, go. Yeah, take it out. Okay. Downsize the graft, Ramakant. Meantime, I can take the shaver, please. Suction is not working.
Sundar?
Yeah.
During tibial reaming,
yeah,
I feel doing sequential reaming may change the dimensions of the tunnel, unlike in the femur.
Yeah.
Because in femur, the lateral cortex is intact and your guide wire doesn't change much.
Grasper, yeah.
But in tibia, once you are doing 4.5, then it may move here and there by 2-3 millimeters.
Yeah, that's we are expecting only 2 to 3 mm only. You cannot change the entire course of the graft.
So it's better to avoid sequential reaming to avoid this. It's advisable.
No, it is advisable. I don't want to ream 9 mm, 10 mm because there are easy way of taking 2 mm, 3 mm medial side or a lateral side after making your 4.5 tunnel. If you ream directly 9 mm, if you once break the cortex, then you cannot do anything. Always I
I'm
advise.
talking about tibia, not femur.
Yes, tibia. Always I do a sequential reaming. It's very, very important. Even the femur, it is very important because I said, no, I showed you here. See, we had issues here. So I straight away I started reaming 8, then I stopped because I was worried because it's a PTB graft. If it is a hamstring, I might have reamed.
Sundar, I'm talking about tibial tunnel, not femoral tunnel.
Yeah, tibial tunnel also, Mukesh. You can change the course of the tunnel around 2 to 3 mm. You can change the entry point. We are not talking about the tunnel size changing. We are at least entry point, what I am saying.
Okay.
If you make a 4 mm tunnel, so that helps you to, if you think that if your entry point is the first guide wire is a more medial,
you can shift
always you can use the 4.5 mm reamer. That the 2 to 2.5 mm, you can easily pull the guide wire on the lateral side so that you can centralize your entry point for your next reamer. Again, I don't go for a 9 or 10. So go over 6 or 7. Then make sure that it is in the center. Always you can take up 2 mm, 3 mm, both anterior, posterior, medial and lateral.
Right.
What is the length of the tibial tunnel you are aiming at, sir, over here? What might be the length of tibial tunnel?
Not measured. We are going to measure. Can you someone can see the suction? It's blocked. I don't know it's blocked here or there.
Sundar is KNS here. Hello?
Yes.
You are saying it's always safe to do serial reaming. That's what you mean.
Yes, that's what I mean.
Yeah. Even in 8 mm graft, you would like to do a serial reaming.
No, not especially the PTB side. 8 mm, if you are confident that your entry point in the center.
So essentially, when the graft size is slightly in the 9 mm side, the better is to do serial reaming.
Absolutely.
Yeah, correct.
And also, when you make an entry point itself, you know that you are in the center or medial or lateral.
Yeah.
Whether whether you can take out and make another entry point, or you do the 4 mm drill and you can adjust again.
So the message is if you are bare confident you are in the center, then you can go for a normal size reaming.
With 8 cents.
Any doubt, go for a serial reaming. That
yes,
is
with the standard 8 mm.
Yeah.
But if you are going a bigger graft, like even Sachin did 9 mm graft or 9.5.
Definitely serial reaming is better.
Absolutely.
Yes.
Yes, a beginner, I don't want you to put a 8 or 9 mm reamer. You see the femoral side what happened. It can happen the tibial side also. You can break the cortex. You can break the anterior cortex. It happened to me once.
Tibial cortex, anterior cortex breakage has happened.
Yeah, if you use a 9 mm, 10 mm directly, if you are not careful, there is a possibility you can break.
And if it breaks, it's very difficult to manage.
Very difficult to salvage.
You have to go for suspensory device only.
Correct. Yeah. So always I suggest to go serial reaming, especially for the beginners. Unless you are Mukesh.
Unless you are super Sundar.
No. Here I am trying to clear that entry point.
Sir, how much angle did you keep in the tibial jig for drilling?
55.
Okay, so is there any change we can use it when you use a BD? That is when you adjust the tunnel length?
When you use the hamstring, I use 50. Can you do uprighter otherwise? I am not able to take out that flap. Punch, can you give me the punch please? We are almost ready for the graft passage. I am not worried about the too much length mismatch. You can adjust. You can see the entry point now well.
Yeah.
Just to show I am doing so slowly. Can I see the footprint now? Pro please.
Yes.
So we are not damaged on the medial or a lateral tibial spine. So that is the lateral border. This is the anterior horn of the lateral. If you become more lateral, you can the possibility of the lateral. That's why I said that better to go till reaming so that you damage the meniscus too. Okay?
Yeah, got it.
Okay. Ready? The graph? Ready? Sure. 9 production. Because it's because each footprint is different. Because initially when you have a transtibial technique, we used to take 7 mm anterior to the post PCL. So that concept when we did the transtibial techniques before, now we don't do that much posterior. Previously we used to go posteriorly, but we don't go that much posteriorly now. Can you put it in the gun and give it to me? Power, can I put it in the power? So now usually you know that your 70% of the ACL footprint in the tibial side corresponds to the anterior horn of the lateral meniscus. Unless, for the femur, tibia, always you have some kind of remnants, unlike femur. So femur, you may not, in the chronic cases, you don't have it. But in tibia, always you have remnants. You know the center of that footprint. You no need to worry too much about your entry point there.
Okay.
You don't do much mistakes in the tibial side, that's why. Always we do mistakes in the femoral side.
Agreed.
Okay, can you pull it? Yeah, go ahead. Go ahead. Pull. Come on, some more. Take it some more inside. Grasper, please. That's okay, no problem. Leave it. Wait for some time. Can you give me the nibbler? Always I clear that tibial entry point, Mukesh, because especially when you do a PTP graft, retract and nibbler, please. So if you have a soft tissue, always you have a problem. 11 blade again. You see here? Can you show here?
Zoom in.
Zoom in.
PIP image larger, please.
Give me the probe. Give me the probe. Probe. Yes. You see the entry point here.
Yeah.
Actually, this is the entry point. It's completely obstructed with the soft tissues. If you don't clear this, sometimes the patellar tendon graft will not go. Again, this itself in a big obstruction, especially the tongue flap. If you are not careful, if the soft tissue obstructs, then if you try to pull it, it will break.
Okay.
So you have to make a 11 blade. Make sure that it clear the soft tissues. You can see that how it is making the water, how it comes out now compared to before my knife, and use the nibbler. Can you see that?
Yeah, clearly.
Okay, so this is very, very important step. Unlike hamstring, this is very, very, very important. Can I hold it there? Okay. Thank you. So almost we are ready here for the passage of the graft. Yes, graft please. Nalla check pantiya Ramakant unai nambi dhaan podraen. Hope that, because I don't want to get any. Yeah, pull it please. Pull the thread. Yes. Go ahead. Wait. Yeah. Go ahead. Inside. Go. Pull. So we can see that. Wait. So that is the femoral plug has come inside. So this is the graft which was taken from the patella. Okay. So this is what we use for the tibial side. Wait. You see the tongue flap here?
Yeah.
Can you show the here outside view? Outside view kaamikiringla?
Yeah.
So if you try to pull it like this, you can see this will go here and hitch this cortex and it will break invariably.
Okay.
So you have to keep it. You can see tilt it like. Make sure that you are holding and trying to insert yourself with hand, not pulling blindly. Pull it now. You can see that?
So what should be the orientation of the graft?
I'm guiding that. I'm guiding the graft to go inside. Go inside. Give me the artery forces for him to pull gently.
So the orientation of the graft in the femoral side.
Yeah. So you can see the graft. You are asking about the facing the bone, which side or what?
Yeah.
Usually this is this is how I do it. Gently. Right. Super. Leave it. Yeah, I don't want to go too much inside on the graft side. Can I give an artery forceps? Can you give the RF? Just
Sundar, the graft is sitting at the mouth or it has just went in because your tunnel diameter was little bigger.
yeah, it is in the mouth now. You can see the bone plug there. You can slightly pull inside. Can you pull it slightly? Take out that artery. Slightly pull it inside. Yes, enough.
Yeah.
Put the artery now. So I don't want my screw to enter in the soft tissue part.
Okay.
You know, that then will be a problem. Sometimes it can twist the graft and all those things. Can you flex the knee? Can you give the 1 minute? RF, please, again. Usually, sometimes I can use the, if you have a soft shaver, you can remove this, hold the graft in a slight traction. That is a small bone, please, I think. இதெல்லாம் க்ளீன் பண்ணிருக்கணுமா? Can you see the now?
Yeah.
You see the bone plug and that is the junction. So you always use the notcher here for the entry point here. So unfortunately we don't have a notcher here. Can you flex some more? You should try to flex as much as possible. Make sure that your entry point, okay, enough, good, that is good. Make sure that your entry point is okay. Because otherwise the possibility is that, yes, I'm using a awl, you can see that, to dilate to create the space between the bone. No, not required. So we don't have a notcher, but we are planning to use the metal screw. It will be okay. You need 23 or 25.
Any steps to prevent damage to the tendon while inserting the screw?
So that's why one thing is I don't want my graft to too much inside. You know, if the soft tissue is in the entry point, the chances of getting this kind of what the problem which you anticipate can happen. Make sure that you're entering in the bony part, so there won't be any major issue. This is a 7x25, I think. Can you pull it in a slight traction? This is a 7x25 metal screw. Can you do a slight extension? 1 minute. Slight extension. Some more. Yeah, flex now. So try to make as much as an acute angle for the graft go inside. And I will ask Ramakant to keep it in slight traction.
It's sticking.
It is twisting. I need take it 90 degrees. I will take out the screw. I will make some more notch. I need an archer. Give an artery. Take it 90 degrees. Okay. Can you give me the RF again? Do you have a smooth shaver? This is the. You have a smooth shaver? It's the aggressive shaver which you got. Okay, can you give a 5 more? Yes, we don't have an archer. That is the problem. So I do a slight notcher using the small osteotome.
Okay.
Mukesh.
Yeah.
So I don't want to take a risk here. Flex the knee to 120 degrees, more than 120 degrees. Flex it some more. Yes, enough. So I want to make that entry point slightly bigger for my screw to enter here. Okay?
I think Arthrex provides with a protective cannula also.
Yes. Go. 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 Okay. Go. 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 Yes. Go. 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 Okay. Okay. Hope that should make, because the bone is also very strong. You know?
Yeah.
And usually when you make an entry point, the notcher, if you make it just anterior to the graft here, it's fine. Make a small hammer here. Yeah. 1 minute. Go. Slightly flex the knee somewhere. That's all. Okay. Okay. Yeah, slightly sharper than that? No. You have anything that's sharper? Go. Go. Yeah. Okay. Okay. So you will try again. Give me the guide wire and the screw again. Because we...
Can't we just flip the graft completely? Because the...
Yes. You need a... You don't have the soft shaver? Can you give me the soft shaver? Can you extend it? 90 degrees, please. Yes. Just I will clear that fat pads and bits so that you can see the graft better. Put... Can you use the hold it tightly?
Sundar?
Yeah.
Look-wise, we feel Soceity looks much better than BTB intro.
Don't worry, I will do some cosmetic.
No. I'm just asking.
No. See, no. You see at the end. Cosmetically, it's getting better now.
Tony and Guy.
Yeah, can you see now?
Yeah.
Looks good?
Yeah, looks good now.
Yeah. The grip, okay.
Nice.
Yeah, look-wise it may look like that, but you can see that at the end of the probe, give me the probe now. You see now, what is the difference?
Nothing.
It looks like a normal ACL now.
Yeah, you see that. You see the breadth of the graft.
Yes.
It's around 10 mm.
Yeah.
Okay? You see that entire footprint is occupied here. The tibial side also is covered almost well. When you put a screw, maybe slightly rolling, it can roll here or here. Maybe I will see at the end of the screw again. Okay? Use the extension, please, to see the notch impingement. Full extension, please. Full extension. You can see that? There is no impingement. It is almost hyperextension of around 15 degrees. Flexion.
Oh, super, sir.
Okay, so I am going to put a screw now. So this is a nice case to show how you manage PTP with limited instruments.
Good job.
Artery. A screw, 1 minute. No. I'll tell you. I just will see the all and that 30 degrees. Somebody can support under the tibia? Under the tibia. No, support well. Retractor. Baya? Suction. Retractor, and I need like this, and 30 degrees flexion. Some more flexion. Yes, good. Retractor. Can you focus the camera here? Suction. Your suction here. Can you see the entry point? Take one more retractor. Sandosh? Are you
Yeah.
focusing here?
How much of bone is?
But now don't focus the hand. Can you see?
How much of bone is outside the tibial tunnel?
That's why I want to show you. Just maybe a 5 mm. Can you see here?
Yeah, yeah.
Okay, yeah, we can see now.
Can you see that?
Yeah.
Yeah. So that's why I didn't want to put too much graft inside. Because I didn't take 3.5 or something. It's just a 3 centimeter graft. Some more flexion, please. Yes, same 30 degrees. Huh? Please keep it in the same position for some time. Always I again use these awls to see how much space is there. But even in general, like femur, here also mostly I use only 7 mm size. Unless the bone is very osteoporotic, 7 in 25 metal screw.
Do you always use metal?
Sorry?
You always use metal screws, or you?
Most often, all my revision ACLs also with metal screw only. Unless patient is very, bio screw, then I use a bio screw. The bio screw problem is like no, you have to do a reaming,
Tapping.
725 screw kudupa. Metal screw. Yes, 7 in 25. Say, kudung. It's okay. 30 also fine. So most often tibial side, you can use a 30 mm safely, no issues at all. And if you want to measure the tibial tunnel, you can measure the tibial tunnel. I didn't do a measure tibial tunnel because in the length of the patellar tendon in the tibial cell doesn't matter at all. Even if your whole of the bone plug comes out, you have still soft tissue graft inside, then use the bio screw. Or you can, that's why I told we can ream more on the femoral side, you can put the more bone inside. The only thing is the problem is when you use the screw, the femoral side, you should not touch the graft. That's why I kept that bone tendon junction at the entry point, so that your screw doesn't twist the graft. In the patellar side, that is the only problem. Hold it in the internal rotation. Enough. So you can see that my hand is pushing the tibia posteriorly, giving the slight posterior dryer, and gently I'm using the screw here. You can see that?
Yeah.
Oh, that is a nice fixation. Can you give the forceps, tooth forceps? Just to show the graft here, you can see the position of the graft.
Yeah.
You will check again, put a scope and see. Shave. That's okay. Probe again. Can you see the graph nicely now?
Yes.
The cosmetically is better? Mukesh?
Yes.
Because you are in the favor of cosmetic.
No, I was not in the favor. I was just asking your opinion.
Yeah. But you see the nice, you don't see this in the hamstring. You see how the tendon is broad. Probe again. Thank you. Can you see that?
Yeah.
So it's a nice tension. Do the extension now again, Ramakant. Can somebody open the water well? Yeah, that's fine. Go again. Do the extension. Do the extension. I think the tunicate is gone. Okay, that's fine. You can see that? You have good space. Enough. They are going hyperextension. Yeah. Okay, flexion. I think that's it. Any questions, Mukesh?
No, superly done.
Thank you very much. I thank Ramakant, your fellows, Piriti fellows, and anesthetists, and all the staff. Thank you very much.
Can you hear the applause?
Thank you, Santosh and Mukesh. Thank you very much.
Thank you.
Thank you. Close me.
Thank you, sir. Thank you, Santosh sir and Mukesh sir. I think we will get ready the tables for workshop on meniscal repairs.
Hello.
Sir?
Yeah. Santosh. Yeah. Can you demonstrate the meniscus repair technique so that we can save some time for the workshop?
Workshop, okay.
Yeah.
Okay.
Yeah. So you demonstrate one technique. Mukesh can demonstrate if he's there. So then you can leave. So we will come down and join. Yeah.
Okay.
Historically, meniscus tears have been difficult to repair. Meniscus surgery has often resulted in meniscectomy. The Nephew's NovoStitch Pro meniscal repair system passes suture from bottom to top.
Yep. Till we set up the tables for the demo, I mean, there's this video of outside-in repair technique. That's the graphic representation. This is usually meant for lateral meniscus and medial meniscus anterior horn, where the sutures are passed from outside to the inside. This is a meniscus mender, where a couple of needles, which is like a spinal needle, comes inside, goes through the tear. The first needle is posterior and the second needle is slightly anterior. The snare of the first needle goes in, is the one first deployed, and the second needle, which is anterior, takes the thread inside. And the snare catches hold of the thread and it pulls it out. And when you pull out, to make sure the snare is not too tight, it might cut the thread. So both the threads are pulled out and sutures are placed probably through the portal or through additional sutures. That's how an outside-in meniscus repair is done with the aid of menders. This can still be done with spinal needles and threads. And only thing you might, instead of the snare, you might need to use an ethylene or any monofilament to retrieve the threads.
they are arranging meniscal pugs and all inside device. The time they will just discuss the video how it works. Run the video. Now that's an outside in one. Can we go to inside out? Have other video? No, that's an outside in. This one, yeah. First, all inside. Yeah. Just stop over there. Stop. The first initial. Go behind. Yeah, stop over there. So this fast fix 360 device comes with various angles, reverse curve, straight and curved one. And you have a half pipe with it, which is a very important instrument whenever you are doing all inside meniscus repair. The down one is the half pipe, which you have to put through the portal so that you avoid entering into the patella fat pad. Otherwise the device will get entangled in the fat pad. And you have that special instrument to cut the threads. So half pipe cuts and it comes with straight, reverse curve and curve angles. Please go ahead. It's usually done in the posterior third repair where you have to manage the posterior third. So first step, just stop. The first step is to use a calibrated probe to see the length of the tear from the capsular area, so that you can accordingly manage the depth of the device, how much it should penetrate. You have to be very careful whenever you are using this all inside device in the posterior third of lateral meniscus, because the neurovascular structures are very, very close. So by general rule, on medial side you can go up to 18 mm depth, but on the lateral side you go up to 14 to 16 millimeter. And if you are very close in the center, if you are repairing posterior horn lateral meniscus nearly in the center, see that the depth is hardly 14 millimeters and the curve going away from the center. If you go towards the center, you will hit the popliteal vessels. So be careful about it. Please go ahead. So once you calibrate, you know that's almost 16 mm. So you mark that up to 16 mm on your fast fix device, so that the needle will penetrate only 16 millimeter, 14 to 16 millimeter, whatever the depth is you have calibrated. Then use your half pipe through the portal and towards the meniscus. It can sometimes be helpful to keep the meniscus in the reduced position as well. Just a gentle push on the meniscus, it will help you to keep the meniscus in reduced position. And please stop. This important point, whenever you are entering, the tip of the needle should be pointing towards the half pipe, not away from the half pipe. If it's away, you will again entangle into the retropatellar fat pad. So the needle should be going, scuffing the half pipe or touching the half pipe. Please go ahead. So this needle should be towards the half pipe. So once you reach, ask your assistant to remove the half pipe. And then first bite is taken through the meniscus and the capsule. And once you feel the, please stop. Once you feel the give way in the capsule, then only you deploy your first anchor. With a click sound it comes. So once you deploy, the anchor becomes vertical there, posterior to the capsule. And then very slowly and gently with the half rotatory movements come out of the capsule as well as the meniscus. Don't use much force, otherwise you will come out of the portal and then it becomes very tough. So you have to be very, very gentle while coming out, very subtle movements of the wrist, and you come out only up to the meniscus, not in the joint also. Please go ahead. And slowly withdraw and then decide which configuration you want, whether you want horizontal or you want vertical. But here you need a vertical stitch. Again the same thing, pierce the meniscus, pierce the capsule, you will feel the give way. Then deploy the anchor and then gently pull, twist up. So what here you do, I use a probe through the portal and keep the meniscus reduced and ask my assistant to pull it, so that the meniscus is well reduced and there is no much pressure on the meniscal when you are pulling the thread. Please go ahead. And then you pull and the meniscus is repaired very well, stitched well. And then you use this cutter which is provided by the company, so that there is very minimum foreign material outside touching the cartilage. And with this you can even tighten the knot and reduce the meniscus and cut so that you have a very small fiber thread, because they are strong enough to damage the cartilage as well. So you can take vertical stitch, you can take horizontal, and whenever you take two vertical stitch, there is a chances of meniscus to flip. So one stitch should go in the inferior capsule and in the meniscus so that you can avoid the flip. Yeah, it's a good one for the beginners, but it's difficult to do in the posterior third. So outside in can be managed in mid third and the anterior third very well. You can use this specialized meniscal mender, or you can use a 18 number spinal needle as well with number 1 ethylene loop and the 2-0 fiber wire. Here also you have to decide what configuration you have to take. If you are planning to take horizontal configuration, you have to come from the meniscus, medial or lateral end of the meniscus through the substance. If you are planning to take a vertical stitch, the first one will come through the capsule and the second one will come through the substance of the meniscus, so that you form a horizontal stitch. And that gives more compression at the tear site. So this is a horizontal type of repair. If you are using for medial side, generally we don't take safety incision, but whenever you are planning to do anything on lateral side, safety incision is must to prevent injury to the common peroneal. So the demonstration is ready. Super.
I think so, all delegates can have tea. Meanwhile, they can arrange the meniscus stations. Oh, stations arranged here also. Okay, then yeah. Okay, I think so. We can continue with the workshop. Yeah. No, somebody suggested. You can come in. Yeah.
this is the NovoStitch Pro device. The NovoStitch Pro device is unique because it is one device that can help you repair any type of tear configuration. So the common tear configurations that you need to repair are your peripheral longitudinal tear, you have a radial tear, you have a root tear, and you have a horizontal cleavage tear. So this NovoStitch Pro will allow you to repair all the tear configurations with just one device. The NovoStitch Pro consists of the following parts. You have the you want to, and it has a black handle which essentially deploys the suture. It has an orange handle which will close the upper jaw, and it has this grey handle which will deploy and retract the lower jaw. So what you see here is that it comes with a couple of cartridges. There's a green and there's a blue. Blue cartridge is there? Blue cartridge. So the green is 0, the blue is 20. The green is useful for the root, and the blue is useful. Light put the light power. Okay. And the green is useful, and the blue is useful for the rest of the meniscus. So normally when you get it, you will get the handpiece with a cartridge, and these other cartridges, they come as disposables, so you can use the same gun with different cartridges. So we'll start with the green device first. Everything is gone. No, okay, I'm fine, yeah. It doesn't matter. So how are you going to use this? Let's say we want to repair this root which is there, and I'm using this green one. The first thing that you want to do is to ensure that the lower jaw is retracted, is inside. I will press the orange handle so that the upper jaw comes in line, and then insert it through my portal and go inside. Once it goes inside, once you leave it, the upper jaw will flip up. This upper jaw is very flexible, and it will protect your femoral condyle from any form of injury. Then deploy the lower jaw with one click, and now you are ready to go ahead, bite the meniscus and deploy the suture. You see this laser mark which is here. This laser mark will give you an idea as to where the needle is going to come out. So let us say I'm going to repair this root. I go ahead, I squeeze, I grip it by pressing the orange front handle. I grip the meniscus, and with the back of my palm I'm going to fire my needle, and you will see that the needle will come out in the front here like that, correct? And it deflects away from the condyle so that it doesn't injure any cartilage, and it will not injure the capsule as well. Once you've deployed it, your first suture is ready. You can now shift your device to the second portion of your root without actually having to remove it. Deploy the second suture, and then you pull the whole thing out of the joint. So what do we have now? We have 4 sets of sutures that are coming out. I will go ahead, the lower one, which is the loop, that gets deployed free. Just hold this in your finger, please. And now I have the upper one, which then top part just freeze out. So what you have here now is a loop and these 2 sutures, and that you want to this. No, check, yeah. This will give you a cinch loop type of a configuration, which you can then retrieve through the tunnel that you've made in the meniscus and then reattach the meniscus back to the bone. So this is how you'll use your number 0. Now you've used this, and now this gentleman also has, say, got a bucket handle tear or a peripheral non-clinical tear. All that I need to do is to just throw away this cartridge. I don't need to use a new gun. And then I'm going to open just a 2.0 cartridge. Take it out. You will see and observe that it is written 2.0 and there is a black laser mark. There's another black laser mark which corresponds. Hold both of them together and pull back. Okay? Once it locks, retract the lower jaw and you're ready to go with your next suture. Right? So now this is, I'm going to use a 2.0 suture. Let's demonstrate how you'll do a side-to-side repair for a radial tear, which is probably the most important indication of this Novo stitch. Otherwise, when you're doing radial tear repairs, you're passing inside out sutures and it becomes very messy that start exiting. So if there's a radial tear, again I'm going to select the portal. While going in through the portal, depress down the upper jaw, go inside, open up the upper jaw, deploy the lower jaw, grab the meniscus to the desired depth, first suture, bring out, second suture, grab it, and then bring both of them out. As I just hold the meniscus, please. Yeah. As I bring it out, you'll find that the loop stays inside. And now, these are the two limbs of my meniscus sutures which have been passed out of the meniscus. And use any sliding locking knot, sliding locking or a sliding non-locking knot, whatever you are comfortable using. You can use an SMC knot, a Duncan loop, a Nicky's knot, whatever it is. Knot pusher. And then when you pull on the loop, your knot will cinch down firmly in this particular fashion. You do get a tool which is called as a sliding knot cutter. There are two buttons, a load and a cut. So when you shift the load, the mouth of this will open up. Put it on load, close the mouth, the suture will get entrapped like your shoulder. Sit the knot where you want it to sit, and then you can tie 2 half hitches on top of the same in this fashion, just like how you do if you're doing, say, labral repair or rotator cuff repair. This finishes your side-to-side repair. Again, use the same device, put it on load, the mouth opens up, you can load both the sutures in, give adequate traction, seat it, cut it, and this is your side-to-side repair. The next type of repair is for what you use for a bucket handle tear, one more, or a horizontal cleavage tear. So in a horizontal cleavage tear, if you're using a fast fix, then you, what do you have? 0, give a 0, doesn't matter. If you're doing a horizontal cleavage repair or a bucket handle repair, bucket handle is similar to what we did for a radial, but instead of doing side to side, we'll do front to back. So we'll pass one suture at the, at the peripheral end and one through the middle portion. So again, align these two sutures, align these two black marks on one another in this fashion, push it back, it loads, ready to go. If I'm doing, say, a horizontal cleavage repair, I want to get a circumferential compression suture. So in a horizontal, the tear is going through and through, and you want to close down the mouth. So again, same way, appropriate portal, press down on the orange handle, pass it through, go inside, open it, deploy the lower jaw, grab the meniscus, single bite now because it is a horizontal cleavage tear, pull it out, meniscus, it will otherwise come out. Single bite through the meniscus, and again go ahead, tie tie a simple sliding knot, just like what you did demonstrate previously. Go ahead, cinch it down, make sure that the knot goes away from the articular cartilage. You can either bury it on the under surface like this, or you can have it go away towards the periphery. Couple of simple half hitches, and then once you've done that, load both the threads and cut. So this is how you can use a NovoStitch Pro. You can use it for a variety of combinations. You can use it for the root, you can use it for the meniscus, you can use it almost in all patterns. So this becomes a very versatile technique of you being able to repair the meniscus. Just like that. So root, radial, horizontal cleavage. If you want to do a peripheral ankle, then you will take one bite here, second bite there, and then tie the knot. So again, for a bucket, you can use this very easily. Okay, so this is NovoStitch Pro. And now, come here.
Fast fix is a technique for all inside suture repair, the meniscal repair. So as we told earlier, it needs, initially you need to measure how much the width of the meniscus is. Anterior-most portion, it can be easily repaired by outside in, because needles can come from anterior to this much portion. In the middle third, you can do inside out. You can use inside out needles to repair that. But the posterior most portion, mostly we use only all inside technique, because it is very difficult to enter from an outside in or inside out position. So the most efficient device for it is fast fix. Okay, so it has got two anchors, as we told. You can see inside there are small peak loaded anchors inside. You can see one plastic thing there. No? It is attached to the fiber wire. So what is there is there are two anchor devices which is attached to a suture thread, and it is connected with just like a knot that we put, sir has put it right now, a sliding knot. So actually it is only two small peak devices which has attachment with a fiber wire which has got an inbuilt this sliding knot. Okay, it could be any knot. So what we are doing is that we are putting this anchors outside to the capsule, that is just outside the meniscus, and we are deploying it, and that will hold there. And after you put the two anchors, we'll just pull that thread so that this sliding knot will get locked and the meniscus will get repaired. So initially for that, first we should measure what is the distance from here to here. That is, we need this much to deploy outside, and this should deploy outside the meniscus, right? So we should measure with a device, a measuring device. Okay, just a probe is enough. Yeah, okay, no problem. That is, initially we are seeing from this portal, anterolateral portal, and this is medial one. Then we are going and just measuring it. Okay, say it is some 14. That will be a measuring probe. That has got markings. So it will be ideally some 14 to 16. That in Indian population it is approximately 14 to 16. So what you are doing is that we are setting that length. That is from the tip to this wide sleeve tip. We are setting that length to 14 to 16. So if you push it, this white portion will go only there. Okay, so you can set it here. You can see that. You show it here. The measurement is there. You can just adjust it. You can press it and adjust it like this. It will move. Now it has come small. And again it's moving down. So you can just set it at that point, and the cannula, what a cannula? Half tube. Half tube is also coming. Actually, the most important thing is that it's very costly. It will cost around some 18 to 20,000 rupees. But this is one of the best devices for all. So if you enter this portion in the fat pad or anywhere, that is gone. Then you can't use it, because at least if one anchor is deployed accidentally, this is gone. Then it is no use anymore. We'll have to take it over and take another piece and put it. So the most important thing is that that properly debride the fat pad region where you are putting it. Second is that you put a cannula. That cannula is there. It will come right now.
L-shaped cannula.
L-shaped cannula is there. So the cannula should be introduced, and through the cannula, you should graze the cannula like this and go. It shouldn't go like this. It should go above. There is high chance that it will get entangled in the fat pattern anywhere. So this portion, sharp portion, should be hitting the cannula. You put the cannula inside, and like this, grazing the cannula only, it should go. The cannula has not come yet, so that is why I am not able to show it. Like this. This is like similar thing like cannula. It should go like this. Okay. It should go like this, and it should enter this portion, and then you can remove the cannula. Okay. Once you see this much portion, it should be a constant field till the end of the procedure. You shouldn't give it to anyone else, because you should see this end till the end of the procedure. Okay. So this is a cannula. This is a cannula. You put it in there. You see the meniscus. You should this is a tear. You should just visualize the tip where the tear is. Okay. And through this you can just introduce like this. And once you reach there, you can remove the cannula. Okay. It shouldn't go like this. That is the point. It shouldn't go like this. Okay. If it goes like this, it will hit here and everything will come out from that. So it should go like this, and once it reaches there, you can remove it. And with an accessory portal, you can keep a probe here to keep the meniscus stable. Otherwise, it will move on. It is a torn meniscus, right? And through the scope, you are visualizing it, and you are, yeah, if it is a horizontal tear like this, you put one above, one below. According to the pattern of the tear, you can put the stitches wherever you want. So you are penetrating it. Okay. So this goes out. Okay. Till here only it goes. And then you press it. Okay. That one is, see this is deployed. This is anchor that is deployed. See that. This one is deployed here. The small anchor thing. Okay. Then you remove it. And while you remove, don't use your full power. Your scope should be seeing here. You shouldn't remove it hastily. Okay. You should slowly. You should use only 90-degree turns, pronation, supination movements in your elbow. Slowly. You can take 1 minute. It doesn't matter. Okay. You slowly remove it. And this is the most important step in which you will miss the second anchor. Okay. And then you should put penetrate it. If it is a tear is like this, if the tear is horizontal here, I put above and I should go below the tear. Okay. Below the tear again, I am pressing it. Now what happened? This has got engaged, right? This anchor has got engaged there. Outside. In the outside peripheral capsular region, it has got engaged. Now you are putting the second anchor. Okay. Second anchor also you are penetrating. And then you are pressing it. See that. Now the second anchor is released. Now after you release the second anchor, you will hear the click sound and you will feel that one thing is gone out. Okay. You again slowly take it out. You can just put it out, and this is a single suture fiber wire, and just pull it. Okay, when you pull it, the knot, see that knot is getting engaged. That knot has got engaged. Now see, this is one, this is a two. These two are deployed there. This has got some problem here, otherwise. So once it is engaged, this loop shouldn't be there. This should have also gone there. This could also happen. See, this one anchor got deployed here outside. It came out when I put it, right? So this can happen drop also. So be careful, because this time what happened is that it went underneath. Didn't penetrate this. This was like this. It didn't penetrate here. So that is why this was deployed. So otherwise it would have been a normal sliding knot. Okay. After that you can put the normal this thing, cutter. Okay, so it's an older variant. Other one is a newer one. Okay, so just it's a knot pusher. You can just put it and seat it there, and you can just cut it at the periphery. Okay. Okay, so I think that is it. This one is a inside out. And a needle it's an inside out technique. These are cannulas which have different areas of, here you can, the middle zone. Okay, mostly outside in that is a meniscal mender. This is a middle zone you can do. Okay, if it is a longitudinal tear, you can put sutures like this. The same thing you can, horizontal tear, you can use it like this. Okay, if the tear is like this, the suture will go down and come like this. Okay, where is the needle? This is a meniscal full set. Full set. Needle. Okay, so these are the needles used for the inside out technique. Okay, so this cannula you put it there. See, these are the different types of cannulas. Okay, for the different positions in the meniscus. Okay, so yeah, in this you can see. If you want to put it like this, na, the horizontal one. For horizontal tear, you can put one up, one down. This is a vertical one. For a longitudinal one, you can put that. However, all these you can use in the middle zone and almost in this portion. Okay, this much portion is covered by the inside out. The anterior portion is by the outside in. So how will you do it? So I think there are two needles. Okay, there are actually two different things. That is, one has the same needle. There are two needles with the same single thread in it. That is another device. Okay, that will be more easier, because once you pass one, another one also you can pass. Then everything will go simultaneously. I will show you. So this is a horizontal. Imagine there is a horizontal tear here. Okay, you are putting this thing here. Okay, it should come like this. So I am putting this needle. I'm putting this needle here and pressing it out. Okay. Now what will happen? It will come outside through the capsule. So before pushing that, ideally when it comes through the capsule, the main point is that all these inside out or outside in should be tied on the capsule. There shouldn't be any tissue in between the meniscus. The soft tissue shouldn't come in between. Then only the repair will be proper. So this thing should be over the capsule. The knot should be over the capsule. So if it is a bucket handle tear, we might be able, need to put more sutures. Okay, that is 1, 2, 3 or 4 inside out sutures might need to put. What happens is that the sutures, the tear is extending, and you know that you are putting the first suture here. Okay, you know that all the other sutures will come posterior to it. So when needle comes outside, you can just make it on the needle, okay, and see where it's coming. After that, you put a small incision, a horizontal incision along the portion the other needles will be coming. Okay, then you can see the capsule properly. What will happen now? Once if you pull out this entire needle out, then the suture will be coming. When the suture is coming, if you put an incision there, the suture, high chance of suture cutting is there. Now if you put only the needle has come out, and you pull it out. I'll show you. Okay. Okay, now this needle has come out. Okay, you don't change the position of this. Okay, and a needle then. Okay. Now we'll hold it with a heart ray or something. Ideally, this thing has got 2 needles. That will be easier. Now you have put the needle. You are putting the needle on the opposite hole. Okay. Now this is coming. So the both of the limbs are coming on the upper part and lower part of the tear. Now both these needles have come with these sutures. Okay. Now this is sitting there, right? It is between the tear. Similarly, you can tie a sliding knot because it will slide. You can put a normal sliding knot like that we put in a shoulder, and we can just put it in. Make the knot sit properly. See that? Now that has gone and sit there. Okay. So it is on the capsule. So what I told is that if there is a big longitudinal tear, like a bucket handle tear, you will need to put sutures, say from here to here. Okay. So first you reduce the meniscus. You try to put a reduction suture. You put it there, and you start passing an inside-out suture. Okay. First you pass it. You take it down, and you pass a needle here. Okay. Now you know that needle is the most posterior most stitch in that meniscus, right? So from that needle itself, you just put a anterior one incision you put horizontally, and just clear it up to the capsule. Okay. And just retract it. And then all the other needles will come only through that hole, through that incision. So the capsule will be clearly seen, and all this outside in sutures will come through the same incision. And then inside out is not a problem because you are seeing outside and you can suture it. There is no need for that. And the remaining one you can do all inside, like fast fix. In the
LCL, MCL and all will be there, sir.
Yeah, I am telling about the medial meniscus. Okay, medial meniscus I am telling. Lateral meniscus always you should put a safety incision. Safety incision should come like this, and you should put a spoon or something like that behind so that all the needles will come out. Lateral meniscus always you should put a safety incision. That is better. But the medial incision, medial meniscus we can escape without a big safety incision. So because most of the things will be posteriorly, we can put 2 fast fix here. Here 3 or 4 inside out, and here 1 outside in. So all together in a bucket handle tear I am telling.
I'm asking outside the capsule there will be MCL.
Yeah, outside the capsule there will be MCL.
When the knot we are tying, it will not compress the MCL also.
No, MCL, the deep MCL is actually here. Deep MCL is between the this meniscus and tibia and all it is there. It will be stuck on the deep MCL only. Superficial MCL will go like a band only. It will be a separate structure. It won't get stuck to it. It will be a separate structure like a band from the 6 cm below the tibia. There will be no need to retract it because you won't properly see that. It will be like a structure only, shiny structure. Don't get stuck to it because it has small knots. They go inside that. They go inside the superficial MCL. They go to the deep MCL and capsule and it goes and stuck there. Yeah, try hands-on. Fast fix you try someone. These things, these things have got a single.
This is actually having eyelet.
This eyelet is there. It's very difficult actually. The one which has got 2 needles are there. It is connected with one fiber wire. The singly you can pass it both, and then you can pull it again. So it is simple.
Understood. But the earlier one, what happened actually?
They don't have it right now. It
comes with 2 thread connected to needle. Once you use it, then you have to throw it. You have to use this. It comes with eyelet.
but it is difficult. The other one is simpler.